important. And so we have to emphasize this as professionals to the medical professional team so that they understand that nutrition assessment is very critical and it is not any other person's duty. It's the duty of a nutritionist. Now, we want to look at another aspect, which is very important, reasons why healthcare providers assess nutritional status. Why do we assess nutritional status? As a provider, we assess nutritional status for many reasons. One, we want to identify people at risk of malnutrition for early intervention or referral before they become malnourished. Number two, we want to identify malnourished clients for treatment. Malnourished people who are not treated early have longer hospital days. We cannot start treatment before we assess to recover the status of nutrition. Treatment becomes effective after that. Again, we are talking about slower recovery from infection and even complication and higher morbidity and mortality. That is why we must assess before treatment is offered. Also, why do we assess? To track child growth, because nutrition in the life cycle, the bigger focus is normally on children under 5. So that's isolated as a very important area for assessment. We must assess to identify medical complication that affects the body's ability to digest food and utilize nutrients. If we don't assess a patient early, we are not sure of the gut system. We are not sure of the utilization of nutrients. So we must get this assessment early. And that is where the biochemical and clinical assessment comes in. Why do we assess? To detect practices that can increase the risk of malnutrition and infection. You may do well with assessment. However, if we do not look at other things surrounding the person in terms of social well-being, the social environment, and even the factors that determine their economic empowerment, our assessment will be in vain. Why do we assess? To inform nutrition education and counseling. So after assessment, you can take clients or patient through a counseling process. Now, the final is to establish appropriate nutrition care plan. So these are the reasons why we must assess clients and patients before any medical attention. This ranges from the curative ones to even mental health. So we must conduct assessment at all costs. We should note that the results of a client's nutritional assessment and the classification of nutritional status determine all other elements of nutrition assessment, counseling, and support for such an individual, including counseling, treatment, and referral to food security and other support. That is why assessment becomes a pillar and a serious tool and an area of practice for a nutritionist or dietitian. But then sometimes we have used certain terms like screening. So we also need to differentiate between assessment, which is the ABCD approach, and now includes even the food security or nutrition security assessment, to see what screening means. When we talk of screening, a full assessment can be preceded by rapid. These are quick and rapid and simple identification of people who may be malnourished or at risk of malnutrition and need a more detailed assessment. So you screen so that you can look at those you can subject to further higher level assessment. Nutritionists and dietitians are trained facility-based healthcare providers or community service providers. And they can do screening in the healthcare facilities. during growth monitoring and home-based care and during support groups. And I think when it comes to the time for making resolutions for policy on matters of primary healthcare, will be very critical, because we know that as at now, there are certain people that are doing this exercise that are not trained properly. If you look at the community health promoters, for example, and you look at those who are operating at level 1, level 2, 3, you might find that those who engage in this kind of assessment, screening, are basically not trained nutritionists. So then this would justify why we need nutritionists in every level of service delivery when it comes to healthcare. Simple nutrition screening can include checking for bilateral pitting edema, for example, measuring weight and mid-upper arm circumference, and asking about recent illnesses and appetite. Now, many people think that this one can be done by anybody. And that is why when the task sharing policy was brought on board, there was a lot of debate on whether we can whether we can release this aspect to even a nurse. The answer is no, because this nurse has not gone to a deeper depth of nutrition study. So we have to fight as nutritionists that we remain with this aspect of assessment purely, and the nurses can only work in collaboration with the nutritionist on this matter. We are not saying nurses cannot do it. Where we do not have nurses, they can, but then they have to be empowered again on this area of assessment. Now, screening requires standardized training in line with the national and local health policy. We also know special training materials may be needed for low literacy and illiterate population. Now, a community health promoter that did not go into any class of medical care, they are illiterate, and therefore they can be trained. They have to be trained also. And if they are trained is when they can offer the service. Otherwise, our Nutritionist Act bar them from offering such services. Community service providers need government-approved recording and referral materials and clear guidance on provider roles, whom to screen and how often. Now, the question is whether we have this properly defined in the policy at the national level or at the county level. If it is, then we must emphasize that such materials or policies are used. They may also need incentives to do accurate and consistent nutrition screening and make referral. So this is an area that probably could be transferred to those who are supporting nutrition agenda at the county, including health promoters, but must be backed up by proper training. So this is my second last slide. If healthcare providers can't assess every client's nutritional status, what clients should pay attention to as a priority include the following. We are saying children under 2 years of age, especially if they are not breastfed, we know that this is the time that we have, you can either make a child a full or a high class or a first class child in terms of thinking, mental development, and brain. So that is very critical. It's a priority, and we must do it as a nutritionist. Women who are expectant or pregnant and up to 6 months of postpartum, very important age group also, because they determine life of the future for a child. And so if you don't take good care of them, that is a disaster. On the other hand, if they die, you terminate lives, not life. If a man dies, there's no life terminated because we have many other men. But if a woman dies, we terminate lives. So that is very important as a priority. People who report unintentional weight loss, very important. If they drastically lose weight, you must prioritize the assessment. People who have been prescribed specialized food products, They have been prescribed with specialized food products to treat malnutrition, like those on ready-to-use therapeutic feeds and any other. They need to be assessed because you have to monitor how that food performs. People with disease-related symptoms that can be managed through diet, like the NCDs. And finally, we know of infectious diseases like HIV, tuberculosis, and other, like pneumonia and the rest. Those ones must be assessed. How often should nutrition assessment be done? The frequency of nutrition assessment depend on the client, the age, pregnancy, disease status, and national policies. Now we are beginning to think of, are we having adequate national policies? If they are there, have we educated people enough to use them? We will be thinking about that also in the process or in the course of these conferences and the rest. Now, the recommendation below should be adjusted based on nutritional guidelines, and it can vary from time to time. However, when we talk of pregnant, on every antenatal visit, they must be assessed. When it comes to infants, 0 to less than 6, that is 59, less than 6 months of age, at birth and on every schedule for postnatal visit. When it comes to infants 6 to 59 months of age, then during monthly growth, they have to be assessed. That is growth monitoring sessions for children under 2 years, or every 3 months for older children. I hope we are together there. Then children 5 years of age or over. There's a group we have forgotten many times, the adolescent and the adults. We think that they have no problems. However, we need to do assessment every time they visit a clinic, which means that anybody who pays a visit to a health facility is a nutrition case, justifying that we must have nutritionists also to take charge of such cases. And you can imagine how many visit clinics. The emphasis is that on every visit, anybody who enters the gate must be assessed. Then we have people with HIV, TB, and others. On every visit, they have to be assessed. This tells us the frequency of nutrition assessment. And so nutrition assessment then becomes a very, very important exercise for a nutritionist. And I want to encourage you to pay attention to the basics. We are not going into details of the higher level assessment, but what you can use as a professional to change lives for humanity. Thank you very much. And I want to take this time to invite our next presenter, basically Madam Banis, for the anthropometric, and I hope that she's on. She has been allowed to speak. So, Madam Banis, the floor and the air is yours. We want you to also tell us what we need to do when it comes to anthropometry on this exercise. Thank you very much.
Okay. Thank you, Daktari. I hope you can hear me. Can you hear me?
Yes, we can hear you. We can hear you.
You can, right? Yeah. Great. So my name is Banis Kendi. I'm a clinical nutrition therapist. That's what I call myself, a total wellness consultant. And I'm a founder of Neo Nutrition Solutions Limited. We've been in the practice for the past 11 years. I think this is the 11th year, and doing nutrition in private practice. I'm so excited to be here at this moment. And without further much ado, let me just go direct to the training, which is the nutrition assessment. So one thing I'll start by saying is that measurement is always the first step that leads to control and eventually to improvement. If you can't measure something, you cannot understand it. If you can't understand it, you can't control it. If you can't control it, you can't improve it. These are words that were said by James Harrington. I find them to be very resourceful words, because anything you cannot measure, you cannot control. Even when you're doing, let's say you're using nutrition anthropometry to come up with your meal plan, nutrition assessment to come up with a meal plan, it is always good to ensure that you understand that your client also need to understand that anything they cannot measure, they cannot control. So first, thank you, Daktari, for the introduction. And that introduction is also going to help us. I'll be going back to what he said, because it's also part of nutrition anthropometry. And I'll not define nutrition assessment, as we already are aware, but anthropometric refers to the measurement of a human individual. It's an early tool of physical anthropology used for identification for the purpose of understanding human physical variations. That is I would say, it's the best way to define anthropometry. And just talking about anthropometry, it is good also to understand quickly why anthropometry: to track a child's growth, to identify malnourished clients for treatment, to identify people at risk of malnutrition for early intervention, to identify medical complications that affect the body's ability to digest food and utilize nutrients, to detect practices that can increase the risk of malnutrition and infection, to inform nutrition education and counseling, to establish appropriate nutrition care plan. Then nutrition screening, which Dr. said is a process used to quickly identify a patient's nutritional status and identify those at risk of malnutrition or those who are malnourished and require more detailed nutrition assessment. So I'll just go direct to explain the detailed nutrition anthropometries. So we have taking weight, we have mark, we also have things like height, we have head circumference, we have skin fold, we have body impedance analysis, and BMI and weight for height are anthropometric measurement presented as indices. Each of these indices is recorded as z-scores. So z-scores are measured as standard deviation, which we use to abbreviate as SD, describing how far and in what direction an individual anthropometric measurement deviates from the measurement. So for a healthy person of the same age and sex, which is called the median. So the further a measurement is from the median, the greater the risk of malnutrition. So when you look at weight, weighing is usually the first step in anthropometric assessment, and the
Madam Benis,
prerequisites.
can you kindly share the screen, Madam Benis? The professionals are asking. Oh,
I'm not
yes.
able to share the screen, but I've shared it with Kinya. If she can, I think she can follow through and help me share.
Kenya, can you put up the screen for the professionals, please? Madam Banis, you can hold on just a bit so that we can do that for you.
No problem.
Yeah. Okay, so we are just loading Bunny's presentation. So you will give us about 5 minutes to do that. We are sorry for that from my end. Meanwhile, we have put for you that background instrumentals you can enjoy. Thank you.
Madam Bandis.
Yes.
Yeah, your screen is on.
Okay, great. So you can hear me, right?
Yes, we can hear you.
Okay, so somebody can help me to go to the next slide, which is nutrition assessment. Yeah, continue. 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 Next. 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 Okay, now that's where we are. So I was explaining weight, whereby I said weighing is usually the first step in anthropometric assessment and prerequisites for finding weight for height z-scores, which is abbreviated as WHZ. For children and BMI for adults, weight is strongly correlated with health status. Unintentional weight loss can mean poor health or reduced ability to fight infections. So weight measurement must be accurate, measured in kilograms to within the nearest 100 grams. So errors can lead to incorrect classification of nutritional status following the wrong treatment or care. So that means that we have to be very careful on how we do nutrition anthropometry, because any mistake will lead to wrong treatment or wrong care, especially if you're dealing with the sick client. And category 1, where we start on the weight in people's life, we talk about pregnancy weight. That is where life starts. And low pre-pregnancy weight and inadequate weight gain during pregnancy. Yes. Yes. Any issue?
Just go ahead, Madam Banis.
Okay. So low pre-pregnancy weight and inadequate weight gain during pregnancy are the most significant predators of intrauterine growth retardation and low birth weight. So to reduce the risk of adverse outcomes, women should enter pregnancy with a BMI which is a normal, in the normal category. And so we talk about the normal weight of 18.5 to 24.9. We say the highest somebody will go is 25. While pregnancy weight vary greatly among women, note BMI is not an accurate indicator of nutritional status during pregnancy. Make sure that you use MWAC during pregnancy. So category 2 is what we call the newborn. So birth weight is mainly used, which is not a measure of acute malnutrition. So infants with low birth weight, which is less than 2,500 grams, are at risk of physical and cognitive impairment and nutritional related chronic diseases in later life. So all infants lose weight immediately after birth, which is not a major issue unless it is 10% or more of the birth weight. So this weight should be gained 1 week after birth, and most double birth weight by the 5th month. So under 6 months, the anthropometric measurements used is weight for age, weight for length, and head circumference. So when we want to understand anthropometrics better, we have weight for length, which is used for measure of acute malnutrition along other clinical assessment that the rest trainers are coming to talk about it, because anthropometric cannot stand on its own when we want to identify client issues or probably malnutrition. And malnutrition, we talk about under and also over. So to measure under 6 months infants, use a beam scale or a digital uni scale that measures infant weight by weighing the mother and the infant together, then subtracting the weight of the other mother. I remember when we used to do this, especially during the internship or let's say attachment, there usually some kids who cry too much, and this would really work, whereby the mother and the kid will be weighed together, and then you can subtract the weight of the mother. So this one will really be a very important thing to do. So length and height, measuring length and height requires a board or measuring tape marked in centimeters. So measure length for children under 2 years of age or less than 87 centimeters long. Measure height for children 2 years and older who are more than 87 centimeters tall, all for adults as well. So weight for height, which we say WHZ, is an index that is used to assess the nutritional status of children from birth to 59 months of age. It compares a child's weight to the weight of a child of the same length, stroke height, and sex in the WHO child growth standards. Of course, these are standards that we've been using for quite some time, and this to classify the child's nutritional status. There are standard charts provided by WHO for both girls and boys, and I'm sure all of us can download that and have it in your phone, especially if you don't have the charts, or even you can print out and hang them in the in your practices, or probably where you are as a nutritionist. So this used to work immediately. When you're done, they can also beautify your office by ensuring that you're able to go back to the reference charts and you are able to check the correct details. Note the standardized monitoring and assessment of relief and transition SMART emergency nutrition assessment tools available from the NutriSurvey website. They are all available. They usually calculate WHZ automatically, and I find it's very interesting because before we used to either check the charts or you do it manually. SMART training package is also available online. So let's look at MWAC. The circumference of the left upper arm measured at the midpoint between the tip of the shoulder and the tip of the elbow using the tape. Make sure you practice a lot on this, because say there are some who put the mark incorrectly, and so we need to really learn how to do it correctly, because we said if you don't do the anthropometries better, you cannot be able to treat or even be able to identify any issue. So they are more accurate in millimeters than measuring in centimeters. So MWAC is a proxy measure of nutrient reserves in muscle and fat that are unaffected by pregnancy and independent of height. In pregnant wasted is less than in pregnancy. Wasted is less than 21 centimeters. Well nourished is above 21. That is if you're using MWAC measurements for pregnant mothers. Remember, we said BMI is not an accurate measure for pregnant women. So severe wasting is less than 115 millimeter. Moderate wasting is 115 to less than 125 millimeter. At risk is 125 to less than 135. Then we have well nourished above or greater than 135. So BMI indicator, it's based on weight to height ratio, calculated as weight over height squared in meters. And being a nutritionist employer, sometimes when we do interviews, it's when we need a nutritionist to come and work. I've realized that if you have 10 nutritionists coming for interview, and this is a challenge that I'm posing to you all, you find that 7 out of 10 do not know or even remember the cutoff points for BMI. So I'm posing this as a challenge because most of the clients that we have already know their BMI cutoff point. If you go to any interview and you do not know BMI, I think any nutritionist, you see, like there are those sins we say they're unforgivable. This should be part of our unforgivable sins, whereby if somebody doesn't know BMI, I don't think you're supposed to hire them because this is the best, the simplest of all assessment or anthropometry that we should have in our fingertips. So let me say from today, we can call it unforgivable sin in nutrition. So make sure that you know BMI cutoff points. When somebody wakes you up at night, you're able to say the BMI of a client when it is severe malnutrition, if it is moderate malnutrition, mild malnutrition, when somebody has a normal BMI. And also, let's also get to understand about, according to, now let me go to practice and anthropometry. BMI is not the only indicator that says that, like before we used to use the BMI and then we start calculating meal plan. And currently we say you take all other assessment and the rest of the things, the rest of the nutritional assessment that will be talked about today, the biochemicals and the rest. So there's a lot to nutrition than just the body mass index. But this BMI is very, very important because we need to know how we drink waters according to our BMI. We also supposed to understand that the more weight you have, the more you are at risk of a lifestyle disease. We also need to know that we also exercise as according to our BMI. So these are also some of the things that we need to be awake to. And yeah, again, another thing about obesity, understanding obesity and its management. Again, I'll say BMI for age Z-score can be used to measure the nutritional status of adults over 18 because they have completed their physical development. So it helps a lot. Sometimes some of the clients will go to gyms and or any other fitness centers they go, and you realize that there's a lot of confusion on the issue of BMI, and some will start saying, is there BMI for Africans? Let me say this, that every time somebody is overweight, I always tell my client the truth. In nutrition, we are like, we are almost like supporting, godly functions, because we must be a very honest person when you're a nutritionist, because there is no lying. You tell them this is, if you don't do this, this happens. And they are being lied to so much out here, according to the anthropometry they present in the gyms and the fitness centers. They are being lied to that there are other BMIs for Africans. Others will come with BMIs of 27 and 28. But so long as somebody's BMI is 25 and above, they always know, they felt when that overpassed, and they knew that they needed to do something. So when somebody does exercise without nutrition, then it's like they try to brush their ego, and also try to show them that nutrition is not as important, and nutrition is 80%, while exercise is 20%. And we need to know that without nutrition, nutrition, exercise alone will not even stand. And these things we need to be awake to, and also be aware of what is going on, and we try to bring our anthropometries at par. Now, let me talk on one thing that I know that most of us probably have either done, come across it or not. We have body impedance analysis as part of the anthropometry. As we mentioned, the mark, the weight for height, and the rest, we need also to understand the body impedance analysis. There are so many machines that are out here. Others are called fit scales. Others, you realize that the very cheap body composition analyzers, 10,000 going for 5,000. And what I've realized in the last 10 years of practice, when we bought the real body composition analyzer, which is we talk of in-body, there's DEXA, and also there is a Tanita version. Every time you do this, and then you compare with what clients come with in terms of if the clients have bought those cheap body composition analyzers that are online, they are totally different with the clinical scales. So this is something I think we need to look into, because clinical body composition analyzer is supposed to help you link also some of the tests from the lab. Now, let me say that when you take height and weight in the clinical body composition analyzer, you get the BMI. It's supposed to be the same across all digital BMI scales and the rest of the manual BMI scales. Then when you talk of total body fat, one thing I've realized about this anthropometry is that when you take body fat of a patient, body fat is the fat under the skin. So when you take body fat, you realize that body fat is linking with metabolic age. Everyone who has a higher body fat has a slow metabolism. Let's talk of if women have, they are supposed to have 16 to 30. More than 30, you realize that so long as you have 31, 32, 33, 34, already there are issues with metabolism that have started. And when metabolism is affected because your body fat is very high, then you realize that with that, you can be able to explain to our clients that because of excess body fat, there is a slow metabolism, which can lead you to digestive system complications. Because when it comes to nutrition, anthropometry, we are supposed to be able to identify, some of the diseases at an early age, and also at an early life, let me say that. And anytime metabolism is slow, if you're at risk of a digestive system complication, you realize that 90% of women, I will tell you for sure, that they will complain of either heartburn, constipation, flatulence, bloating of the stomach. They'll start, others already have gastritis. You've not asked about the medical history, but already with the body composition analyzer, you can be able to link metabolism with excess body fat complication. So when you're speaking to them, somebody, even the client will just stop you and they're like, I think this thing has really disturbed me for so long. I didn't know that this can cause it. Immediately you start a program, what happens is, let's say weight loss program to reduce the fat. As they improve, it takes even, others will take 1 month, others 3 months, others within 6 months of their weight loss program, they are able to have a zero digestive system complication. We've even treated clients with hernia who have not gone for surgeries, more than 10 clients with testimonies, great testimonies, not gone for surgery because they have lost weight. And that is why I'm here to say that it is very, very important to focus on a body impedance analysis, but make sure you do clinical version, because we can't be the kind of nutritionist that will buy the cheap scales online and we measure the clients and we know these are not clinical. These are just fitness scales, and everybody wants to do nutrition online, and they want to do it in the simplest way. They want to show people that whatever they are doing is what is correct. But we as nutritionists, we need to be able to explain to clients and not buy cheap scales and then they are not linking up with the lab. What do I mean by linking up with the lab? Every time you do visceral fat, so long as somebody has a visceral fat above 12, I will always ask them to go do lipid profile if somebody didn't come with their medical history. And let me say 97% of the clients who have visceral fat above 12, they already are having high cholesterol. And this is where now you're able to do proper management, because you know what to give as a nutritionist. If the cholesterol is not too high, you know that you can recommend omega-3s. I see them working so well. If it is higher than 15, if you give one morning, one evening, and then you also make sure you do proper nutrition and do the eliminations of let's say carbohydrates, because carbohydrates, of course, refined sugars are also a risk factor of very high cholesterol. And we need to look at this. Fat is majorly not it's not a major issue if we do it in the best way possible, and we advise clients on the portions and everything else. Now, again, on the anthropometry, just trying to show you the importance of anthropometry. Bone mass, when you do BIA and you check that bone mass is relative to weight. So according to somebody's weight, let me give an example. If somebody has a height of 178 centimeters and the weight is 78.1, then that person is a man. So if they have a bone mass of 2.4, according to their weight, that tells you that their bone mass is low, which is supposed to be from 3.29 and above. Now, anytime this is above, it is lower than the normal, then it means that this person is at risk of either low calcium or low vitamin D. So you can ask a client to go do calcium and vitamin D in the lab, so that you know whether we are dealing with now low calcium levels, we are dealing with low vitamin D, because when vitamin D is low, it also affects the calcium absorption. And also other things. Of course, when vitamin D is low, you are able to connect vitamin D with hormonal imbalances, because vitamin D regulates hormones in the system. So they bring hormonal balance. And so if it regulates hormone balance, then it is low, then you can be able to ask the client to do hormone testing in the lab. And so you realize that nutrition anthropometry, which are clinical, every time I ask a client who has a low bone mass to do their calcium and vitamin D, I will always, if they have complaints, I will always hear things like, I'm having issues with the joints, I'm having, issues with them, like muscle issues and stuff. And anytime somebody mentions muscle, as a clinical nutritionist, you are able to link that with magnesium. There are other issues, signs and symptoms a client will complain about, and they are in the session, and you will ask for zinc test. So according to the body impedance analysis, make sure that you get the clinical version. The first three are okay, and this is what will link with the lab, because most of the times, like you see, when you're in the market, you have to try so many things, and when you do the those as cheap scales, the ones that they have BMI, they don't have everything, but they have around 5 or 6. They will not give you correct readings. And we started by saying that if you don't do proper anthropometry, then you're not getting it right in the client care. Every month, if a client comes to you to repeat this anthropometric assessment, because they're supposed to be repeated on monthly basis as according to the severity of disease, then that means that if you're giving 2 weeks or let's say you're giving 3 weeks or even a month, make sure you repeat all this anthropometry to see whether your client is progressing. And this is what we call clinical weight loss, clinical weight gain. And you'll be shocked that if a client is disciplined, according to the anthropometry measurements, you realize that they keep on improving. They lose 2 to 3 kgs every single month. Those who are gaining, they will gain 2 to 3 kgs every single month, according to the kind of meal plan that you're going to give them. And so I believe in anthropometry, doing it right. And if you're working in hospitals, you have a consultancy that you've partnered with hospitals, make sure that from the triage, do what we call continuous medical education to nurses, let them know the importance of nutrition so that they can be able to take correct measurement. Because I remember partnering with some hospitals, and before we did the CMEs, they could just bring a client with only the weight, and they have not calculated the BMI, and you're a consultant, so you don't know where to start, because without the height, you cannot do body composition analysis. They must do the height from the triage, and they must do it correctly. If you miss it on the height, you miss it on everything else in terms of the BIA. If you miss the height, you also miss the BMI. So that tells you the importance of measuring correctly the height and the weight so that you can get the correct BMI, and you are able to link the BMI with their water, with their exercise, with the lifestyle disease. And of course, that factor, I also talk about the non-modifiable factor. There are people who have the normal BMI in the assessment that you'll do, but the same people will have diabetes or hypertension, because there is what we call genetic makeup, and you cannot, those things that are not modifiable, because somebody is either born with it or it is running in the family. So those are some of the people that you teach on management, and you can help them as much in terms of managing the condition as well, and getting their anthropometry right, so that you are able to get what they are suffering from. So in everything we are doing, let's make sure that we get correct anthropometry measurement. Now, another thing about calories, it's also important to understand somebody's age, so that you don't do a one-size-fits-all approach when it comes to meal plan. And let me pose this challenge to you all nutritionists, that we have non-nutritionists online that are doing a lot in terms of the wrong nutrition. I've said they are using the wrong scales, and also they are giving clients the wrong details. And we are here, we make sure that we call to those people. Let's call them and make sure that they stop doing the wrong things, because we don't want to confuse the profession with the wrong anthropometry, with the wrong explanation. And also, let's be at par with the current guidelines. I'm sure, and I know that KNDI website is really functional, and you can always check the nutritional guidelines online, and you can be able to download the clinical nutrition guideline, and you're able to know what is current and what you're supposed to follow in terms of guideline. So we need to respect our costs. We need to respect our clients, because if you don't respect the board functions, you don't have a license. You cannot be able to give anthropometry. I don't know whether you know, I remember doing a course on anthropometry, but I did it in UK for 6 months and got a certificate. You can even study more on anthropometry and become a specialist on that. And this means that you'll be able to identify client issues at an early age. You'll be able to detect everything at an early age. So as I finish, I'll say that there is also a disadvantages of anthropometry, of course, inter-observers error in measurement, limited nutritional diagnosis, problems with reference standards, e.g. local and international standards. And advantages of anthropometry will be it measures many variables of nutritional significance, objective with high specificity and sensitivity. Readings are numerical and gradable on standard growth charts. We also have readings are reproducible, non-expensive methods, and require minimal training. If you don't have a BIA, you can always start with the BMI and do the manual calculation and come up with a meal plan. You can use the clinical guidelines, the biochemical as well, and also dietary to come up with a client guideline. So it doesn't mean that if BIA is expensive, you cannot start, because I remember the first 3 to 4 years we started without a BIA. So measurement is fabulous, unless you are busy measuring what's easy to measure as opposed to what is important. These are words that are said by Seth Godin. And thank you so much. I think my time is up. I'll leave this to Dr. Okeyo. I'm also a published elder. You can get more on nutrition assessment and the explanation of BMI and BIA cutoff point in my book for those who want. If you came to this conference, I'll give you the book at 900 shillings from 1400. And I believe that it's going to help you, especially for those who want to start practice. It's a very good starting point as we wait for volume 2, which will be very good and difficult, a little bit difficult, but it's an extension of this book. So thank you, thank you, thank you. I wish you all the best as you continue learning about nutritional assessment. That's all I had for anthropometry. Back to you, Dr. Ree.
Thank you everyone. I think this time we will welcome Anastasia Karaoke for the next session.
Yes, hi everyone. Well, my name is Anastasia Karaoke. I'm a consultant in nutrition and dietetics. And I'm going to take you through the biochemical assessment method of nutrition assessment. So for the biochemical assessment, you find that this is another area that is quite challenging for our nutrition professionals because it deals more with pathophysiology and it's more of quite in-depth in terms of the chemistry involved in the analysis and interpretation of the tests that are done. So from my practice, I've noticed that many nutritionists who are working, they are not able to give or do not understand how to interpret biochemistry. And it is important that as a nutrition professional, you are a clinical part of the clinical team. You work with the doctors, you work with the clinical officers, you work with the nurses, and biochemical assessment is part of the day-to-day assessment of patients, especially those ones who are already in the clinical levels, like hospitals, clinics. And in the field, yes, those who are working in the field may not come across nutritional, the biochemical assessment more than those who are working in the hospital. But it's still a challenge when it comes to interpretation. So what are these biochemical assessments? So the biochemical assessment means checking levels of nutrients in a person's blood, urine, or stool. And compared with the other methods of nutritional assessment, biochemical tests provide the most objective and qualitative data on nutritional status. These tests often can detect nutrient deficits long before anthropometric measures are altered and clinical signs and symptoms appear. So, for example, you find that a low albumin result can guide you to start addressing the protein status of the patient before the onset of edema. So some of these tests are useful indicators of recent nutrient intake and can be used in conjunction with dietary methods to assess food and nutrient consumption. So if a patient comes and you test for glucose, maybe you are monitoring a diabetic patient and you test the glucose level, be it be random, probably random, you find it is high, you will be able to, the first question you'll ask, what have you eaten? How long have you taken since you ate that meal? So you are able to tell the kind of food they have eaten in terms of, you compare it with the glucose levels that you are seeing at that time. If it's a fasting blood glucose that is high, you want to know what did they eat yesterday's supper? What time did they eat their dinner? Yeah, so these tests are very important, and nutritionists have to be part of the care giving team with the knowledge of biochemistry on their fingertips. So some of these tests are useful indicators of recent nutrient intake, yes, and can be used in conjunction with dietary methods to assess food and nutrition consumption, especially than those who are doing research. Those who are doing research, they need to use biochemistry to get the true reflection of what the patients or the research participants have eaten. So we go into classification, and the biochemical tests can be grouped into two general categories. We have the static test and the functional test. The static tests are based on measurements of a nutrient or its metabolite in the blood, in the urine, or body tissue. For example, serum measurements of albumin, calcium, or vitamin A are static. These are among the most readily available tests, although they have their own limitations. Then we have the functional test of nutritional status, which are based on the idea that the final outcome of a nutrient deficiency and its biologic importance are not only a measured level in a tissue or blood, but the failure of one or more physiologic processes that rely on that nutrient for optimal performance. So functional tests, you've seen doctors ordering a liver function test, liver function test. So these functional tests and many others are very important even to the nutritionist, because when you're monitoring a patient, say you have a patient with hypothyroidism or hyperthyroidism, when you start your nutrition intervention, you are not just dealing with anthropometry. The patient has come with a metabolic disease. So you also need to be part of the team. You request for a thyroid test in the subsequent reviews to see whether the TSH hormone or the F3 or the F4 are going in accordance to normality. So this is very, very important, where a nutritionist become a doctor in their practice to follow up and interview the patient using all the other assessments. So I normally find the skewing of nutritional assessment to most practicing going more to anthropometry and dietary. When it comes to biochemistry, nutritionists are not sure whether they need to order, or they don't even know how to interpret when the patient comes with the result to their table. So we are going to look at laboratory tests that are common and the interpretation. Of course, this list is not exhaustive because we have many other tests, but because of time, we are going to look at the most common, and we start with glucose. So the metabolic tests, we are going to start with the metabolic tests that are normally common, and the first one is glucose. So glucose is the main, is the body's main source of energy and comes from carbohydrate, which is a macronutrient. So one of the most tested metabolic tests ever in this country and beyond is the glucose. And we find that the normal levels are 70 to 99 milligrams per deciliter. In Kenya, we normally use the millimoles per liter for most of our labs. But it's important to note that you need to know the levels based on the SI unit. And many patients coming from the US or from India, the international unit is milligram per deciliter. So if you are used to millimoles per liter, you need to know how to convert this so that you will understand whether it is high or it's low. So when the glucose is low, what does it mean if a glucose test is low? One of it is, one of the reasons is that the person may be hypoglycemic. The patient's blood sugar may be low, and may be low because of many factors. Either they have not been eating, or they're starving, or they have no appetite. There are many factors that could lead to hypoglycemia. They could also have a liver disease, or adrenal insufficiency, or excess insulin, especially those the type 1 diabetic patients who are insulin dependent. For the non-insulin dependent, we might, like type 2, they may be on insulin or not, but even those who are on insulin, you're finding that of late, the levels of the amount of insulin being given to patients is too high. When you start your dietary intervention, you find that they are reporting hypoglycemia in less than a week, and you at that point you know that your diet is working, and the challenge is you need now to start reducing insulin. So this is where we have a problem, because the endocrinologist or the diabetologist may have told the patient you have to be on these units every day. While they come to your desk, start the nutrition intervention, start weight loss management, the interventions kicked up, and it's good now you call the doctor who is giving the insulin, so that you have the same understanding, so that you become one team. I know for those who are working in diabetic clinics, we have a team of the endocrinologist or diabetologist or the diabetic specialist, and the nutritionist. But I normally find that that conversation is not there, where the nutritionist is questioning the insulin level is too high. You may find that the patient is eating excess when they have hypo, yet they should be reducing the insulin instead. So for the high number, if the glucose level test is high, of course, that means there is hyperglycemia. Hyperglycemia is when the patient is either eating more than necessary food is too much, or we have certain types of diabetes, or in the pre-diabetes phase, pancreatitis, where the beta cells which produce insulin have been inflamed, or hyperthyroidism. So with these conditions, glucose, apart from diabetes, we have other conditions that can cause glucose to be high. We've seen even cases where acute infection, malaria or TB, during the acute phase, the sugar go up. This may not necessarily mean that they are diabetic, but it's because of the acute response to the infection or inflammation. And in this case, you're working as a team. Once antibiotics or anti-malaria are started, the sugars will respond positively and start going down. So it's good to monitor the patient and know the biochemistry part of glucose, when it goes up, when it moves down, so that you can be in the clinical phase of the patient and address it the right way. So for the blood urea and nitrogen, BUN, this is very common and has been associated mostly with kidney patients. However, we find that not always that the BUN is high because of kidney problems. So the BUN measures the amount of urea nitrogen in the blood, and urea nitrogen is a waste product that your kidneys remove from the blood when the liver breaks down proteins. So the normal ranges, reference ranges, of course, these ranges vary from lab to lab, because of the specimen they use. And so you may find deviations. If you have the normal levels from Nairobi Hospital, they may deviate slightly from the ones from Lancet or from Kenyatta National Hospital or from any other. And at this point, I would request anyone who is going to be interpreting these results will use the reference ranges as per the lab that has given the results, the one that has conducted the assessment or analysis. So for the BUN, the normal ranges 2.1 to 8.5 millimoles per liter. For us, we're using millimoles, and the low number is malnutrition. If a patient has a low BUN, the first thing is malnutrition. You'll check. And then high number, the patient could have liver or kidney disease or heart failure. So for us to say that the patient has kidney failure, the BUN and the creatinine must both be high, and they have a ratio. So at that point, of course, this calls for more training and more reading on kidney, and so that you're able to interpret when you say the patient is in kidney, because this is nephropathy. So under nephrology, that is deeper biochemistry, which we are not going to go at this point, because other measures like GFR must be, and electrolytes must be coordinated. So for the BUN, if it is low alone, you find that the most the malnutrition may be present. The patient is not taking enough protein, so the liver has very little protein to break down and release any waste product. So high number liver or kidney disease or heart failure. When it comes to creatinine, again, just like BUN has had mentioned earlier, this is always confused with kidney failure, even when it's on its own independently high or low. Many people rush to kidneys. So the normal levels, we have categorized the creatinine into male, female, 60 to 110 millimoles for male, and females 45 to 90 millimoles per liter. And it is low, there is low muscle mass, or there is malnutrition. We need to know that creatinine is also a waste product, just like BUN, and it results from the breakdown of creatine, which is a compound that helps increase muscle mass. So you find that our sports nutrition comes in here, and you find most of the shops, the healthy you shops and all these sports shops, they are selling a lot of creatine so that people can build a lot of muscles. And that is where the challenge is, as my colleague who has just finished on the anthropometry has said, yes, there is a lot of street nutrition, online nutrition, and many of our population are being caught in this web where they think more is better. So we find many people, many sports people consuming very high levels of creatine, and this can also be very dangerous. These products are very high in electrolytes, especially sodium, and that can cause other major problems, including kidney problems in the long run. So low levels of creatinine means low muscle mass, malnutrition, and high levels depicts chronic or temporary decrease in kidney function. Again, just like I mentioned in the BUN, more assessments should be done when the urea is high, when the creatinine is high. If they're both high, then we need to check on other issues like kidneys and whether the kidneys are performing well. And the next one we are going to look at in terms of metabolic tests is the calcium, which is a mineral needed by the body to build and maintain strong bones and to carry out many important functions. I don't think there is any function in the body that does not rely on calcium. And by this, I mean it's the most abundant mineral in the body. So this is another mineral that is being abused in this country, where many, especially of the women, are supplementing themselves without any medical advice on calcium, especially those who are approaching menopause or those who are going through menopause. And it's becoming a major cause of major metabolic diseases. So what does it mean to have a low calcium level? So a low calcium level means the patient or the person at hand has calcium, magnesium, or vitamin D deficiency. The person may be malnourished. There could be pancreatitis. There could be neurological disorders, and especially those ones of Parkinsonism, or seizures. So we also have patients who are taking medications that could affect calcium absorption, like the beta blocker, the calcium channel blockers. So excess or high number or high calcium level could mean excess intake of vitamin D. This is also very common. We have more vitamin D supplements being bought from the chemist than asking our patients or our people to bask. The sun is predominantly here in Kenya and in Africa at large, but we are concerned at the rate at which we have hormonal cancers due to lack of adequate vitamin D intake. So it's a point to note that most of these conditions that we have are modifiable, and the medicine is as good as free if Sunshine is going to address most of these hormonal cancers by just helping our patients to bask. Why not tell the patient to have adequate sunshine and expose themselves instead of giving them vitamin D supplements? So when the calcium is taken in excess, we are looking at whether the patient has kidney disease, especially in the late stages of kidney failure. stage 4, stage 5, where we have the patient is not secreting many hormones, erythropoietin. We have the parathyroid hormone overworking, and this could lead to hypercalcemia. So this is quite something to take care of, to note. We also have many cancers, of course, present with hypercalcemia, and hyperthyroidism is also presented with hypercalcemia. At this point, of course, if you're dealing with kidney patients, cancer patients, or patients with metabolic issues, endocrinology, or related, we need to work as a team. They may come to your office or to your clinic with the laboratory test, and it's good you understand the pathophysiology behind these diseases so that you're able to address them, because most of them emanate from an inflammatory process, and you need to understand the inflammation or the inflammatory process that brings about these diseases, so that when you tailor your diet and make it highly anti-inflammatory, you'll notice that in the long run, within a very short time, this high calcium will start going down, so that means the inflammatory process is reducing, or the inflammation that the patient has. So from there, we are going to protein. Protein is very important to our bodies. As you know, all of us as nutritionists, dietitians, protein is a macronutrient, and it's made up of building blocks called amino acids. And it's very important for muscle and bone building and repair. And of course, for the production of many enzymes and hormones that keep us going. So protein is a very, very important macronutrient. However, of late, we've seen many patients or many people glorifying protein so much to an extent that they are taking too much protein, either from their diet or from the supplements that are being sold in our country. So normal protein levels 6 to 3 to 7.9 grams. Again, as I said, laboratory differ in terms of references, but with a small margin. So when the protein is low, this could be a sign of malnutrition or liver or kidney disease, where the liver is not able to deaminate the protein. So and then we have dehydration when the protein levels are high. We have dehydration, we have liver or kidney disease, or multiple myeloma, which is a cancer of the bone marrow. So in terms of dehydration, this is very common, where we have patients who are coming, presenting with high proteins when you do the total protein, but in terms of the skin, very dry. And that's why nutritionists must be very keen, so that biochemistry, they assess the clinical part, the signs and symptoms of dehydration are very important, because if you miss dehydration, if you miss that this patient is dehydrated, even your diet will not work. It will never work. The body works on the laws of osmosis, and osmosis is water. So even if you give the best diet, the water is not enough, it may cause more problems to this patient. So dehydration will lead to a high protein status. So, and that is where we find many of these laboratory measures or biochemical assessment methods having their own challenges, because with dehydration or overhydration, you may get a different result. So when it comes to albumin, albumin is also tested a lot, more of course in pediatrics and people with chronic diseases, kidney patients, TB patients, cancer patients. Albumin is really tested, and I agree that albumin is the most abundant circulatory protein found in plasma, representing half of the total protein. As you can see, the normal ranges is 3.9 to 5 grams per deciliter. So this is one of the key tests that you find being done in our clinics and in our hospital. And when a low albumin, when you get a low albumin result, it shows or it poses to either liver or kidney disease, or there is malnutrition. And if it is high, there is dehydration. So you can see that protein require a lot of water for them to function optimally. So the next one is alkaline phosphates, that is ALP. Alkaline phosphate is an enzyme found in many parts of the body. Most ALP is found in the liver, in the bone, in the kidneys, and digestive system. So we have the international units for ALP, and when it is low, it is a sign of malnutrition. When it is high, it is a sign of certain cancers that spread to the bones. Remember, ALP is found mostly in the liver profile. When we do a liver function test, ALP is function. And then you have most of the patients who have cancers that have spread to the bone, bile duct obstruction, liver cancers presenting with high levels of ALP. This is common, of course, even once we start chemotherapy, patients are started on chemotherapy, even radiotherapy, find that ALP levels will shoot. And at this point, of course, this is a point of concern, because the inflammatory process, the inflammation process that is we are calling cancer is spreading, and this predicts, of course, to a poor prognosis in the long run. So those who have high ALPs because of bile duct obstructions, then as a nutritionist at that point, they have to be relieved of the obstruction. So you cannot intervene when there is an obstruction. First, the obstruction needs to be relieved. Of course, that needs to be seen by the specialist. Once the obstruction is relieved, then we have a good flow. Then you can come in with your diet. Can nutritionists be able to relieve some obstruction? Yes, just like constipation, where we can change the diet, some mild obstruction. Unfortunately, in our country, most of the time, our patients are coming to the nutritionist, either they are being referred very late, and you know, from our health-seeking behavior, a nutritionist is not seen as a first-line specialist. So by the time you are being referred to this by the specialist, these patients, either they are vomiting everything or they are on their deathbed. So this is very serious. And I saw that even while I was working at KNH, it was the same story. By the time we are starting parenteral nutrition, especially for the private patient, the physician at hand has just been delaying, not consulting. When the patient has lost most of his or her body cell mass is when you're being called, and they pose this challenge to those who are practicing in the hospitals right now, to be there to initiate this conversation and start learning biochemistry very fast, so that they can help the patients who would have saved or given timely interventions and would not have died. So those also with the liver cancers, just have mentioned, most of the cancers present with high ALP. For the Paget's disease, yes, this is disease of the skeletal or muscle, and it's rare, but for those who have it, again, they present with high ALP. The next one I'll look at is the ALT, alanine aminotransferase. It's part of the liver function test. Not so common like the ALP or albumin in terms of testing, but generally you'll find it being checked, especially for people who present with what we call alcoholic syndrome. People who have been abusing alcohol addicts, they will come with deranged ALT, very high levels of ALT. The normal levels should be 8 to 37, that is international units per liter. Then we are also concerned at the rate at which many of our people are abusing acetaminophen, which is paracetamol. So we have a population where the chemists have become their consulting grounds. People are not going to the physician's desk even for a prescription. And if you look at the self-medication, in this country, we find a population that is Googling everything. We have Dr. Google who is providing every answer to their problem. And one of the challenges we are facing is of prescription or personal self-prescription of paracetamol and most of these painkillers. And this can lead to a problem with the liver. So when ALT levels are high, we look at toxicity either of the paracetamol or alcohol, or the person has hepatitis. So you need more further tests to rule out all this, and of course do dietary assessment and lifestyle assessment of the individual when it comes to the social evils. Now we come to the blood tests that we see commonly done in our country. Blood tests are many. We call it the full hemogram, and I'll just look at some of the tests that are common in the full hemogram, which is a test that is done almost to every patient seeking any medical assistance. It's one of the most common biochemistry, and we start with the white blood cell. So with the white blood cell, you find that, sorry, just a second. So with the white blood cell, the white blood cell count, the white blood cell count, the normal levels are usually 4,500 to 10,000 cells per microliter. And these white blood cells produced in the bone marrow, they defend the body against infections and disease. So low numbers of white blood cells depict an autoimmune illness, a bone marrow failure, or viral infections like HIV, hepatitis. And when the white blood cell count, WBC count, is high, it depicts an infection, inflammation, could be a cancer, or could be stress and intense exercise. Now, this is where now my previous facilitator mentioned about people going to the gym on an empty stomach, doing extraneous exercise. They don't know that they are stressing their body and causing more harm than good. So we have also had cases of hypoglycemia being reported in the gyms because of the same scenario, where people give more to exercises than what they eat. So in terms of weight loss, we can't sit and say that it's okay, let them exercise. No, they need to know that their dietary patterns influence weight loss, and they have to be done in conjunction with the exercises. So exercises are important, but where they are being done without a proper diet, they can lead to more metabolic issues, including changing the white blood cells count to causing more inflammatory processes than good. So in terms of white blood cells, yes, many patients who have high number, they already have an infection and they are given the proper antibiotics to treat it. So for the red blood cells, we have the red blood cell count, we have the male 4.7 to 6.1 microliter per microliter, cells per microliter. So, and the female 4.2 to 5.4. This is also very important, especially in our country where anemia is a major problem. Yeah, and it's a public health problem. And those who are in the hospitals can attest to it, that most women and young ladies seeking medical services are anemic. Yeah, even in our private clinics, that's what we are seeing. On average, 5 out of 10 ladies coming to seek nutrition services in the private sector, they are anemic already. So this is something that we need to address and encourage our young women and even the older women to eat in a healthy way. So when the number is low, when the RBC count is low, it depicts iron, vitamin B12, or folate deficiency, or bone marrow damage. Just to put it clear that I find it more of an iron deficiency disease more than a bone marrow. For the years I've been practicing in terms of red blood cell count, I find it's more of the dietary patterns, poor diets, poor dietary choices, a lot of junk food. So most of our young population, our teenage population, they are not adhering to a healthy meal plans. And because of these losses, the monthly losses, especially the menses, you find that they will always come with a HB of less than 10. And it's unfortunate because most of the time they will come already on hematinics, they're already on iron supplements. And wherever they went, even in big hospital, they're never told or even referred to a nutritionist. I don't understand why, because we should address behavior more from a dietary angle before we go to supplementation. So iron deficiency, anemia remains a major challenge in our population. And I think if we hold hands together and share such experiences, we can improve the situation. So when the RBC count is high, it depicts dehydration, renal problems, pulmonary or congenital heart diseases. So that calls for further evaluation from the cardiologist or from the nephrologist. Of course, with renal insufficiency, erythropoietin levels very low, we find a lot of low RBC in the renal population. But look at dehydration again. It appears here. It appeared in the proteins. It appeared in the albumin. So is it ringing a bell? Are you drinking enough water yourself? Because you can see that most of these things are very they look basic, but you can imagine dehydration can reach a point where it will alter your RBC count. It will alter your albumin levels. It will alter your blood chemistry. That is quite a problem. And with this country where people are not taking water seriously, we need to make it a part of an aggressive kind of campaign. So when it comes to hemoglobin, HB, HB, just like RBC and WBC, is also part of the blood test and tested a lot. And normal levels, male is 10.8, 17.2, female is 12:1. And again, just like red blood cell count, we translate the same. When it is high, it is dehydration, renal problems. When it is low, it's the deficiencies of iron, vitamin B12, bone marrow recessions or damage. The platelet count, again, platelet count is very important, which is usually to show the clotting mechanism, which shows the platelets, of course, are particles in the blood that help the blood to clot, also known as thrombocytes, which are essential for the formation of blood clots. So if the patient has low levels of platelets, there could be a viral infection, there could be lupus, which is an autoimmune disorder, pernicious anemia due to vitamin B12 deficiency, which you can test. Then we have high number, leukemia, inflammatory condition. And finally, stool sample analysis with the helminths. We need to check for worms, hookworms, ascaris, infections. So if they are high in number, we have anemia. So as I said, yes, normal values and reference ranges may vary among laboratory tests, among laboratories, and some labs use different measurements. And those are my references. And thank you for listening. Thank you.
Okay. Yes, it's okay. Yes, okay. Thank you very much, Anastasia, for that. You need to switch it on down. Yeah. You need to switch the mic on down. Push. Yeah. Okay. Thank you very much, Anastasia, for that presentation on biochemical assessment. We started with anthropometry, and then now we have done biochemical. I don't know whether we do all presentations before we can ask questions, or yeah, I think so. We will be able, our questions will continue coming, and they will be collected accordingly, even online, as we move with the presentations. Okay, so after anthropometry, then the next component is clinical. As Dr. K had introduced, we have the A, B, C, and D, and now we are at the C. So I will be able to take you through the clinical assessment, and we will do the presentation following Anastasia's presentations. What I want to do as an introduction is that clinical assessment is usually the first component of assessment.
Putwa, can you change that? Putwa,
when you get into the facility and you get into a consultation room, the first phase
can you change the slide
of assessment, other than what was said, or in terms of clerking patients, the first part that comes up is usually the clinical assessment. When you talk about clinical assessment, you are just talking about signs and symptoms. Signs and symptoms, whereby symptoms are basically what the patient or the client will tell you they are feeling. The signs are what you can see as a practitioner on the patient or on the client. Begin with the slide. There's a slide.
Let me forward. Just go ahead. Let me forward to the slide.
Basically, when I talk about clinical assessment, I will begin to indicate from head to toe. And in very simple terms, as I've said, clinicals is basically about signs and symptoms. The signs are basically what the patient, what you will see as a practitioner on the patient. And some of them have already been alluded to in the biochemical assessment when Anastasia was going through biochemical assessment. And the symptoms are basically what the patient will tell you they feel. For example, when somebody comes and tell you, I have a headache, that becomes a symptom. Things that you can't.
Can we mute? Please, can we mute the participants? Because there are a lot of background noise.
We'll be able to observe. Are you able to have that Nini up? The slide. Okay. Let me wait for the slide to come up so that as I will be doing explanations, you're able to see. Meanwhile,
can we mute participants,
do a presentation. Please? When you want to assess a patient clinically, you will be using mainly your eyes to observe and listening with your ears. So while in anthropometry, there were specific tools that you are using, and even in biochemical, there were specific tools. In the clinicals, the only tools that you have are your ears and your eyes. Your ears and your eyes becomes your tool here. So I will give you what your ears will mean, an interpretation of the ears, and also what your eyes will see, an interpretation of those what your eyes will see, in simple terms, from the head to your toe.
Prof,
So
I
beginning
think
with the eyes, some of the observable, it is usually important that when a patient approaches, you be able to observe the patients in terms of their general strength, the weaknesses. Once they are down, you'll be able to check, or they are seated, you'll be able to check on the hair, for example, the hair color. What does that mean? The spast, if the hair is spast in a child, what does that mean? The change of hair color is one of those that will depict malnutrition, the different types of malnutrition, either marasmus or marasmic quash. But not only that, there are other aspects of malnutrition that will interfere. Thank you very much. I think it is now displayed. So, as I said before, the first component has already been identified there, that clinical assessment is basically checking about the signs and symptoms. And those visible signs will appear on the hair, will appear on the eye, will appear on the body, will appear on the skin. So these are some of the areas that you'll be observing accordingly to be able to know whether the clinicals are matching with the outputs that are from either anthropometry or are matching with the outputs from the biochemical. Now, some of the few that have been put there, one of them is the bilateral deep-pitted edema. But before I reach that, I think I better check on the eye, for example. What you will check under the skin or under the eye, when I say under the eye, it simply means the epithelial cells of the eye. And sometimes the doctor, I wish I would be displaying for somebody, because clinicals is usually very, very practical. When you press and lower the lids of the eye, for that matter, either up or down, you'll be able to check on the epithelial layer of the eye and check whether it is pale or not. When it is white, they call it pale. And pale simply means that there is less blood flow. It will be an indication of anemia, and therefore you would be able to check on the hemoglobin levels. It's an direct indication and linked to the hemoglobin assessment. One of the blood assessment that I was already alluded to. Just as simple as that. Somebody can also come with visual or problem with vision, which can reflect some issues to do with vitamin A levels. You know very well that vitamin A helps in enhancing the retina's function. So one of the key nutrients that would be able to be questioned when somebody lacks or vision for that matter is the vitamin A. Now, as you move down, you can also be able to check even the mouth. In your clinical assessment, check the mouth of the person, and that would be able to indicate if an individual has the paleness can still be reflected under the mouth. But you can also be able to check the teeth. And when somebody lacks teeth, for example, in aged persons, then the ability to be able to chew certain foods becomes a problem. So when an individual presents in the hospital, you'll be able to check on the mouth to be able to check the availability of teeth. And whether if the teeth is not available, then that would be able to reflect in their overall body in terms of their weight. And you can be able to depict that weight loss could be as a result of food that is not prepared in a way that can be taken by that kind of individual. As you move down, then you move to the skins. Skin has quite a number of presentations, and a number of them, you can just move to the next slide, the one that you're presenting. Yes. The one that has physical. When you move to the skin, there are a number of things that you can be able to watch through the skin. And one of them that I will be able to pick is dehydration, for example. How do you test for dehydration in the skin? Dehydration will be tested in many ways. One is that you can pinch the skin and see how the skin retracts back. That is called the skin tagger. When you pinch the skin and the skin goes back immediately, it means there is proper hydration. If you pinch the skin and pull it and it takes a long time before it goes back, then that is an indication of dehydration. So that is one. For children, there are a number of issues that you'll be able to watch. One of them, especially children below 6 months, there is something called frontal fontanelle. When you have a sunken frontal fontanelle, it's an indication of dehydration. And sometimes children will present with restlessness. So sunken fontanelle, frontal fontanelle, sunken eyes, and accompanied by restlessness is an indication of dehydration for the children. For adults, you will also check on the issue of the skin tagger as an aspect. You'll also, as you can see, even from that patient that is presented there, you will realize that the tissues have been wasted completely to an extent that the skin has remained without the tissues under. And that is a sign of malnutrition and could also be as a result of dehydration as well. If you go to the next step, the one that has the major list, can you go down? So that I can list some of those signs and symptoms. Yes, that one. Okay. So there are a number of signs and symptoms that you'll be able to see. And the most important in this case is how to be able to identify them. I've just talked about dehydration and how to identify dehydration using the skin tagger, using the sign of restlessness in a patient. And for adults, it can also present with migraines. That is headache, which means sometimes even to be able to manage headache, you just need to take water. And for young children, you will also check on the sunken fontanelle. Now, the opposite of that, bulging fontanelle, for example, is an indication of infection. Or in some patients, you may need to test for sickle cell disease. When you see a bulging fontanelle in a child that still has pulsating fontanelle, and when I talk of fontanelle, I'm talking of the frontal part of the head, the place I'm touching if you're seeing me. That place is having a lot of clinical indications in children, and you need to watch it. If it is sunken, I've said mainly dehydration. If it is bulging, which means it is swelling, it's a sign of infection that can be meningitis, associated with the meningitis, for example, or sickle cell anemia. It's one of those that will indicate that component of bulging fontanelle. Now, as you move down to the feet, and if you go up a bit, there is, just go to the next before you will come back to this, go to the next page. On the feet, you will be dealing, for example, with the edema. Edema that usually presents in malnutrition is bilateral deep-pitted edema, for example. And how you assess it, you actually press on the leg or on the feet of the client or the patient to be able to see the extent to which the edema is, or be able to assess the grade of edema for that matter. Now, one of the key things that happens in edema, or what is the indication of edema? It simply means that the patient or the client is not able to have the venous return. And therefore, the body fluid is actually accumulated on the tissue. Now, when that happens, it causes a swelling. If that swelling happens on the legs or happens in the general parts of the body, it is called anasaka. So you will get sometimes clinicians use the word anasaka to mean that it is a generalized body edema. How do you test for it? You actually press, of course, not very painfully, so that you are able to grade it. And we have provided there how that press is done. You put the legs in a common platform and press on them and be able to see the extent to which the bilateral edema is pitted. And when I talk of deep pitted bilateral edema, it means you press them and they go deep. That is what is called deep pitted bilateral edema. Now, if it happens in the entire body, it is called anasaka. And sometimes that may be an indication of many things, not just severe acute malnutrition, in this case, kwashiorkor or marasmic kwash, but it can also mean there is a problem with the kidney. It can also mean nephrotic syndrome or nephrotic nephritis, which then can be confirmed by the biochemical tests, including the tests of the urine for that matter, so that you are able to see if that is the case, then it can be managed accordingly. There are very many other symptoms that you'll be able to look at, including, for example, loose stool, diarrhea. When a patient comes and complains of diarrhea, then you know there is a problem with the gastrointestinal tract, and that can have many things. Diarrhea has been classified as either osmotic diarrhea, for that matter, or you can just have diarrhea normally. Whenever there is diarrhea of any form, then it means there is inflammation of the gastrointestinal tract. And one of the key problems that is likely to arise with that is dehydration. Anytime you see somebody with diarrhea, which is more than 3 episodes of loose stools daily, one of the key symptoms that is likely to come about is also dehydration that's attached to diarrhea, which affects the fluid electrolyte balance of the body. And it will present by things like dry mouth, which has been presented up there again. Cheilosis, for that matter. When I talk of cheilosis, it's cracked lip. And it will also present with headache sometimes, especially for adults. Now, that means that a number of nutrients will also be affected other than the fluid and electrolyte, including absorption of specific nutrients. And one of the key nutrients you'll be sure of, as we have already indicated in electrolytes, the sodium and the chloride will be some of the nutrients that will be affected. And usually for such patients, then that will require replacement, either intravenously, or for children, you'll find them now in the hospital, you'll be dealing with rehydration, oral rehydration salts, or for that matter, to be able to ensure that that is corrected accordingly. So this one I know you deal with very commonly within the facilities, And at the MCH, you have a corner where those oral rehydrations are reconstituted to be able to deal with the issues of diarrhea as a symptom. So essentially, there are many, many clinical tests which you can be able to observe and see, and their meaning. I've just mentioned a few. Even the ones that, for example, the albumin ratio, or the albuminuria for that matter, if somebody is losing albumin through urine, that is what is called albuminuria, and it will always be identified by the biochemical tests, as we have already indicated. It is an indication of a failing kidney, as was already said before. And when that happens, then one of the key symptoms you'll be able to observe is, again, a NASACA. There will be retention of body fluids in the body. And when that happens, then somebody will present with swelling. The other thing is ascites, or what we call abdominal distension. When the body fluids accumulate in the peritoneal area, peritoneum is just slightly above or in between your stomach and the intestine. There is a space there called the peritoneal space. Sometimes inflammation can occur in that area, and it will cause fluid retention in the abdomen, and that can make patients come and present with abdominal distension. Okay, so when there is abdominal distension, then you will be able to see it in mostly HIV AIDS patient or patient with immunocompromised conditions. You'll also be able to see it with children who are suffering from malnutrition. So that kind of fluid is called ascites. And it can be intervened medically, of course, by removing it, or management by the doctors through medication. I think those are some of the few, but there are very many other clinical symptoms which you'll be able to observe, and mostly you'll be able to deal with them based on experience. They cannot be presented, and diseases will come with mixed reactions. So it is up to the clinical nutritionist to be able to make decisions. Some of them are not directly related to the conditions as they are. For example, I've just talked about edema. Deep-seated bilateral edema may not just mean kwashiorkor or marasmus. It can mean other things as well. So discernment of those conditions are very important. I think with that, let me leave it and allow questions to come by. Or I think Dr. Keyo, is it? He can be able to now present the dietary. Thank you very much. Is Dr. Keyo? Yeah. Okay.
Dr. Keyo is in. Good.
Okay. Good. I can be heard. I think I can show it from here. Good, because of the links. There's some links there. Okay. If you allow me to be the host. Oh, thank you very much, ladies and gentlemen, and of course, professionals. I'll take us through quickly the dietary assessment. Then we can wind up and now take questions and answer, and we can discuss in the remaining time. So I'll spend the shortest time possible with you. And I want to talk about dietary assessment. I hope I'm audible enough. Okay, thank you. So when we talk of the ABCD approach, and again, I said after the ABCD, we need to add the one major factor that was not part of the assessment, that is nutrition security or food and food security. I think those are very, very important aspects of assessment. In addition to the ABCD, the food security is another component which, as nutritionists, we need to look into. So with assessing food and fluid intake is very important in nutrition assessment. And what I can say that it provides information on dietary quality and quantity. So when you talk of quantity is the amount, when you talk of quality is either in form of food groups or variety. When we are doing diet quality check, normally we look at the distribution in terms of two domains, that is the quality and that quality and quantity. And quality here is in two aspects, that is food group and variety. Now, when we talk of food groups, then we know as nutritionists how we assess food groups. When it comes to variety, then we look at within food group. Within a group, what does it mean? We also look at changes in appetite, allergies, and of course, some aspects of intolerance and reasons for inadequate food intake during and after illness. So when we do that, the results are compared with the recommended intake. For example, the RDAs. And this is purely for purposes of counseling clients or improving their diet at all costs. And why? To prevent malnutrition and treat conditions. And these are conditions, specifically those affected by food intake and nutritional status. And we have quite a number of them, particularly in the domain of NCDs, as you can see on that slide. So I'll go again to different types of dietary assessment that we have, and I'll start with there are three categories I'll talk about. I'll start with the 24-hour recall. Now, 24-hour recall may look simple. Most of the time, we take it casually, but it's a very, very important dietary assessment tool. This method was designed to quantify the average intake for a group of people, although it can be used to assess individual nutritional intake. Now, during a recall, a client is asked to remember in detail every food and drink consumed during the previous 24 hours. Most of the time we make mistakes when we are doing 24-hour recall by just looking at asking the questions, what did you eat in the morning? What did you eat at lunchtime? What did you eat at dinner? Because that is our usual 3-level diet category. That is a big mistake. In this context, the 24-hour recall complete will look at food consumed within the 24 hours. The method can be repeated on several occasions to account for day-to-day variations in intake. Because of the possibility of memory loss, we can always do a repeat test. So you can decide to do a 3-day 24-hour recall to get the real picture, assuming that there's no much variety change between days. But if you do that, then you can do validation. The method can be repeated on several locations, as we have said, and this is purely for validation. So as a healthcare provider, we may prompt clients to remember what they ate or drank by time periods or activities, just after waking up, before going to bed, or to estimate portion sizes by looking at household measures, food models and household utensils and photographs, or actual food. And most of our nutritionists that are trained, they understand this. But I want us to look at the form for 24-hour recall, so that we see how do we take the best 24-hour recall so far when we are assessing within 24-hour period. This is the nature or the structure of the form that we normally use. And as you can see, it is very open. It does not categorize. It does not categorize breakfast, lunch, and dinner, because the dietary patterns are changing. And so you cannot assume everybody is on 3 meals a day. People eat at different times. Others depend on 1 meal a day, but they have snacks or in between, or 2 meals a day. Some can even do 4. So we have to really be specific on the time food was eaten along the process, and that depends on the memory scorecard of a particular client. So there's a lot of biasness with this. So the table here allows you to record every minute, every time somebody ate within 24-hour period. So what normally do we do? Now, that static means that it includes both foods eaten alone and foods combined in a dish, or soup or stew. And that's why sometimes it's very difficult and subjective, because when you ask people what they ate, they will not tell you sometimes whether they shared the food or not. They will just tell you, I ate sukuma wiki and ugali in the morning, and the portion size was the size of my fist, or 1 serving. But they didn't tell you that they shared that serving with somebody else. So it becomes very difficult to quantify. Those are the key biasness we have with the 24-hour recall. Now, how do we do it? Explain that you will use the information to evaluate the client's diet, and then counsel on how to improve it. So anytime you conduct a 24-hour recall, you must make the clients or the person you are interviewing to see the seriousness of what you intend to do with the data. We are also required to reassure the clients that information will be kept in confidence and used only to assess his or her nutritional status. Now, we have to stress that there is no good or bad food, so that they cannot hide what they ate. There are people that can hide for you what they ate because of the feeling that they are embarrassed when they mention it to a third party. Do not show in words or facial expression that you approve or disapprove of any food or drink to the clients. That means you have to be very, very candid and also very objective, and you have to desist completely from taking sides on your preferences when you're dealing with a person on 24-hour recall. Also, we are told, do not ask any question that will lead the clients to think he or she should mention any particular food or drink. So when you're doing a 24-hour recall interview, you have to take caution of that. List everything the client reports eating or drinking, including snacks, beverages in between, condiments, or foods eaten at home or away from home during the past 24-hour and the past week. Now, one of the things I found with most of my students, for example, when they're doing a 24-hour recall, is to categorize 24-hour recall into just main meals of the day, breakfast, lunch, and evening. They never talk about sweets eaten or chocolates eaten or sugarcane chewed along the way, or maize cobs. And that is why it is very important to be very keen to persuade
getting
Recording in progress.
We can continue. Sorry. Am I being heard? Okay. We are sorry for the power went off, so I can continue. Can you make me a host so that I can continue sharing? Can go ahead. Good. So I can share the screen now. Thank you. Good. So my screen is up now. Good. Professionals, we are sorry. Power went off abruptly, and it went with the back end. So we are continuing. As I said, when you're conducting, these are some of the things you check when you're conducting a 24-hour recall. If I go back to where I left, we are told that do not show in words or facial expression that you approve or disapprove any food or drink when you're collecting data for its accuracy. And we are also told to list everything the client's reports, eating or drinking, including snacks, beverages, and condiments, and all foods eaten at home or away from home. And I said, this is where I said that sometimes when I deal with the students, they will only focus on major food, and they forget about the in-betweens that people take, like chocolates, for example, or maize cobs. And that can bring an error in their consumption. So then 24-hour recall does not become the best way to assess a status of an individual or a group. Now, we are supposed to ask questions such as the following to probe information. What was the first thing you ate or drank when you got up in the morning? Now, do you remember anything else you ate or drink? These are probing questions. Did you eat the food plain or put something else on it? What foods do you especially drink? I mean, like or dislike? Now, if you were sick during the 24 hours, how did that affect your eating or your eating? And you can ask many others like, did you share the food? And all that can be useful to get the accuracy of data. Then now you go back and ask the client to estimate the size of the portions of each item. So you see, it is a real tedious process. Sometimes people do that and they are doing it so quickly that they don't really check even the portions. Sometimes I ask people, is it really true that we ask a 24-hour recall accurately? Because I'm looking at the time that you are going to take to ask for estimates of portions, and sometimes it becomes very difficult. I'm off, eh? Have you put me off again? Yeah? Somebody was interfering with the internet? Wow. Yeah, that's what I'm saying. I keep on getting disconnected, but it's okay. We can go on. So, as I said again, you'll bear with us, but we are sorting out the matter once and for all. So, again, do not label the meals breakfast, lunch, and dinner. That is the rule, a final rule, because this is usually what we know, breakfast, lunch, and dinner. Don't. You have to time what food did you take, what time. I think we need to stick to that for 24-hour recall. After the client has mentioned all the foods and amount for the past 24 hours, then read the list back and ask whether there is anything that was left. Then you thank the clients for cooperating because it's a tedious process. Then assess whether the clients ate food from all the food groups, and if not, cancel the clients to add. So you can also be courteous enough to tell them how they can choose from the different foods. So as you can see, a 24-hour recall is not just assessing breakfast, lunch, and dinner. It is a whole process of looking at the entire food behavior from morning, that is from waking up to going to bed, and not leaving anything that was consumed along the process. That is when you can get the accuracy. And then sometimes when this happens, of course with the students who do assessments, when you see that they are trying to tell you about correlations, you wonder if really it was the real 24-hour recall done, or it was lunch, supper, and dinner. They may get it correct, but sometimes there's a lot of error in it. So that is a 24-hour recall. I want us to go to stop sharing and then go to another, continue with the slides. And now I'm going to food frequency questionnaire. I hope I'm sharing. Food frequency questionnaire. This is also another dietary assessment tool. Now, a food frequency questionnaire is designed to obtain information on overall dietary quality rather than nutrient composition and intake. So when you talk of food frequency questionnaire, we are looking at the food groups and variety, not the composition of the food. It examines how often someone eats certain foods, or sometimes the size of the portions. And it is a very quick and inexpensive. But underreporting is also common for food frequency questionnaire. Again, I would want to show you a form, a typical form for food frequency questionnaire, so that we can see how is it done, how to use a food frequency questionnaire. Practically, this form demonstrates the food frequency questionnaire, which is generally acceptable by a majority of scientists and also professionals. We are looking at the food item, and we are looking on the left-hand side, and we're looking at the columns. So we have average number of servings per day and per week, and serving sizes estimated, whether large, medium, and small. Now, many times people ask, what do you mean by large, medium, and small? And sometimes people you say, oh, no, for a serving, you can use a fist, but you have different fists. Some people have bigger fists, others have smaller fists. So how then do you tell somebody that somebody's bigger fist is a serving and another person's smaller fist is also an equivalent serving? So then we must have ways of using standardized cups, for example, which has quantities needed to get the real demonstration, to get the real information from a particular individual or a group of individuals. So on the left-hand side, you'll see a number of foods. So we're looking at meat or chicken, and you're looking at fish or seafood, and you're looking at eggs. Basically, in the traditional days, people were looking at protein-rich foods, and so they classified all of them. But when you see them divided in this format, then you get to understand that even within the meat itself, we have variety. So when you have meat or chicken, or you have fish or seafood, or you have eggs, it means that these are treated as the most acceptable food groups we have. And if you can count these, you'll find that we have, counting with you, 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, up to alcohol, 14, 15, and 16 items in the food group, which is far different from the common pyramid that we know about. So this is based on a 16-item food groups. So what you would want to do is to find out the number of servings per day that for meat that was done. And then serving size, you have to estimate at an individual level to tell you how much they put on that plate. It's a very tedious exercise also. So that and assessment basically are tedious exercises. And you cannot tell me that you can spend 10 minutes or 40 minutes, or you can get 10 people in a day and you assess them effectively for purposes of assuring or analyzing that they're eating well. But this just to show you what is required. So how do you do it? Yeah, you list everything the client's reports eating or drinking, including snacks, beverage, condiments, and all foods eaten at home or away from home during the 24 hours. You list them down. And then you explain to the client the purpose of the food frequency questionnaire. Then stress that you will use the information to evaluate the client's diet, not for anything else, then counsel on how to improve it. Now, when necessary, when assessing a child, ask the client to try to remember what the child ate. That is the caregiver or the clients or the person or the guardian for the child, or drank during the past day and past week, including snacks. Now, what is important is that after you have listed all the foods eaten in 24 hours, then you can group them in terms of frequency. So you have to dig deeper to ask the amount in terms of serving and also the serving size and the number of servings in a day for that particular food group. So again, as you can see, as nutritionists, yes, this is more of the theoretical than practical. When we now get into the real practice and you want to assure people that you did, you must really be very candid with the information. So most probably, the things that we have been doing are just shortcuts. Now it is the time for us as professionals to say, this is how we want to do. And so we can only call for what could be the best standardized sizing for a serving. What do we use as nutritionists? Do we still use feast or do we still use cups? And if you're using cups, have we designed our own cups that we can use locally in East Africa, in Kenya, in Africa, or globally? Or are we still using a Mzungu design cup? So it is now a challenge to all of us to see how best do we come up with a serving size cup, which we can classify as large, medium, and small, and what is the quantity of it, and where can it be located, and where can we put it, and where can people buy it from, so that we can use them as standardized materials or equipments, small equipments, when we are conducting a food frequency assessment. We don't have that, and no scientist can tell me that they have a standardized one. So probably the data we have in the libraries are wrong data. That is my voice. Now, as a trainer, we need to come up with our own cups, defining large, small, and medium. Now, average number of servings. Those cups will now be regarded as a small serving, a large serving, and a medium serving. So if it was medium serving, then you can say how many medium servings did you eat by showing the model. That is when the food frequency questionnaire will be accurate. Otherwise, as at now, we do not have a standard. That is my voice. And so all the data we have are wrong data. I'm challenging scientists for that matter. The same applies to a 24-hour call. I went to a workshop where somebody was demonstrating a serving by saying, this is one serving, this is two serving. How accurate is that, profs and doctors and professionals? How accurate is that? So if we go by 250 ml, 100 ml, and we standardize this, and we have a particular cup we are using, which is recommended, locally made or imported, crafted, then we can now be talking about we have ways to conduct an accurate 24-hour recall. Otherwise, if you ask people, when you went to assess this in the household, did you carry this type of cup and is it a standard cup? You will not get an answer. So that is another way of assessing diet. I want to move to the last one. Now, in the last one, still sharing, is the food group questionnaire. Now, another way to do a dietary assessment is to show clients pictures of different food groups. In most cases, available from national nutrition authorities or guidelines or policies that have been developed per country. And ask whether they ate or drank any of those foods in the previous days. Again, the issue of memory and individual differences comes in here. Now, looking at this, I want to show you this again. How to use a food group questionnaire. Looking at this, what did the client eat yesterday? That is the main question item. And you look at the picture on the right, I can share it, okay. Look at the picture on the left, I hope it is there. Left-hand side, we have cereals, which is a food group. And here we have rice, biscuits, bread, roots, tubers, potatoes, name them. There are many. So now somebody classifies, did you eat at breakfast, this category, lunch, dinner, or snacks? Snacks are in-betweens. Then we move again to meat, fish, seafood, beans. Of course, that is protein sources. Again, breakfast, lunch, dinner, and snacks. You're talking about variety. Then we have fruits and juices, fruit juices. Then we have vegetables, the way it appears in the pyramid. And then we have oils. So the question is, and then sugar. Does your household grow any vegetable? These ones you also ask just to validate if there's an element of lie or individual memory interference, or just individual wanting to please the data collector. If yes, what kind? Does your household raise any animals or food? You can use it for validation, just to find out whether these people are actually capable of eating what they said. Then we talk of, if yes, what kind? Then clients eat food from at least 4 food groups per day. You can classify that. Clients eat food from fewer than 4 food groups in a day. Now, the quality of food depends on the number of food consumed from different food groups. And this is used both Kenya, Tanzania, East Africa uses this most of the time. So food group is also another method. Now, again, another challenge for me as a scientist, yes, this is well, good enough, but is it accurate? So that you can say that you classify me. Now, this is a bit better, because then if your intention is to look at the quality of diet from different food groups, this is just to check the number of times somebody consumes from different categories. Now, alongside this, then you can also assess the variety. If it is the cereals, what type of cereals? And what is the food composition of that particular cereal? That would then determine the quality. If it is meat, fish, and seafoods, then we also need to know how many times they ate meat, breakfast, lunch, dinner, or fish, just to see whether there is also the element of variety. So this food group questionnaire is purely used for assessing diet quality, not quantity. Now, as you can see in all these 3 methods, they are basically qualitative in nature. But sometimes we try as scientists to quantify them by using food composition tables to try to get the actual intake, and then we correlate. Again, as I said, that is also very subjective and may not be as accurate as we would expect it. So these are just to give you a picture of the behavior in terms of food or eating. But I can assure you, it requires more than what we have been doing to ensure that it is done accurately. So again, another challenge that we need to come up with a methodology of a measurement, a methodology of interpretation, so that if two people are collecting the same data from different households, they are as equally accurate as possible or as close as possible, determining error margin. So I think these are the three data reassessment tools we wanted to display alongside other assessment methods. And what I want to summarize is that nutrition assessment can be very, very difficult. And but we have to now sit down as scientists and say, how best can we come up with almost accurate information for our countries using our local foods, and also ensuring that when we do it, we have a methodology that does not contribute so much towards errors and bias when it comes to assessment. Again, as I said, we are looking at discussion or question time, but I also want to say that even anthropometric data, the way we conduct anthropometry sometimes is one thing. I went to one of the health facilities, I think in the CBD. It must have been AR. And when I went to stand to be assessed, they wanted to take my height using stadiometer. Intentionally, I bent. And when I bent, the one who was taking me did not bother to make me straight. And so they took my height and they calculated the BMI. And I said, they told me that your BMI is 26.5. And I left them. They continued with all the assessment and treatment. But when I finished, I told the nurse that was there that, you cannot take weight when a patient or a client is bent. Then you will not get the accurate height. This is what we do, even nutritionists. We don't care so much about the 90 degrees. We don't care so much about accuracy. And that is how we go wrong with the assessment. So I would want to open this for question and answer. And I want to request all the facilitators to be ready to respond to questions. Professor Nguka and Madam Banis and Madam Anastasia. But I want to invite Laura to come and take us through that process. Yeah. Thank you.
Thank you, everyone, for attending the workshop for the morning session, which was nutrition assessments. My name is Wangara Laura Ching. I work at KNDI as quality assurance person, but today I'm going to take us through the first session of the workshop, questions and answers. So I have been able to follow through the chat box to pick the questions. The first question that people raised was, could they get access to the presentations? So the current conference proceedings is being recorded and it's live on our KNDI YouTube channel. You can always access it at any time. At the same time, also, you can get the proceedings in our KNDI website. If you go to our website, there's a pop-up. You can always click and get the conference proceedings. The next question was on how people can get the book for bunnies. So you could attend the conference fee, will be discounted at 900. At the same time, if you check the chat box, Bernice, for those who will be attending online, Bernice shared her contacts. You can also contact her directly. She will be able to deliver the book wherever you are. But in case you're not able to get the number on the chat box, you can equally send an email to KNDI journal at kndi.institute, and you'll be able to get the contacts. The other question was on kindly share the values for vitamin A, zinc, and calcium. That one has been addressed at the chat box by Anastasia. She said that the values she has shared are the international values, but again, you can use the local values that are being provided at the lab. The other question was on, there's a craze on ketogenic diets in the interest of managing weight and the high use of animal fats for cooking. What's your view on this? For this particular question, I would like to invite Bernice to share her experience in the private practice session. Bernice?
Hello.
Yes.
You can repeat.
There's a craze on ketogenic diets in the interest of managing weight and the high use of animal fats for cooking. What's your on this?
Okay. In my response to this, I would say that as a clinical nutritionist or dietitians, whatever you call yourself, it is very, very important for us to follow through what we studied as clinical nutritionists. I'm sure that we remember that we didn't have a one-size-fits-all approach. I would say that a ketogenic diet have been found to help or assist some various patients with different medical conditions, but it doesn't work for other people. So I would say that as nutritionists, let us be very, very careful when we are giving meal plans or when we are training people online on a one-size-fits-all approach. We also need to understand about the central nervous system, how it works. It can't work well without carbohydrates because of the production of the serotonin hormone, which are feel-good hormones. And we will need carbohydrates in the first line of nutrients. We will also need to understand that the kind of clinical nutrition that we should be talking about is standardizing the nutrient intake, ensuring that we understand a client's needs, where they're coming from, we understand what is available for them, what is affordable for them, what is accessible. You know, we also need to understand that different medical conditions cannot have the one-size-fits-all approach. So for us nutritionists, clinical nutritionists and dietitians, is it possible to help our client individually? If somebody, you know this client very well, and you know that ketogenic will work for them for a specific time, please make sure that you also advise them on having a natural, a normal diet, which is well balanced with all the nutrients, because I never believe in giving diet and eliminating, another nutrient. If we have 6 nutrients that we are supposed to be taking, which is carbohydrate, fat, minerals, oils, and water, then that means that all of them play a major role in our bodies. In our African setup, we realize that anything that grows from the root, most of them are very high in things like potassium. If you tell somebody not to do a potassium diet, they'll start having complications of potassium as well, which we also need it in the body. So every nutrient is very, very important in our system. We need to understand our clients. We need not to do a one-size-fits-all approach. When you teach people on keto diet and another time you teach on intermittent fasting, always know and put a disclaimer as a clinical nutritionist or dietitian that this does not work for her. This works for specific. So they must come and see you so that you can tailor make a diet as according to their body composition and their clinical signs and symptoms. And this will now make sure that we are all treating our client in the best way possible. Because I'm trying to imagine that if we treat all clients for keto, I've been having so many clients who come to me, they tried keto, it didn't work for them. What are we going to do to those who keto will not work for them? And as clinical nutritionists, if you see something has been taken to work for a certain group of people, then we need to be very careful also on how it is started, who started it, for which target group, and the kind of people it helped. And then we are able also to put disclaimers in our clinical guidelines and in our talking to clients. So for me, ketogenic diet is not supposed to be a one size fits all approach. And then something else they asked is about animal fat. Animal fats, in terms of cooking, we know that this is what is mostly available for most of the Africans, and is also very affordable as well. It is important if somebody can get this, it is okay. Fats are good. They are not demons, or let me say, they are not to be said as devils, because fat is very important. In fact, when you look at the makeup of your brain, especially is made up of mostly of course cholesterol, and we realize that cholesterol is not a devil as we used to think, because according to the latest research, if we look through the clinical guidelines, we are able to understand about portioning. And I would want all of us to know portioning is key. Let us teach people what we studied, and then also we go to the current guidelines, and let's guide people properly and individually. So let's not do a one-size-fits-all approach. Understand your client and know where they're coming from, and you can be able to support them from that perspective. So that is my answer to this. So portioning of oils and fats is key, and the type of oil. If somebody cannot afford to buy, let's say, coconut oil, we have got other oils in the market, but we can teach on portioning because it is the portions in most cases that matter. The more you take can cause toxicity, the less you take can cause deficiency. So let's just teach clients in terms of balance, and let's not do a one size fits all. If you decide to do a one size fits all, don't demonize the rest of the clinical nutritionists and dietitians who are doing other normal diets, because this is what I think has been seen so much in the market, and we need to really be careful about this. So let's support each other, so that even the private practice becomes very easy for all of us nutritionists. I believe the last thing before I answer this question, I would say that a doctor who is in Embu giving antibiotics, and the one who is in Mombasa giving antibiotics, the only thing they do is they give antibiotic but from different brands, but it is still antibiotic. Why is it that a nutritionist in private practice who is in Embu is giving keto for all the clients, and another one in Muranga is giving intermittent fasting for all the clients, another one in Nairobi is giving normal diet? So where are we ended in terms of clinical nutrition and dietetics? So in this conference, I'll just put this clearly, that we need to teach people what we studied. We need not to be a one-size-fits-all approach as consultants and as nutritionists and dietitians. Thank you.
Thank you, Banis, for that. The next question will go to Professor Nguka. Someone requested that you repeat the clinical implication of the front fontanelle.
Okay. As I said, the clinical implication of the front fontanelle, especially for young children, with the fontanelle still pulsating, if it is sunken, it's an indication of dehydration. If it is swollen or bulging fontanelle, could be two implications. One, an infection, or what we refer to as meningitis, inflammation of the meninges of the head of the child, or it could be as a result of sickle cell or early indication of sickle cell anemia. It can also cause bouncing fontanelle. So those are some of the implications. But as I said, clinical symptoms are not directly linked just to those conditions I've mentioned. They may mean many things. So if you see a bouncing fontanelle, you don't just limit it to the ones I've mentioned. It can mean, like, infections can be far and broad when I talk of infections. Or even when I talk of sickle cell anemia, other anemias other than sickle cell anemia can also cause bouncing fontanelle. So the ones I've mentioned are just for examples, but just know when you see a bouncing fontanelle, it can be varied, including the ones that I've mentioned, the sickle cell or infection, meningitis for that matter. If it is sunken, then it might mean dehydration, but it might also mean a different thing as well. Okay?
Thank you, Professor Nguka, for that. The next question would go to Dr. David Okeo. How to weigh or measure raw food versus cooked food. So the question is foods with soup versus foods versus dry foods. Which one is measured by the cup? Or even how do you weigh them?
Laura,
Dr. Okeo?
repeat the question. Repeat the question. I didn't get it.
Raw food versus cooked food, foods with soup and dry food. Which one is measured by the cup, or even how do you weigh them in terms of dietary assessment?
Yes, that's why I was saying that this is a very big challenge. Normally, when we talk about the translation of food, which is already cooked, into measurements, it is important also to look at the recipe in terms of the quantities so that we are sure of the content distribution based on that particular portion that has been cooked. Now, that's why we talk of that's when we talk of dry weight and of course wet. So when we talk about food that is on a 24-hour recall, for example, if I use that, it is a cooked food. Therefore, we must get to understand even the cooking method and the recipes. And that's why I was saying the accuracy of 24-hour recall would be very difficult unless we dig into deeper methods of cooking and also the portion sizes. Now, if you know the recipe, you can determine the quantities very well with serving, because then you cannot create matter or destroy matter. You can only transfer matter. So if it is nutrients you're looking for, you'll still get the same nutrients, but the ones that are volatile definitely will not be there. So this is a complete complex. So what we get from the measurement is still not clear, not only in Kenya, but globally. And that is now why I was bringing it, that can we come up with an accurate way or methodology of assessing the serving, the nature of serving, the type of food, the cooking method, all inclusive, to come up with an accurate data. So the scientists in this forum should start thinking like that. We don't have it. So I cannot give a straight answer. Let the scientists get us the answer. Maybe Professor Nguka, if you have been in dietary assessment, you can let us know, or Madam Cheserek. Maybe there's another question that came from Madam Cheserek as Prof is coming. She was asking which is the best method to use in clinical setting. As at now, what we use, Dr. Cheserek, is 24-hour recall. That is the most common one. But as I said, for me, it is not very accurate, but it can give you a picture of typically how somebody is eating. Yes, so it's more subjective than objective in nature. Yeah. Prof, you want to answer that question? You are in the university.
I agree with you, Dr. Keo, that our homemade foods, especially when we have to collect that data using the 24-hour data recall is more of estimations and estimates than actually being very accurate. So, but that would be very different when you're using, for example, foods that have been processed. Most processed foods from companies, for example, milk, they are very accurate measurements per 100 ml of the nutrients. So if somebody consumed, say, a liter of a packet of milk from any of the company, the KCC or whichever, then the specific measurements are fairly easy. But that will not be true in a normal setting, especially when you are meeting our clients in our normal setting here in Kenya. They will tend to consume not mainly processed foods. They will have, like some of us in our village, we will pick even sugarcane, for example, from mashamba, and you eat it. Sometimes you even forget about it. Or you're walking and you pick a bit of guava and eat it up without knowing, so that you will realize that in the process of taking a 24-hour recall, people lose out these bites, especially from the village. The sugarcane that they just took, they just lose out on the guava or a fruit or some small bites, depending on the cultures where we live or we come from. If you come to Luyaland and Luoland, we don't believe on anything called food if there is no ugali, if ugali is not part of it. So if you ask somebody, even in terms of a language, you may end up losing out simply because somebody ate some rice. Then they say, oh, that was not food. So the actual food was ugali. And so it will depend on a lot of techniques in trying to get information from these clients, especially the ones who may not be having higher level of education to be able to know that all foods are supposed to be listed. Thank you very much.
Okay, Laura, before you just, before Prof, I know Maingi has shared. Maingi, what is your intention of sharing? Can you talk now? You have shared the photographic atlas for the adolescent, which is a very good work for the adolescents again, but it's just an indication of how much we are supposed to do when it comes to dietary assessment. Can you talk about it? We can unmute you for that. Can you unmute Maingi? Zadok? Is he able to speak?
Yes, we are working on unmuting. Zadok, you're welcome.
Yeah. The aim of sharing was as a follow-up to a question I've just asked about utilization of the photographic food atlas in doing dietary assessment, more so in the 24-hour recall, specifically on the food portion sizes. Now that the photographic food atlas has majority of the household measurements that we normally use, items that we use for measuring our food. It also has even the portion sizes with even the quantification of the amount of grams that a portion size might have. So I was asking if we can use this to do dietary assessment for adults, since the photographic food atlas is only limited to adolescents of 9 to 14 years of age.
I think you are correct, but then we may not use it, in my opinion, because of the limitations. What I'm thinking, and I would challenge the scientists, is that why don't we come up with a life cycle-oriented atlas for all age groups, so that we can now have photographic representations with our own cups. That is where to go next. And I think the PhD holders we can try to think about it and have a major grants for that, so that we can run the National Food Atlas for Kenya, and we can even extend it to East Africa, so that we know the typical foods there and how much we can quantify them. That atlas can be very useful for dietary assessment. That's what I can say. But it should go through the entire life cycle, so that we don't limit it to adolescents.
Okay, thank you. And
And
just
you have
an
a PhD, you have a postdoc area for grant writing. You can do that.
okay, thank you. Yeah, that's an addition to what you're saying. I think the photographic atlas for the life cycle you are mentioning should also factor in the cultural aspect of foods, because we have some foods that are culturally enshrined to some communities in Kenya. Like, for example, when you talk of the mursik, are we able to quantify the nutrient content of this? So I think it should factor in the cultural aspect of the food. Thank you.
Okay, thank you.
you.
Dr. Sesterek is asking you whether this document is validated already.
Yes.
It is already validated, yes. Okay, thank you very much. I think because of time and we are starting another session at 11, is that a very burning question, Laura, or we can sum up now?
There is one.
Yeah.
So by Samuel, we have two other questions which are pending, but those ones we will reply via email to the specific people who've asked. So the one that is really burning is, does camel milk or meat cause cancer? This is an idea from one of the doctor. I could like to understand this, since it is a problem from where I come from. Professor Nguka?
Yeah, scientist, I think if there is no valid research that confirms or links camel milk, at least from what you're talking about, if I'm able to look at it, camel milk or meat cause cancer. There is no study that has ever linked camel milk particularly and meat to cancer, apart from one study that I know that has linked generally meats with colon cancer only. And it is not causal analysis. It's more of association, just an association, which means you cannot be able to specifically say that camel milk or camel meat, for that matter, can cause cancer. So I dispute that.
Can I just interject a bit?
Yes.
I'm thinking, as scientists, cause and effect is something that scientists need to be very cautious about. As far as I know, cancer, we don't have any specific cause for cancer. Correct. If there's any study that has found the real cause of cancer, I would be interested. We have been thinking of the possible causes of cancer. And so the question somebody will be asking is, camel milk edible? Now, if it is edible, does camel drink camel milk? The camel young one, does it drink camel milk? And then do we have cancerous symptoms in camel who has drank camel milk? Now, if not, then we have to look at, if somebody drinks camel milk and there's a possibility of cancer, then what are some of the treatment behind cancer? And when we are talking about, when I'll be talking about my keynote tomorrow for food animals, you'll notice that it is about the environment and the treatment we do for these particular foods. Any food that is edible, if it is properly treated, it can cause some conditions. So it's not the actual milk that causes cancer for me. Yeah. If there's a study like that, I'd be interested. It could be the treatment around how it is handled, probably could be the one causing cancer. But that will come to me. Yes.
Correct. I think very, very important. That's a good rejoinder. So what we have said is that that doctor is not communicating the truth. Camel milk or camel meat may not be the cause of cancer, or there is no study that has ever associated that with cancer.
Okay, so we can sum up, Laura. Ladies and gentlemen,
Yes.
and my team members, I am very happy that we have communicated some voice in the field of science as well as practice. And it is upon us to start thinking how best can we make nutrition better when it comes to assessment, which is our core business, and of course, what should position us in the medical field. We will also try to make all the information available, and we encourage you to join the conference and listen to issues of food safety. Professor Bong will be talking about food safety from the animal perspective. So this question that has just been asked would be very, very much relevant when he's presenting his paper. So I've also seen a question here, animal fat consumption. Research has been done from Europe and America that has associated animal fat consumption with the deleterious health effects like, of course, hypertension, diabetes. Why would one recommend people to consume animal fat? For me, I don't even have a problem with animal fat. I have a problem with the type of fat. The type of fat. So studies have now come out saying that even what we used to call saturated fat is not really hazardous the way the scientists used to think. But those are areas of debate. So I would want to sum up this and say that welcome for the next session on pharmacology. And we will also welcome tomorrow. From tomorrow, we will be having our conference. And thank you very much. You have a nice day. We are starting at 11:10 for the next session, so you can have a break and then you come back. First, Nguka will be taking us through the pharmacology, which is another area. Thank you.
Okay. Thank you very much, ladies and gentlemen. We want to go through some bit of clinical practice, combining our clinical use of drugs and how that interfaces with foods and nutrients. And this is going to call for previous understanding of basic pharmacology and toxicology. And so there are key issues that I want us to understand. That as we are going to approach this, there is a general understanding that you're already having the basic understanding of drugs, common drugs that we use in our hospitals, and that you understand that there is a difference between food and nutrients. So that when I'm going to talk about food, you completely delinked it from nutrients. And when I'm talking about nutrients, completely delink it from food, so that you'll be able to understand. Food basically is what we eat from the table, what Dr. Keo had presented in the food groups. That is what is called food. And the food has nutrients, but it also has other components, which are not necessarily nutrients, what we call the non-nutrient compounds, like the phytochemicals and the phenols, which play a critical role, even as a component of that food, especially in the interaction with the drugs. In fact, some of the drugs that are used in hospitals are actually components of some of the foods that we have, as we are going to see. And therefore, it is incumbent upon clinical nutritionists and clinical dietitians to understand deeply this scenario so that you can be able to creatively use food to complement the treatment that is going on in the facility. So there are basic terms which I think are critical for us to understand, and I will make them very simple. There is something called pharmacokinetics and pharmacodynamics. So if I begin with the word pharmacokinetics, and as you'll be able to go ahead and see, you'll be able to understand that pharmacodynamics, in simple terms, is the action of drugs on the human body. In simple terms, how drugs act on the human body, how those drug substances exhibit pharmacologic actions that reinforce or even interfere with each other in the management of conditions. So in simple terms, what I've said, pharmacodynamics is how drugs act on the human body, or the action of drugs on the human body when treatment is done. Pharmacodynamics. Pharmacokinetics is the action of the human body on the drugs, how the human body acts on the drugs once they have been taken. So it is important to understand those two concepts as we are moving on. We have so many drugs that we use, ranging from antibiotics, antihelminthes that was talked about, antiprotozoals, and of course, antihypertensives, the ones that we use for management of diabetes or diabetic drug management. I will focus in different drugs accordingly, and we'll be able to understand them based on the nutrients. So let's move to the next. What I would want to let you know is that a number of nutrients that come from foods will always be able to interact with drugs in the clinical setting. Literally all drugs interact with foods in the clinical setting. There are some of them that I've actually mentioned specifically in my notes, but I want, as you will take my notes later, I want us just to get into normal talking in our clinical area and use the common drugs to be able to understand. And I will specifically pick on some of the common drugs that we use in the clinical area, not all. And some of the antibiotics that I want to pick as an example is a group of drugs which is referred to as the cephalosporins, if you allow me to use that. Cephalosporin drugs are antibiotics that we use in the management, for example, of typhoid. And some of the examples of the cephalosporin drugs include the following: ciprofloxacin, norfloxacin are some of the drugs that you will find are being used in the management of various bacterial infections in the hospital. The others include Septrin, which you always use in the hospital. And if you go into your basic pharmacology, Septrin is actually classified under something called bacteriostatic drug. Now, why I'm mentioning them is that some of those cephalosporins, the ones that I've mentioned, particularly ciprofloxacin, will interfere with the metabolic process of iron, and particularly affecting the erythropoietic process. So you will realize that medically, doctors are aware that those drugs are not supposed to be prescribed for children who are too young, especially below 13 years, because they have an impact on the megakaryocytes and will be able to influence or completely deter the manufacturing of red blood cells or metabolism of both folic acid and iron in the human body. So that drug, whenever it is prescribed, you must be able to check. And of course, it cannot be supplemented together with iron if there was also a concomitant iron deficiency, because it will affect. That's just one drug. I want to bring you, for example, to a drug, and the notes you will use. Don't care about the notes. I will give drugs as we use them in the hospital. Some of the drugs, for example, the drugs that we use for blood thinners, and I will be able to mention the specific drug, in this case, heparin or acetylsalicylic acid. When you get patients have been prescribed on a blood thinner, and an example is heparin or acetylsalicylic acid or any other blood thinner for that matter. And acetylsalicylic acid is just ASA or aspirin, which you use in the hospital. It will come in different forms in ASCAD. There are specific foods that will complement that effect, which we call the blood thinning effect. And some of those foods are as follows: tomatoes, garlic, and onions. And in some situation, you can use ginseng or gimsomin. Gimsomin comes into our hospital in form of capsules, so you will get a supplement. It's a food supplement. So those foods that I've mentioned have in them chemicals that are very similar to blood thinners. And therefore, when somebody is mainly predisposed to thrombus, or somebody suffering from DVT or deep venous thrombosis, or any stroke for that matter, somebody who has suffered a thrombotic stroke will always be prescribed on the drugs I've mentioned. Now, when such drugs I've mentioned, then a clinical nutritionist need to urge the use of those foods I've mentioned, the use of onions, tomatoes, or garlic, or ginseng, to be able to complement the blood thinning effect of the drugs that shall have been prescribed, and I've mentioned them. There are other nutrients that will also interact with some other antibiotics. For example, I will still bring in another antibiotic called tetracycline, and sometimes even amoxicillin. And even the anti-TB, like rifampicin, and you can list them. Rifampicin is mainly used in TB, or even it can also be used in the treatment of brucellosis. These drugs I've mentioned have a problem with free calcium. So any food that is rich in calcium that is free will actually interact with them. So it will always be recommended that during the use of these drugs, then milk as a product or as a food should be discontinued or contraindicated for that matter. The reason is the calcium in milk will chelate with the components of doxycycline or tetracycline or even rifampicin and cause it not to work. So the good thing is that pharmacists know this, but I think nutritionists need to understand this even deeper. That when such drugs are prescribed, you are supposed to stop using, for example, milk in that matter. I will still push you to some other drugs that we have in the facility. And one of them, which is critical for me, in this case, because it is affecting the heart use or the heart rate, is called digoxin as a component. It's also one of the things you'll find in my notes, in as much as I've done some depletion there. Digoxin is a drug that is used in the management of heart condition. If I can simplify it, when somebody has a failing heart, or the heart is failing to do the pumping, then one of the drugs that will be prescribed is called digoxin. Now, when you go to the clinical area and a digoxin is prescribed, then for a nutritionist, all foods that are rich in phytates must be discontinued. And a number of them will be found, for example, in wheat products, all wheat products, not just phytates only, but even gluten. So if you continue providing a diet rich in gluten and phytates to a patient who is already on digoxin, you cause a problem. The problem is the digoxin will be depotentiated, which means it will not do the work it is supposed to do because of interactions. And therefore, the patient will take longer time to be able to recover from failing of the heart. So what do we advise is that whenever a patient is prescribed on digoxin, then one of the key things as a clinical nutritionist is to advise on to advise patients to stop the use of all wheat products, for that matter. And wheat products means breads, mandazis, chapatis, and everything around wheat, including biscuits. Now, this, if you go to a hospital setting, does not happen. And for sure, I know even doctors don't understand this concept. So it's a concept that needs to go deep into our practitioners, especially in those working in the medical wards under these conditions. There are others that have been, you can move ahead. I think I've talked about those chelations, the CoQ10, these are available in our hospitals. I will still bring in the other components, including, okay, the adramycin is there. Those ones I've already talked because they will be able to use. Now, the other one I want to bring in is the use of thiazide. Just before, we have some antihypertensives. And I will bring you antihypertensives, particularly the diuretics. One of the diuretics that we use, actually there are two different types of diuretics. Let me begin with Lasix or furosemide in that aspect. Lasix is mainly used for antihypertensive to be able to reduce the flowing volume. Now, one of the reasons that we will be able to advise that when somebody is using Lasix, please do not use added sodium chloride is because, again, added sodium chloride, that is the table salt, when you add it on the food, it will be able to, again, depotentiate the Lasix. That is the reason. Not that sodium chloride causes hypertension, but it is because the sodium chloride will be depotentiate the Lasix. Again, you have seen there, I've also indicated that is a loop diuretic. It will increase, as you've seen there, loop diuretic, which is Lasix, the one you have in the hospital. It increases the excretion of potassium, excretion of calcium, excretion of magnesium, zinc, vitamin B1, B6, vitamin C. And therefore, there may be need even to be able to correct the deficits of those vitamins. Vitamin B6 pyridoxine is a big problem for the loop diuretics. I'd already talked about cephalosporins and the way they deplete, particularly the vitamin K, and they may cause hemorrhage for these patients. So usually, children who are below 12 years, as I said before, should not be prescribed on cephalosporins, especially parenteral cephalosporins. And I told you the drugs that fall in this group include ciprofloxacin, norfloxacin, and even nalidixic acid falls under that group. There is something there called steroids. Some of the drugs that fall in this group called steroids include prednisolone, which you find in the hospitals. Sorry. The prednisolone will cause depletion of mainly calcium and magnesium. And most patients who have used these steroids over a long period of time develop what we refer to as osteoporosis and osteomalacia, weak bones. And it becomes a big problem. So usually we don't recommend, from the nutrition perspective, the longer time use of this, but particularly of the steroids, especially steroid-based anti-inflammatory, and I've said prednisolone being one of them. Now, the other drug or nutrient depletion or antiretroviral nutrient depletion, you will be able to see AZT, for example, deplete the muscle carnitine. And you realized this carnitine, usually when it was being discussed at the initial stages by our Dr. Anastasia, who talked about its measurements, it's an indication when you realize that the carnitine is affected, it's an indication of low immunity. It increases the lymph apoptosis, and clinically lymph apoptosis, you will be able to see it by the deposits of fats under the skin. It's fairly easy. When somebody you see from far, you will see some white deposits under the skin. That's called the lymphocyte apoptosis, and it's basically fat deposits under the skin, and that can be usually be recovered by some levels of supplementation, which we are going to provide. Again, AZT is associated with the decreased serum of zinc, copper, but you can be able to reverse that by supplementing zinc at that rate that I've indicated, 200 milligrams per day, or be able to even help in reducing the amount of candidiasis, especially for the ISS or those whose immune system have gone down as a result of HIV. Candida albicans can greatly influence or even the food intake when those drugs are affected. The other one, which I have to talk about because these are common drugs, I said I'm picking on common drugs, is some barbiturates. And I'm picked on one barbiturate there called phenytoin. Phenytoin is a drug that is mainly used for patients who are suffering from tonic-clonic epileptic seizures. And phenytoin may deplete particularly biotin, folic acid, and even thiamine and vitamin D. And they may end up causing something called hypokalemia and osteomalacia, and vitamin K. So what we are trying to say is that, and it's not just phenytoin, other barbiturates include phenobarbital. So phenobarbital, phenytoin, and hepanutin will fall under that group, and they will affect the memory of the patients who are using them over a long period of time. So clinically, you will find that most of those patients lose the ability to remember certain facts. So that can always be reversed by actually supplementing those vitamins. So when patients are on those drugs, barbiturates, phenytoin, phenobarbital, and hepanutin, then you will need to supplement vitamin K, vitamin D, and even folic acid and biotin. This is not happening in our hospitals. So it is something that you need to pick up. I'm pretty sure. The ones that are not happening in our hospitals, this is new knowledge for them, but should not be new knowledge for nutritionists. Let's move to the next. I'm through with barbiturates. The valproic acid depletion, these are very important. Valproate has been used in cancer management, and valproate, just like the other drugs that I talked about, also deplete carnitine, and therefore you can reverse whenever you are using valproic acid as a drug, then you need to supplement carnitine at 2 grams per day. That should be happening, but above that, you also need to know that valproic acid also lowers the folic acid, and therefore raising the phosphoric, and has a problem with the homocysteine. So if you want to reverse this, then again, whenever you are using valproic acid, please do supplement folic acid, vitamin B6, and vitamin B2. The others we have done. Let's move to the next. I think chelation I had already talked about, but I want to talk about this chelation bit. I talked about it at the antibiotic level. The component that I want to talk about here is the antihypertensives, and specifically focusing on angiotensin converting enzyme inhibitors. And one of the drug that's affected there is the, other than the quinolone, some of the angiotensin, very nice drugs. That is nifedipine. Now, one of the ACE inhibitors, I will get an example of that, levodopa, L-dopa. Levodopa, and of course, the antibiotics that I've mentioned there, and I'll talk about like tetracycline, doxycycline, they have a chelation effect on the absorption of particular nutrients. And one of the nutrients in this case is calcium, as I said before. And whenever you're using these drugs, you will need to window if you have to use them, because those things cannot be able to work together. If you are supplementing calcium, you'll have to window within 2 hours of supplementation of calcium. 2 hours after the drug, or 6 hours before the drug, you need to have already provided calcium. Now, this will also even affect iron supplementation. One of the key problems we have had, for example, with our IFAS in our hospitals, is because IFAS sometimes has been provided without instruction that IFAS need to be taken in an empty stomach. So most of the patients, once they leave the IFAS, with the IFAS from the hospital, they go, and a number of them will take IFAS together with tea. And especially for those of us who come from Western, we know our ladies, and because mostly our ladies are the ones who are being given IFAS, especially from the Maragoli side, They love tea. And you cannot do anything to separate them from tea. But whenever that happens, one of the affected nutrient, there will be the chelation that will come in. So during that time, they need to be told that some of those drugs need to be taken in an empty stomach. Let's move to the next, other than that chelation and absorption. Okay, I didn't want to take you through this science of cytochrome P450 system, drug supplement, but one key thing that I want to raise about cytochrome P450 system in overall, which I want everybody, forget about the science that you see there on the CYP250. The CYP250 is found in 4 major areas in the human body: in the stomach, in the intestines or gut, in the liver, and in the lungs. Now, those sites within which cytochrome P450 systems are found are actually the sites of drug interaction. Now, one of the key foods that you need to be careful of, just move down, in this, and which I want to raise, because I told you I'm talking about food and nutrient. The food that you need to be careful of is called, it's a fruit which we buy. I'm just forgetting the name. Maybe somebody can remind me. Kudo, can you remind me of this fruit that we find in all supermarkets? And small fruit. I'm just forgetting the fruit, but I have to get it. Yeah? Not apples. Small ones. Yeah? Grape, yes. You have reminded me. Thank you very much. Grapefruits. Grapefruits is one of those fruits that need to be contraindicated in all hospital admissions. And the reason why I have to put this very clearly is that grapefruits are acting as the CYP450 system. So all the sites with the CYP450 system will always have grapefruit interaction, which means grapefruit interact with all the drugs. So again, this is another information that need to go deep with all doctors and all practitioners in the clinical area, that all admissions with either polypharmacy or drugs are being administered should stop giving grapefruit, because definitely it will interact with all the drugs, because all the drugs are run through that CYP450 system. So that is one information that I want to pull on that. Let's move down, bypass that science bit of CYP450. Just go down, go past that. Go past CYP. I've already finished that. Go past that. Okay. Yeah, go ahead. Go ahead. I don't want that science. Just go ahead. Okay. Okay. I think those ones have already been done. Antibiotics interactions, we have done them. The aspirin, I've done that. Aspirin, I think I've already done. And vitamin E interactions. Warfarin interactions, I've done that. It seems I've covered everything. Yes, the beneficial drug interactions, I think I've already mentioned about warfarin. But the other component that you need to know is that the fish oil or eating of fish and the issue of inflammation. For those people who are suffering from inflammation, and inflammation are characterized by many things. Any fluid within our peritoneum or pericardial effusion, or even the lung effusions, what we call the in between the lungs and the walls of the lungs. Any effusion, for that matter, is a reflection of inflammation. So whenever there is an effusion and reflects inflammation, then encourage those patients to either use the fatty acids, particularly eicosapentaenoic acid and eicosahexanoic acid, mainly from fish, to be able to enhance the anti-inflammatory effect of those drugs. And some of the anti-inflammatory effect, whenever somebody uses prednisone, for example, which is steroid-based, or any non-steroidal anti-inflammatory drug, like brufen, acetaminophen, which was talked about, or diclofenac, for that matter, then these drugs actually are going to help those patients regain the anti-inflammatory effect. Let's move on to the next. And many others that I'm not able to. I've talked about acetaminophen and its toxicity. That is non-steroidal anti-inflammatory drugs and side effects. You don't need that. We have talked about it. Move up. Okay. Cisplatin toxicity. These are anti-cancer drugs. Again, very similar to valproic acid. Okay. Fish oils, non-steroidal inflammatory drugs, and ASA, I've already discussed it. I've just said very clearly that some of the very important foods that is going to help on that are basically fish oil, particularly with the DHA. And so in conclusion, as clinical nutritionists, let's know that all the drugs that is used in the healthcare facility have capacity to be able to deplete nutrients. And there are specific foods that will also be able to deplete nutrients if taken, the ones that I've mentioned particularly, if you take them with those drugs. So as nutritionists, I would want to urge all of us to be able to use the beneficial drug supplement interactions to be able to complement drug use in our hospital systems, and that will be able to help us help our patient have shorter stay in the hospitals and avoid those foods that have adverse reactions. And some of them you'll even be able to see, and mostly patients will be able to present clinically. Please avoid and let them know the relevant drugs to avoid, the relevant foods to avoid when using specific drugs, and then reintroduce them later. Otherwise, thank you very much, and I will be ready for questioning, I think, on this drug, nutritional pharmacology in clinical use. Thank you very much. Questions? Are there questions? Yes.
Yes, good morning.
Thank you, everyone. We are at the question and answer session. This will be taken through by Mr. Maingi Zadok. Mr. Maingi Zadok, there are questions that are on the chat box. The first one, as he's preparing to take us through the question, was, is there a difference between grapefruit and grapes?
This is just this agronomic question. But nutritionally, they may not be different. Agronomically, they may be different. Just like asking me, in food groups, or at body level, at the gastrointestinal tract, the body decodes all foods into nutrients and their phytochemicals, relevant phytochemicals. So when you are talking about drug-nutrient interaction at the blood level or even at the gastrointestinal, the CYP450 system, they may not be different unless you are asking agronomologically. If it is agronomic or agricultural, then they vary. But at the level of CYP 2450 system, at the gut, at the blood level, at the cell level, they are not different. They're the same.
Yes, thank you so much, Professor Nguka. There is another question from Shivon Otieno.
Read it, Mike.
Yeah, Shivon Otieno is asking, what about patients on dialysis? Should they stop taking grips?
Yes. I've said very clearly, and I take it from me, any person using any drug, grapes get or affects the CYP 2450 system. And it happens that the CYP 450 system is the only system that actually do the pharmacokinetics of drugs. So what I've indicated is that all hospitals, all, should contraindicate grapefruits because it will definitely interact with the drugs. And this needs to go very deeply because I know doctors don't know this. Nutrition must take charge of this matter. I've seen it, it shocks me. I've participated in hospital inspections and I still get this. And this is today is an opportunity for nutritionists to pick this matter up properly. So whether kidney patients, all patients during treatment should avoid grapefruits, and especially during pharmacotherapy.
Yeah, thank you, Prof. I think you have answered that question. There's also a comment from Mercy Chepngeno on the same. She's saying a patient on dialysis should take grapes, not grapefruits. What's your take on that, Prof?
I'm wondering, are they differing phytochemically or nutrients? As I said before, maybe I may not know agronomologically. I need to know the difference between those. Maybe somebody who is very conversant agronomologically with those. But if they fall under the family of the grape fruits, for that matter, maybe grape is, I don't know whether grape is the same as dates. I'm not very sure. But so long as it is grape fruit I've talked about, just know that it will not be very different at nutrient level. That is in the GIT and at the blood level. The chemicals will be the same and we will have the same problem. I'm wondering whether you have data on the variations by FIFA-YU. Let's avoid grape. I don't know whether grapefruits are the same as grape. Somebody needs to answer that question for me, agronologically. But if they're falling under the same group, please avoid. My take is avoid. This we have done practically, avoid those because they will interfere with the drugs. The patient will take longer in terms of therapy, whichever the patient who are using drugs, because all drugs that we are given to patients go through the cytochrome P450 system. And that is the reason why grape is being contraindicated. It's the only food that we are contraindicating during treatment. You need to read deeply on that. Okay? Are we agreeing with that individual? Maybe we can consult later. Or you can call me in that hospital and I take you through the reasons why you must avoid, whether it is grape or grapefruit, I think it should be avoided. Go ahead, Mike, if there is any additional question. Okay. Mike,
Prof, maybe, Prof, Prof, maybe You are correct. Grapefruit fruit needs to be avoided, but there's a difference between grapes and grapefruit. Grapefruit is about, it's bigger. It looks like oranges.
Oh,
I think that's what
I don't know.
Yes, but now it is the one that needs to be contraindicated, but the grapes are okay. The grapes are the smaller ones. The bigger one is the grapefruit, the orange type.
Okay, okay.
So, and it is correct that grapefruit must be contraindicated when it comes to the nutrient-drug interactions here, or food-drug interactions. Yeah. Mm.
Yeah. So we have, I've talked about grapefruit.
Yes.
So maybe not grapes.
You are correct, but not the type. Yeah. No, that's agriculture now.
Okay.
Okay.
Any other additional questions?
Thank you, Prof.
Okay.
Thank you, Prof. There's another comment and question from Suzanne Miriti. She's saying that the session was very educative and saying that it's unfortunate that unless one probes and many times it's later on, there's no way to know drugs the patient is on. How can pharmacy services and nutrition office bond be strengthened?
It's already being in most of the hospital institutions. It seems it's already being strengthened. I've again participated in this through inspections, and I've seen most nutrition departments and pharmacists have come together. But the most important is not even at that level. We want nutritionists to form part of the clinical team. Prescription is being done in the wards, not as at pharmacy. And whenever prescription is done, that is the point where the nutritionist at ward rounds or during their own checks need to identify which drug has been prescribed for that patient and advise accordingly. So my take is nutritionists need to take charge of the facility.
Prof, can I assist there?
Yes.
Now, Prof, thank you very much for bringing out the knowledge of nutrition pharmacology, which is a core unit we have prescribed in our core curricular guideline. You know that we struggle to put it as a core unit. The reason why our nutritionists cannot do well when it comes to advisory on matters of food interaction, food-drug interaction, and nutrients-food interaction, or nutrient-nutrient interaction, is because we have literally refused to study the terminologies used in drug-nutrient interaction, particularly nutrition pharmacology, and linking them up with the drugs. So it is high time now, as nutritionists, we must study the drugs so that when we are part of the frontline therapeutic team handling patients, when a doctor makes a prescription, you look at the lens of its interaction with the nutrients or the food. So please, this is a challenge we are bringing out this so that we can consult. At the same time, we can get enlightened and we start to read on matters of food-drug interaction and nutrient-drug interaction so that you can actually advise the medical doctor appropriately when it comes to prescription of drugs and on matters of contraindications. So this is an area that I would just say that in the frontline therapeutic team, we are going to make sure that we keep on drumming nutrition pharmacology in every aspect of our service delivery, even on matters of CPD. I think that's what I wanted to say. Yeah.
In addition, I want to give you an example, for example, on treatment of those who are suffering from epilepsy. Those who are suffering from tonic-clonic epilepsy, and there are so many in this country, they have been booked under what we call the medical outpatient clinic. And they visit those clinics every month to be able to pick up drugs. The drugs they are being given are called barbiturates. And I mentioned examples of barbiturates: phenytoin, phenobarbital, hepanutin. Most of these drugs will be given to them for a period of a month and they go back. Over a period of time, these drugs will deplete vitamin K, folic acid, vitamin D. Now you go to our hospitals, all folic acids have been restricted to MCH. And they are leaving these patients without supplementation of folic acid. Within a month or two, these patients then begin to lose memory. They come back, they are unable, kilipungwani kidogo, and then over years, those guys are not able to think anymore. They forget, and they become now not the people you would want to be because of just lack of supplement. This information, I can assure you, doctors don't have. And I want to request nutritionists, pick this component. Begin even with just tonic-clonic epileptic seizures. Get to that clinic, tell them you have now prescribed the barbiturates. Please supplement vitamin C. Or as a nutritionist, go ahead and supplement. So that all patients who are, just like we are dealing with TB, I've said, TB, for example, you cannot use anti-TB like rifampicin, which is an antibiotic, streptomycin, which is an antibiotic, and it's called what? Not zidovudin. Streptomycin, rifampicin, and which other drug? Isoniazid. These drugs are antibiotics used for TB, and we know very well that whenever you use these drugs, they increase the loss of pyridoxine. I'm very happy that that has been integrated. At least for anti-TB, there will be a concomitant supplementation of vitamin B6. Now, that is what we want. Even in malaria, how do you manage malaria? And we know sometimes, especially, but again, this one doctors at least understand, especially the use of quinine, for example. We know very well that quinine will actually lower the blood sugar automatically. So that whenever somebody takes quinine, then the first thing you need to do is that this person should have already taken a base diet, food that is rich in glucose, that's going to raise the blood glucose enough to be able to sustain the level of quinine. If somebody was injected quinine, IM, or given quinine tablets in an empty stomach, you can be sure that person will go down on hypoglycemia. So you can see that, yes.
Now that you still have time,
yeah.
I think what is coming out very well, and the nutritionist needs to know this, and even other health cadres, you know, the prescription of a medical physician or a consultant is very specific with drug sensitivity, but there is very limited nutrient sensitivity.
Yes, very true.
Now, what a nutritionist needs to know is that for every intervention given as a drug in terms of, let's say, antibiotics, there is equivalent treatment on nutrition when it comes to supplementation. Yes,
Correct.
Antibiotics are good because we are targeting bacteria to kill, but killing bacteria is not treatment. It's actually scavenging bacteria, but leaving the disease or the causing factor of that disease still in the body. For example, if your immunity goes down, you need supplementation to boost your immunity before you apply any antibiotics. But what do we do as physicians? They have prescribed for us the antibiotics, and once they do that, their work stops there. Nobody is very sensitive on the negative effect of antibiotics that would require reconstruction. For example, antibiotics interfere with the gut system, but who will tell people that as you take antibiotics, also remember that you need to replenish with the probiotics, for example?
Yes, yeah.
So no one is coming strongly from the nutrition side, and so we end up giving antibiotics and killing patients who would have survived if we only balance these two parallel people. And that is why probably you'll notice that most, and I'm sorry for the medical doctors that are present, most medical doctors don't agree with nutrition interventions. And so it is high time now we position so that we can balance the whole process, curative, from the physician perspective, and nutritionists also must come strongly from their own perspective on how they can balance the two. Then we will be in the frontline aspect with that kind of lens. And so we have to study.
I agree.
Yeah.
And we must read far and wide. Are there any questions? Maybe as I add this, on top of what Dr. Keo said, have we ever known the cause, for example, of the growth of yeast on the mouth, sometimes throughout the gut? When there is overuse of antibiotic, it kills the commensals, which gut microbiota, which Dr. Keo has talked about. And that again shifts the entire pH to alkalinity in the gut. And that creates a very good condition for the growth of fungi, Candida, for example, Candida albicans. And it can grow everywhere, in every space, then affecting nutrients. Now, when we use, for example, slightly acidic foods to be able to shift that alkalinic part of our gut back to acidity, then you will see, even if you are using antifungals like Niserol, like Diflucan, like Crucifulvin, like Nystatin, the best is actually to be able to also shift the acidity of that guts for them to, and I'm very sure this one nutritionists who are in CCC have used very well. This one they have used very well to be able to manage such conditions. And that is whatever has been integrated in the CCC should be integrated deeply in the medical wards. Because that is where I think in the medical wards, there's been a little bit of laxity in the problem. CCC has done very well, especially in this country, by integrating, but medical ward, we still have a problem. And I mentioned one key drug, particularly the digoxin bit of it, which is being used. And in the same ward you get, people are still taking mkate. In fact, they are being given the first thing in the morning is bread and tea. And you have prescribed this patient on digoxin. When do you expect this patient to get out of the ward? Surely. Atakaa hapo forever. And you know, for the hospital, that is benefit for them. The longer you stay there, the more NHIF. So you can be sure there'll be working mechanisms to have you stay there so that they can get more money, especially for the private hospitals. I'm sorry to say that. But that is the reality. If nutritionists do their work well and are much informed about drug-nutrient interaction, we will reduce the hospital stay. And therefore, we will even reduce the amount of money these guys are spending on medication.
Even when it comes to, Prof, just as a rejoinder, even when it comes to disability adjusted life years,
yes,
it is the nutrition that is a solution to most of the problems we have in the curative, in the clinical settings. So if we don't take our positions as nutritionists and we understand the language of a physician, because they have been taken through the drug index, so they understand, nutritionists must also have the drug index as their pocket book,
yes,
so that they can now look at, relate it with the nutrients. Yes.
In fact, I expect all nutritionists to have the drug index, particularly the East African pharmacopoeias, so that you are aware of all the drugs that are in the East African community and particularly Kenya. Yeah, that one is important. Any question? Yes.
Yeah.
Go ahead.
Yeah. Thank you, Professor Nguka. Thank you, Professor Nguka and Dr. Keo, for responding to the questions. There are more questions in the chat and comments. There's a comment from Stephen Oyugi, who is saying that they totally agree with you on grapes and drug use. Grapes is no for patients on medication. Another participant named JM says that grapefruit or grapefruit juice inhibits the cytochrome 3A4 system, which is essential in the metabolism, in the phase 1 metabolism of dietary compounds. There's also another comment from Kaguda Nutrition, who is asking if there is any published research to support your condemnation of grapes on medication. I think this has been responded to, because I can see several articles shared in the chat box on the same. There is a question from Dr. Maureen Cheserek, who is asking if we have a national guideline guiding the use of food and nutrient supplements in our hospitals.
Yeah, unfortunately, we only have that clinical manual. It has not been properly I don't know whether it has been published. The one that was worked on.
No. The clinical manual is not published, but I think what Dr. Chesarek is raising is very important. We are the professionals. We have seen the gap. Let us do one.
Yeah.
You know,
we don't have one.
KNDI is supposed to develop all guidelines. The service providers are supposed to use the guidelines. It is the other way around now. But we are picking up this. This is a matter we have picked up already. That any guideline developed either by a third party or the one that is developed by the professionals has to be okayed by KNDI. So we can either delegate or we do it ourselves. So if we realize we don't have any guideline, we can do that, or we can initiate its development, even in the ministry, for that matter. But we have to spearhead the whole process. Yeah, we don't have.
I agree with you. I agree with you, Dr. Keo, and Dr. Cesarek. I think we have to come up with this because, as I've said, not all drugs have been dealt with properly. We need to generate a document as per the pharmacopoeias of Kenya, or the common drugs that are used in Kenya in most of our hospitals, and get their drug-nutrient interaction and give proper guideline. Because as I've told you, I've personally witnessed some doctors, or even most doctors, sometimes are not in tandem with when they prescribe those drugs, they don't give the relevant nutritional information, apart from the most common ones. The ones that I've mentioned, and I've mentioned one in particular, barbiturates. No doctor, no clinician has ever tackled that barbiturates bit accordingly. And I can tell you that they have been given raw deal to the patients because they give them drug, and they have not taken care of the folic acid, which is depleted, vitamin K, which is depleted, and even vitamin D, plus very many others. The ones that I mentioned before in the CoQ10, including others that are being depleted, of course, by other drugs. Valproic acid is serious. We have just doing some research with cancer patients, and a lot of nutrients are being depleted when you're on cancer therapy. Nobody takes care of them. They just give general guidelines. So I agree that we need to do our own guidelines properly. Yes. Maingi?
Thank you, Professor Nguka. There is another question from Jacqueline Ogomo. She's asking, is it okay to recommend cod liver oil for patients with cardiovascular diseases?
Oh, yes. Cod liver oil is okay. You know, cod liver oil basically contains docosahexaenoic acid, icosapentaenoic acid, and
the EPA.
Generally what we call the high density lipoproteins, whose
they're essential.
They are not
essential fatty acids
or aggravating the problem. They are actually helping. So they actually work very well, even with antihypertensives and any inflammation that can come as a result. I told you that those who have hypertension sometimes will develop clinical symptoms of what we call cardiomegaly, mainly associated with that what we call enlargement of the heart, associated with the pericardial effusion, depending on the underlying causes. Now, when you use this cod liver oil, or it will help, just like I said before, it will help in reducing those inflammations, but also helping in reducing even the plaques that could be within the cardiovascular system. They will remove them, or it will help in reducing its atherosclerosis, for that matter. So it's okay.
Prof, my question to you now, as a professor who understands both the field of clinical medicine and nutrition, is it not in order that we have to bring all these doctors and teach the nutrition pharmacology to appreciate that fact, and then empower our nutritionists to be at the front line when it comes to decision making?
Yeah, it is something that I've tried to do with our clinicians at the hospital in Kakamega, but now we can bring, and a number of them have appreciated, the ones that have taken through have appreciated this, but now we can bring all of them, even countrywide. I just recently presented in a medical doctors conference, which was based in Kisumu, and they all appreciated the nutrition deficiencies related to diseases and how the role is critical. And a number of them were actually urging us to continuously educate them, especially the continuous nutrition education, to be part of this. So it is something that I think is viable. The doctors
So maybe
need
I
this.
can ask the professionals themselves. Yeah. What if we decide now as KNDI to make nutrition pharmacology a mandatory CPD nationwide for all nutritionists working in a clinical setting, so that we can drum this and also gain this knowledge to empower ourselves, because knowledge is power. What if we make it a mandatory national CPD for clinical nutritionists? Because you cannot appear in the world rounds and you want to run away because of just a terminology. If you are empowered, you'll stand there and tell the medical doctor or physician or consultant that what you're prescribing, I would want to give you a better approach on how we can deal with it alongside the nutrients. And they will listen to you only if you are empowered. What if we make it a mandatory national CPD? And I'm talking like this because some of the students approached us and said, we need knowledge in nutrition pharmacology because we feel inadequate when we go for our internship, just because we did not understand it well. And it's simply because probably they were not taught well nutrition pharmacology, because it is different from general pharmacology that a pharmacist would teach. So we need to look at that as part of the resolutions in this conference, that we make nutrition pharmacology a mandatory CPD for nutritionists who are intending to work in curative areas. Yeah, that's my thinking. Now as a professional, not as a CEO.
I hope they can give those comments so that we can see. If that's okay, then we continuously have this so that we are able. And you know, molecules are being developed on a day-to-day basis. And part of the clinical trials is to be able to see how those interactions go on, so that during treatment, we are able to get the best out of that treatment. Like I said, there's also complementary. You know, some drugs interact with nutrients, but in a complementary manner. And I mentioned one big example is the ginseng, tomatoes, onions, and garlic with heparin, the one that does the blood thinning, or the anticoagulants. When some of the anticoagulants, heparin being one of them, is even acetyl salicylic acid, which is aspirin, and the other anticoagulants. So you can see for such kind of patients, and some of these patients, for example, the ones who are suffering from sickle cell, all sicklers are highly predisposed to vasoocclusion as a result of a thrombus, or anybody who's suffering from deep venous thrombosis. Any dislodging of that thrombus to any other part of the body will cause a problem, and especially if it goes to the heart or even to the brains. So when somebody is prescribed on those drugs, then to complement, you can now add that kind of diet. And it only happens when you know it, because it's not guesswork. Just like medicine, it's not guesswork. You will have to know it and have it at your fingertips, so that you give, very accurate and timely information to the medical doctors. Because you have prescribed this drug, let's stop this food going forward. Like what I've mentioned about the digoxin. You have prescribed the digoxin. Can we now be able to stop all wheat products from this patient until after the digoxin has been used? You have prescribed, for example, you are supplementing maybe folic acid and iron. Can we stop tea intake or any caffeine-containing substances? This patient is in the ward. Can we stop grapefruit? And you'll agree with me that this information is not with all doctors. Some of them are with, like the issue of supplementing vitamin B6. That is okay. And especially only in TB. That is what they think. but they don't know vitamin B6 is also required elsewhere. Folic acid is being given in MCH. They are forgetting our epileptic patients. It has not been included as a protocol. So these are critical things that will be able, and many, many other drugs. I've not mentioned all of them. If you look at our pharmacopoeias, we have over 900 thousands of molecules. Yes. Maingi?
Yeah, thank you, Prof, for responding to the question. There's another question from Edna Warento. She's appreciating you for the presentation, and she's requesting if you can clarify on the first point in your conclusion. Did you mean most drugs used in the US or in hospitals?
Kenya, not in hospitals. Most of the drugs in the hospitals. I think I put it. Yeah, in the hospitals in Kenya. In our first, if you look at our first, isn't it?
Okay, thank you. I think that is clear. Then Siobhan Otieno is requesting if we can help with best fruits for dialysis patients.
Or for dialysis patients. Dialysis,
Yes,
at least their diets are known. The most important about patients who are on dialysis is to avoid foods that are rich in potassium. The only fruit that have actually against, but for dialysis patient, bananas, and of course we have just talked about grapefruit, are supposed to be avoided. Other fruits can be taken, but with a lot of moderation. And of course, Banis had already said that in a clinical area, you must be able to check on the individual patients. So some patients would have a problem, for example, with oranges, but others also don't have. You'll also have some patients have a problem, for example, with mangoes, but others don't have. So it will be to be able to monitor these patients. Fruits are very difficult to deal with, especially for the renal patients, end-stage renal disease. They are required, yet you really need to monitor the patient's reaction. So there is no blanket for the kidney patients. As a clinical nutritionist, each patient will come with different reactions, and you need to watch that. Some of them will accept the fruits I've mentioned. The others will not. But so long as you have avoided fruits and tubers rich in potassium. In fact, all tubers are contraindicated for the patients with kidney because they are still rich in potassium. And I've just mentioned bananas. You may not be able to use bananas and all other fruits that are higher in potassium levels, because usually there will be a problem. Potassium is usually retained a lot in patients with kidney issues.
So maybe, Prof, I need to clarify something.
Yes.
I've seen, maybe people are wondering, our professionals are wondering whether nutrition pharmacology is taught in at the university or at the college level. Yes. Nutrition pharmacology is a co-course. We have general pharmacology and nutrition pharmacology. The only problem we have had with the nutrition pharmacology is that some institutions tend to bring pharmacists to teach it, and they have taught wrong things. Before I discovered that Professor Nguka had some good knowledge in pharmacology combined with clinical medicine, I used to give, as a head of department, a pharmacist to teach nutrition pharmacology. And they taught literally off what was prescribed. So the student came out with nothing. But now that we have expertise, we only need to strengthen the process so that we teach. We have even a guideline for teaching nutrition pharmacology. The same applies to human anatomy and physiology for nutritionists. It's totally different from the general gross anatomy and physiology for medical doctor. So nutrition pharmacology is a core unit prescribed. We only need to now expand it beyond the pre-service training so that even those in practice can have it as a CPD to build their knowledge. Because I think for me, that is what is important. Yeah.
Yeah. Thank you very much, Dr. Keyo. Maingi, is there any last one?
Yeah, thank you. Thank you, Prof. Nguka and Dr. Keyo. There is a comment from Lavenda Mwanzo. She's saying that you comment something on NSAIDs and nutrient interactions, as these drugs are commonly abused, misused, and self-administered by individuals.
NSAIDs, that is non-steroidal anti-inflammatory drugs. And I said very clearly, these drugs include brufen, paracetamol, even acetylsalicylic acid, acetaminophen, and the other non-steroidal anti-inflammatory drugs. They're usually abused, very true, because they are mainly used for pain control. We call them analgesia. They actually play three major roles: analgesic, anti-inflammatory, and antipyrexia. Antipyrexia means fever. So, but for acetylsalicylic acid, it also goes into anticoagulants. So acetylsalicylic acid has additional function other than the three. It is critical that they don't get abused. One, those NSAIDs are very irritative. They actually corrode our gut. So when you use them for a long period of time, you end up developing the corrosion on your gut, and it might lead to ulcers if you're not careful. The other thing is that some of them lower the lower esophageal sphincter pressure. Now, when the lower esophageal sphincter pressure is lowered, then you develop a problem with GERD, gastroesophageal reflux disease. So over a long period of time, then you will tend to have a problem with refluxes. And then what people call heartburn is actually slight burning of the esophagus as a result of reflux or flow back of the gastric content back to the esophagus. The other thing is that when you use all NSAIDs, the metabolic pathway of non-steroidal anti-inflammatory drugs is to block the formation of prostaglandins. As you are aware, the formation of prostaglandins metabolic pathway is from the arachidonic acid to end up forming the prostaglandins. Now, prostaglandins are responsible for sensing those that we've talked about. Fever, it is the one that senses headache, it is the ones that senses pain. So the NSAIDs target the metabolic pathway of cyclooxygenase 1 and cyclooxygenase 2, blocking that pathway of conversion of arachidonic acid into prostaglandins. When that happens over a long period of time, and you lose that metabolic pathway, you lose your ability to sense those important body functions, and it might affect you forever if you're not careful. So, and you might even affect the nutrition imbalance of arachidonic acid. So at the end of it all, it becomes a problem. So my take is that all non-steroidal anti-inflammatory drugs should not be taken beyond 3 days. Ikienda sana iende 5 days, but mostly 3 days, stop it. Or else you will face those consequences I've talked about.
Okay, thank you, Prof, for commenting on that. There are several comments regarding what Dr. Keyo has mentioned regarding the nutrition pharmacology being implemented in the curriculum. One comment is from Ra Boyenya, who is saying that it's a good concern and issue that is coming up on nutrition pharmacology in clinical setup, and therefore to address the gap, there's need to have harmonized training and guidelines to guide clinical nutritionists. This will not only boost their confidence, but standardize services. Dr. Cheserek has also commented on the same and supporting that perhaps this should start by training the lecturers and tutors on the same. Suzanne Miriti also agrees with the CEO, Dr. Okeyo, that most of the times nutritionists shy off from ward rounds and interactions with patients due to limited knowledge. And yet they should start training the trainers first on nutrition pharmacology. There's Ayura Edna, who is also seconding the aspect of nutrition pharmacology, and this and says that this should be implemented in the colleges and other learning institutions. There's a concern from Kaguda Nutrition, who is saying that contrary to your recommendation of cod liver oil supplements, research has found that most cod liver oil supplements are counterfeit, and asks why not recommend the home cooked fish.
Oh, okay. You know, when the difference, what you have said is actually the same thing. A counterfeit is not a cod liver oil. That's what I would like to say. When somebody has done that's fraud in the first place. But typical cod liver oil. So differentiate between products and counterfeit products. When somebody has a counterfeit or a product which is not cod liver oil, because I was not saying cod liver oil as a product, no. When you talk of a cod liver oil, is a cod liver oil from the fish. And I want to agree with him that fish actually constitute the best meal. But it reaches a point when somebody cannot even be able to retain certain foods, especially in the clinical area. And then you have to use, for example, specific lipids. And that's why I was very specific at the nutrient level, at the gut and at the blood level. We talk about EPA, eicosapentaenoic acid, docosahexaenoic acid. You know, those are the ones that you target. Of course, at food level, they will come in various forms, including the counterfeit. The counterfeit ones, I don't group them even at that. So we have actually agreed that cod liver oil, if it is genuine cod liver oil, will help, and it is not contraindicated in the management. But if it is counterfeit, that is not a cod liver oil. That needs to be actually acted upon by law. And I agree with you, there are many. There are many. So my advice is people should try to find the genuine ones, including going to take the cod liver fish directly from the fish. That will be better. So I agree with that.
Okay. Thank you so much, Prof. There's also another comment from Leonard de Kwam, who is supporting that the need for a national training, starting from the Ministry of Health, cascading downwards to counties. It's a comment of supporting the training on nutrition pharmacology, starting from Ministry of Health HQ as it can cascade downwards to counties. Then Dr. Maureen says that she observes there is a knowledge gap in nutrition biochemistry among practitioners. There's a question from Mercy Koech, who is asking about sensory science and nutrition. I'm not getting exactly the question, but she's asking about sensory science and nutrition.
Sensory, maybe sensing. I don't know whether internal body sensory or this.
There could also be food. There could be food also.
Food. Yes. Yeah, and in all that is using senses. For example, the taste, the smell. I think that's what they could be talking about, and the feel. Sensory science. You know, senses only work if they are proper nerve transmission. That's one.
Food, nutrition, and sensory science. That's what she's talking about.
Okay. So let me, Dr. Keo, you can come in, and then I will also come in with what I wanted to bring in.
You know, Prof, if you look at the way we have categorized subdomains of nutrition and dietetics, food science and nutrition is becoming a very, very critical area. And you know, when you talk about food science, the aspect of palatability and sensory evaluation is very critical. Now, this sensory evaluation, palatability, and matters of texture and issues surrounding the acceptability is a matter that needs to be also integrated in the clinical setting. And particularly when we are dealing with the enteral feeds and parenteral feeds, we require a strong background of sensual evaluation and also normal food. As at now, I want to tell you, I don't think there's any facility or hospital that is offering food for patients. We have people who are keeping patients in ward so that they don't die, but they don't offer food for patients. And this would require a lot of knowledge in food science because most patients that are fed, it is a common business of sukuma wiki, meat, and ugali. And it is a normal menu throughout. If you change it to another normal, ordinary meal, but they're not targeting patients. So that knowledge needs to come out very well. Food science must be brought on board and sensory aspect must also be brought on board. And that's why we were talking about the aspect of food service diet therapy, so that we can integrate that with food science and nutrition to help us in delivery of food.
Yeah. So that is on
it's
the
not
aspect
relevant.
of,
It was not really direct to this, but we have to bring it on board even on matters of on other aspects of integrated healthcare.
correct. And that is one. The other thing is that, people lose even tests during sickness and during use of drugs. There is something called hypogeusia and loss of tests or loss of ability to even smell. Now, those are related to nervous system. And sometimes disease conditions would inhibit, or sometimes the use of drugs would inhibit. Like I said before, we use non-steroidal anti-inflammatory drugs to block the conversion of arachidonic acid to prostaglandins. And therefore, that would make a patient automatically lose the sense of pain. Not that what is causing pain is gone. If it is malaria, it is still there. If it is antibiotics, bacteria, it is still there. If it is any pain, it is still there. But your body has been blocked from sensing that there is pain using those. Now, in a nutshell, if that happens, then there is an aspect that affects the nervous system and metabolic system, for that matter, that are responsible for such sensations and their transmission and interpretation in the brain. Therefore, to improve your sensory activities, even for those who are working at the chief liquorers, is to ensure that essential fatty acids are taken to sharpen those aspects. And even after treatment with these conditions, including non-steroidal anti-inflammatory drugs, it is important that what should follow that treatment, just like we talked about antibiotic, is to be able to have high levels of oleic acid, linoleic acid, and linolenic acid. Those three, oleic acid, linoleic acid, and linolenic acid. Those three are critical because they are important in myelination of the nerve sheath to be able to regenerate the ability to transmit sensual from the various sensory organs to the brain and interpretation. So that is one component. The other component is already talked about.
Prof, I think you are now getting a bit tired. You have answered so many questions, and we may need to stop there. The rest we can answer. Yes. We can look at the charts, and then two. I've also seen that the scientists or those who are participating are digressing. I mean, they are deviating from the focus of the conference because we are not discussing employment here. One of the things that people have forgotten about, this is a research team, and this is the Journal of Nutrition and Dietetics. It's not KNDI. The KNDI is only oversighting the activities of expertise. So employment of nutritionists is not relevant for this forum. However, also KNDI, I can't avoid to answer that question. KNDI is trying their best to position you. So it is you now to demonstrate that you have adequate knowledge, because also we have gotten complaints that many of our professionals are not doing well. So to say that, let's build knowledge and take our position. Then we create an environment as KNDI. And now get to the union and tell the union we need jobs. Because now we have even a union that is really very strong, and I know they'll be giving us a presentation. They are supposed to ensure that they push, and they're doing a good job in pushing that. So as we will only help with the environment, keeping it safe for practice and ensuring that you're confident enough, the union will help us to make sure that you are employed, and where the ministry or the counties are going slow or private practice, we come in just to support them to do that, even as KNDI. Good.
Thank you. I think
Yeah,
that's
thank you.
okay. So Maingi, we are through.
Yeah,
We
thank
will
you,
leave it
Prof.
at that.
Nkuka and Dr. Keo. I think we have exhausted most of the
Mike, I
questions.
think we can end it there until 2 o'clock. Yeah.
Yes, but there was
Okay.
a concern. There was not a concern, but a comment from one of the participants, which I thought we can explore, who is asking about leveraging artificial intelligence with the prescription of drugs, and is suggesting that drug interactions should come automatically on prescription generated by computer. Once computer
Dreadlock, we didn't get you well.
sorry? I'm saying there's a comment from one of the participants on leveraging artificial intelligence in prescription of drugs, and is suggesting that drug interactions should come automatically on prescription generated by computer. Once computer has the data which drug interacts where, and finally pharmacists should proofread, check, and get it printed for patient taking is our responsibility. So ideally, the participant is asking if we can have a database of what drug interacts with what, and then at prescription, we can use artificial intelligence to determine the drug interactions at the point of dispensing and at the point of prescription.
It's an ongoing development. So I know we can't run away from it. We are all moving towards that direction, including even the pharmacist. The reality is those artificial intelligence will work with what you and me has provided. They will not work alone. You must feed in some data, as you've indicated. The pharmacist has to feed in the data, and that feeding in of that data will not be done by anybody else. It will be done by the nutritionist who has been properly trained to be able to fish out that information. Thank you.
Okay, thank you so much, Prof. and Dr. Keo. We have exhausted most of the questions which were critical and related to the topic. However, participants are encouraged to continue asking their questions in the chat. They will be responded to as we take off the break. Thank you so much.
Thank you.
Thank you, Professor Nguka.
Takatifu na umungu alivua, kakubali kufunua kile kitabu, akatafuta aliyepotea, huyo ni sulubisha. Akatafuta aliyepotea, huyo ni niliyemsulubisha. Nyaraka za mashitaka zilikuwa nyingi, Babiloni yote ikajua jina langu, ila baada ya kifo chake, damu yake Yesu mshinda hukumu. Ila baada ya kifo chake, damu yake Yesu ilishinda hukumu. Imeniweka Sikiliza we mlima nikwambie, nimesimika bendera ya ukumbusho, nitarudi nikushuhudie, amenibadilisha akanipa jina jipya. Sitaondoa mguu wangu katika hilo bwawa la damu yake Yesu. Nitarudi nikushuhudie, amenibadilisha akanipa jina jipya. Sitaondoa mguu wangu katika hilo bwawa la damu yake Yesu. Imeniweka tena wanayenitegemea, bali yule Mungu anayenitakia Amenibadilisha kwa damu yake, amefuta majina ya kale, akanipa jina jipya. Amenibadilisha kwa damu yake, amefuta majina ya kale, akanipa jina jipya. Wengi walifikiri mimi yule wa kale, wengi walidhani mimi natenda ya kale. Sikilizeni, nimebadilishwa, amefuta majina ya kale, akanipa jina jipya. Sikilizeni, nimebadilishwa, amefuta majina ya kale, akanipa jina jipya. Ameniweka huru, ameniweka huru, ameniweka huru Yesu, ameniweka huru, ninaimba. Lakini ameuiba moyo wangu, Yesu si polisi anifunge, ananibeba bembeleza, yeye ni rafiki wa dhati, akiahidi lazima tatenda. Yesu ni mfalme wa amani, kuwa karibu naye natamani. Yesu siyo mwizi lakini ameuiba moyo wangu, Yesu si polisi anifunge, ananibeba bembeleza, yeye ni rafiki wa dhati, akiahidi lazima tatenda. Yesu ni mfalme wa amani, kuwa karibu naye natamani. Yesu, Yesu ni rafiki, nimemwona dhabiti. Yesu, Yesu rafiki, ahadi zake kweli. Yesu, Yesu ni rafiki, nimemwona dhabiti. Yesu, Yesu rafiki, ahadi zake kweli. Subira mumwami, ubulayi mumoyo kwanje, okulonda malako gake. Ulire shuya, ishibaya Yesu nomulina watoto. Abolanga malako gake, Yesu nomulina watoto. Oba ebini na etanganga. Yesu, Yesu no mulina, emulola ngabane. Yesu, Yesu mulina, malako kake toto. Yesu, Yesu no mulina, emulola ngabane. Yesu, Yesu mulina, malako kake toto. Yesu, Yesu nimemwona dhabiti. Yesu, Yesu rafiki, ahadi zake kweli. Yesu, Yesu ni rafiki, nimemwona dhabiti. Yesu, Yesu rafiki, ahadi zake kweli. Kumtegemea Yesu ni utamu sana, kukubali neno lake raha moyoni. Kumtegemea Yesu ni utamu sana, kwake daima nimepata uzima na amani. Kumtegemea Yesu ni utamu sana, kukubali neno lake raha moyoni. Kumtegemea Yesu ni utamu sana, kwake daima nimepata uzima na amani. Yesu ni rafiki, nimemwona dhabiti. Yesu, Yesu rafiki, ahadi zake. Yesu, Yesu ni rafiki, nimemwona dhabiti. Yesu, Yesu rafiki, ahadi zake kweli. Neno lake Bwana ni kweli na amina. Ahadi zake, akiahidi kitu lazima atatenda. Mungu ni mwaminifu. Ahadi zake kweli, ahadi zake kweli. Oh, yeah, yeah. Nisijuti kupata wokovu ngali kijana, nimepata amani hiyo ya kweli, amani ambayo sikupata kwingine. Mungu niliyejivunia, si Mungu niliyesikia, ni Mungu ambaye nimeona akitenda. Kwake napata raha, kila kitu nafanyiwa, hiyo ni hasara. Mungu ananipenda, kwake napata raha, kila kitu nafanyiwa, hiyo ni hasara. Mungu ananipenda, nimependa, penda, nimependa, 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 unavyonitembeza. Una changamoto ukiwa katika safari ya wokovu, ila mapito yako yanatendeka kwa wema. Piga simu, pigia rafiki zako simu wote leo, uambie una shida sana, unahitaji sapoti. Ukimaliza pigia na Mungu wako goti, kisha naye umwambie una shida sana, unahitaji sapoti. Hapo ndipo utaona nani anayekutania, atakaye kusaidia. Kwa Mungu wangu napata kila kitu nafanyiwa, ina imani kwamba Nikupe jina gani kwani kila la kheri ni upekee wako. Majina yote mazuri ni yako, ewe Jehova, Mpaji wangu. Nikupe jina gani kwani kila la kheri ni upekee wako. Majina yote mazuri ni yako, ewe Jehova, Mpaji wangu. Nikupe jina gani, kwani kila la kheri ni upekee wako. Majina yote mazuri ni yako, ewe Jehova, Mpaji wangu. Nikupe jina gani, kwani kila la kheri ni upekee wako. Majina nikupe jina gani, kwani kila la kheri ni upekee wako.
Okay. So wow. Good afternoon. Well, for those of us who are in, am I audible? I can be heard from that side. So we want to start thank you, Esther. We want to start our afternoon session. And what I want to say is that for me, we have had a very interesting morning session. And I want to be very grateful for those who facilitated the first and the second. Professor Nguka has done very well. He has given us a new thought. We want to get now into aspects of management. That is leadership. And maybe as colleagues, what I would want us to take into consideration is the fact that we are leaders at every level we are. It doesn't matter whether you are a CEO or just an officer in the line of service. What is critical is that all of us are leaders, and if we are not yet given higher positions in the future or in the time to come, you'll be a leader, even in those bigger positions. So I'll be handling this aspects of the workshop before the opening of the conference with Kutwa, who will be assisting me technically, and of course in the question and answer. So I'll share my screen, and let me go to the sharing first. Am I a host? Yes. I'll share my screen, and I want to start with an aspect of leadership that people really need to look at very well. I'll be using one of our slides, which we use for training of leadership. We have a whole 15-module leadership course, which normally, I think we didn't run it last year. We're going to have a whole complete course of leadership on which takes about 1 month or so. It can always be squeezed to 14 days. This time around, we want to run it for a whole month. And it is purely on leadership and emotional intelligence. So I want to pick the emotional intelligence part of it and one module, which is teamwork. So you are all welcome. And the interesting thing with leaders is that we cannot define leadership from one domain. We have leaders with different types of traits, but there's one thing they share, which is in common: the aspects of teamwork and emotional intelligence. Now, every leader requires emotional intelligence competencies. And why we are going to focus on emotional intelligence is because it is a new area that many of us don't take seriously when we are leading. Even when you are you were a prefect in high school, and then you became a student leader at the university. you remain the leader, but there are aspects or competencies that probably in one way or another you missed out on. And one of such competencies we miss out on is emotional intelligence. That is purely a mental aspect on our leadership approach. When you're a leader that does not put him or herself in the position of the people being led, and then internalize that by empathizing with the situations. For example, we say that we are emotionally insensitive to the people we are leading. And the best leadership is normally leading from behind, not from the front. But most of the leaders, they prefer to lead from the front. And so all of us can be given a position, but if we do not get the best competencies, then we cannot lead. When we cry very well that, okay, the leadership of the country is not very good now, it needs to be given to the young people, that is well said, it's good. But we also need to ask, are young people prepared for leadership? Do they have emotional intelligence? If you criticize an elderly person for wrong leadership, do you also empathize with that elderly person? Because if you are going to lead as a young person, then this elderly person will be part of your subject. So if you're not insensitive to them, then you are not a leader yet. And that is why we need to get to understand emotional intelligence as a component in leadership in practice. And so I'll be taking us through this. This leadership slide is was spearheaded by Professor Grace from Nelson Mandela University in our leadership program. And so today we agreed that I can use it to train our professionals who have not been trained before. And we all agreed on that. She's also part of this conference. She's one of the editorial board members for the Journal of Nutrition and Dietetics. Professor Grace is an associate professor and is a full professor at Nelson Mandela University and associate member of KNDI, the first one we gave when she came for a licensing award some times back. So in the outline of this training, we are going to look at emotional intelligence leaders. And we're also going to look at the history of emotional intelligence. In leadership, what is emotional intelligence? Emotional intelligence framework and key elements, the benefit of emotional intelligence, and then personal leadership, emotional intelligence in non-Western society, how to develop emotional intelligence, and then the brain and emotional intelligence. And then leadership styles in the context of emotional intelligence. Of course, we can touch on COVID-19 and emotional intelligence, but not very important for now. So here we go. What are the characteristics of a perfect leader? When you look at Africa as a whole, and you look at the Western world, particularly the South America states, what comes to our mind? We see two people here. We have Nelson Mandela of South Africa, and we have Donald Trump of America during his leadership. What comes to your mind as a picture of the type of leadership that we have? I got a story from Nelson Mandela where somebody who was urinating on his head when he was in prison met with him in a hotel or restaurant when he was the president. Now, if you were the one that you find somebody in a restaurant that urinated on your head when you were in prison, what would you do to such a person? But he welcomed him and talked to him and invited him to be next to him and never did anything bad. But the man was trembling because he remembered what he did for Nelson Mandela. But the Mandela was still the Mandela. When you look at Donald Trump, how his pushy factor, for example, and how he stands for what he stands for, what comes to your mind about the sensitivity to the society, and particularly to the people that he does not like? Leadership is the most researched topic in science, both social science and also in the framework of arts. But a perfect leader would be depicted by these two as a contrast: Donald Trump type and Nelson Mandela type. History of emotional intelligence theories. The study of emotional intelligence is anchored in psychometric studies. When you talk of psychometric studies, we are talking about studies oriented to psychology and dealing with measurements in terms of the social behavior and brain factor. And we have psychometric tests which are done to measure the emotional stability and capability of a leader. It was first studied by Thorndike and Stein in 1937 as social intelligence. So emotional intelligence was initially labeled as social intelligence. It simply meant get along with other people, which means if you're a leader, then you must go with the people. You don't go alone, or you don't let the people go on their own. And if you let the people go on their own, you must get along with them. They must go with your spirit, with your blessings. And so get along with other people was social intelligence, which is also emotional intelligence. If you're a leader, do you identify with the people you are leading so that they are very comfortable with you? It was again studied by Wexler, Maslow, and Gunnar. And more recently, the guru of emotional intelligence is Goleman from 1995, 1998. Then we have Gibbs and also Savo and Meyer. This Slovey and Meyer studied in 1990. If you find these books, you can read them by the authors. But more important is Goleman's books, because he is a serious author of emotional intelligence in leadership. Goleman books is about emotional intelligence, and which served as a catalyst in many studies. So if you look at Goleman's record of studies, you will see the history and the trends in emotional intelligence and how it is applicable in leadership, your leadership, and also my leadership. So essentially, 3 ways exist to define emotional intelligence, and we look at them. Number 1 of the definition of emotional intelligence is set of competencies. So it is defined as a set of competencies that a leader has that will make such a leader go along with those that are led. That is the first definition. The second definition is part of personality trait, mainly the work of Barrow. It's also the same as competency-based definition. So emotional intelligence is defined as a personality trait for a leader. But how? As the leader gets along with others. The third definition is mental ability to solve problems, as developed by Mayer, who also developed the frequently used emotional intelligence questionnaire. But these abilities are same as first model. So we will look at what is really emotional intelligence in the context of leadership. Now, emotional intelligence is the ability to understand. That is, underlying the word understand, control, and develop own feelings or emotions, and also to understand and manage the feelings of others. So in the context of leadership, you as a leader must understand yourself first. And then in the process, you also understand others that are working around you or those that you're working together with. The moment you set an equilibrium where there is a balance between your own understanding and the understanding of others, then you have reached the emotional intelligence peak. And that is the time that a leader is described as having a personality traits that gets along with others. And so such leaders that have reached the emotional intelligence peak become successful leaders in whatever they do. They are able to know when things are not good enough to make a turnaround. When people are pushing too much, they can change the course and balance the entire scenario. That is balancing own self with other people's personalities or self. It combines both self-awareness and empathy. Empathy is exterior, is external, intrinsic, extrinsic, while self-awareness is internal, intrinsic. So you don't look at yourself only, but you look at other people when you're working together with them. It also emphasizes how your emotions affect others and how you use knowledge to create positive aspects or outcomes for yourself and your staff or the people you lead. So if you're a leader, you must have a set of staff, or you can have a set of people you are leading. In a case like that, when you create a positive outcome for yourself and others, then you are defined as having been cognizant of emotional intelligence in your leadership. Extremely valuable in the modern, complex, and growing organizations, essential for success. One of the answers to get for successful leadership, for a perfect leader. So all leaders, whichever level you are, you need to have a trait or build a trait of emotional intelligence. In most cases, it involves let others think they made the decision that you made. That is the simplest thing. Let people think that the decision you made, they were part of it. And that is like teamwork. So it is the foundation of teamwork. And therefore, they work together. So a good and intelligent leader must make sure that people think that they worked together. They pushed it together. The outcome they obtained, it was together. And while they were doing it together, the leader got along with them. So the question will be asking, in whichever leadership position you are, what is your current position? Are you emotionally intelligent? in your style? Or are you moving forward and leaving others behind without sensitivity about their emotions? So we look at the emotional intelligence framework. I hope the slide there is moving. Is it moving? Emotional intelligence framework. Good. Now, in the emotional intelligence framework, we are looking at Goldman's et al. 2018, and we said Goldman is one of the greatest authors for emotional intelligence. You can always find out from your references. We have what we call self-awareness, social awareness, self-management, and relationship management. So a good leader will work on these 4 pillars or 4 domain areas perfectly to the peak to become successful in leadership with emotional intelligence. Now, self-awareness, recognition of who I am is what it means. As a leader, you must know yourself, your weakness, your strength, and you must also know where things are not good, even your level of intelligence, and what your capability is and what you cannot do. Also, when it comes to the lower part, so both self-awareness and social awareness is about recognition of who I am. So many times you need to ask yourself as a leader, who am I? Who am I? And when you give that answer of who you are by writing it somewhere in a book, then you will begin to know yourself of who you are and what you can do. Now, the lower part, which is regulation, what I do, that is self-management together with relationship with others. The two form what I do part. However, if you look at self-awareness and self-management, then you come to the level of how to manage yourself. So when you look at yourself and you look at your self-management skills, then you come on to understand how to manage yourself on the lower end. And when you look at the social awareness and you know how to build relationship with others in a workplace, then you come to social manage relationship. So you know how to socially manage relationships in an organization. So any good leader that is going to be successful must have this pillar in their leadership style. And then they become positive influencer of the people being led. So these 4 pillars is what will make you influence others towards a good cause. So your success will depend on how you recognize who you are by social awareness and social and self-awareness, or self-management and managing relationship. And that means also how to manage yourself and how to manage your social relationship. All this give you influential characteristic as a leader. And that is when you'll be said you have emotional intelligence. So this is the emotional intelligence framework. So if I were you as a leader, I would go and analyze myself. Who am I? Then I would also analyze who is around my social life. Then I also analyze how do I manage myself? And then how do I build relationship with others? Now, if you score high, then you are emotionally intelligent. So then you can influence others towards a positive course. Most of the leaders have failed because they left others around them. Some also fail because they don't know themselves. Others failed because they did not familiarize themselves with the society around them. Others failed because they could not manage their emotions, themselves. When in trouble, they cannot manage it. So they failed. So you see that kind of cycle, then we call it an influential framework by Goldman et al. So key elements of emotional intelligence that we must look at when we are leaders. Leaders in church, leaders as a head of department of nutrition, a leader in the society, you're a county nutritionist, you are a sub-county nutritionist, or you are just a mere principal or a deputy. That is leadership. You must have these elements: self-awareness, learn to know yourself and your feelings and your strength and your weaknesses. Keep on examining and reflecting. So from here is, peradventure you are a leader, it is good to go and sit down and analyze your feelings, your strength, and your weaknesses in relation to your work and see where you are scoring poorly. We also have self-regulation. Think before you do or speak. We were saying that our former, the late President Kibaki, if you were keen on his leadership style, you would see that most of the time he never spoke. And if he had to act, then he would do it after others have spoken. And so somehow he became a successful leader because he had self-regulation. And people would have thought that he was not intelligent. But remember, he was a first-class material of Makerere University. So he talked less and did things, and in his doing, people did on his behalf. So he had self-control. But you must practice a calm trait in you. You must always remain calm, even when things are not good. You hold yourself accountable for every step you make. And then you know your values. No abuse of privileges. That is a characteristic of self-regulation. You have been appointed a cabinet secretary for health today. Your role requires that you improve the health sector. There's no way you'll go to Vihiga, for example, and start shouting at the head, the county commissioner. That's none of your business. It's not part of your trait. So if you fail in the leadership, it's because you went beyond your regulated self. See, you must look at it. Am I being held accountable? What are my tools of operation? Where do I make a reference? And how am I going to execute them, having a set of values, and then without misusing the privilege that I have? That would mean you're self-regulated. If you score high, then you're moving towards successful leadership. But you must also be motivated. High work standards. Know why you love your job and set goals and be optimistic. Be optimistic. So any good leader must focus on the performance contracting or performance goals of any organization. They must be motivated to work. Whether people observe or not, their self-motivation becomes a priority, and they're optimistic that they will achieve. I was listening to the new cabinet secretary for finance, Bade, and you could see when he was being interviewed, he was confident and motivated, and he told us that, this mess we got involved in was a 2014 mess. It is not a 2018 mess. And he dug deeper and said, I can improve the economy without borrowing, because he has seen that he is optimistic, well set to go for the job. Such people can become successful if they stick to that level of motivation. Then we have the empathy. Put yourself in others' person's shoes. Give constructive feedback. When somebody has made a mistake and you're the leader, everybody makes a mistake. Therefore, correct with reverence, correct with love. Say, okay, you don't have to do it this way. This is not how we do it here. Next time, make sure this is how it is done. And after that, get the person on track to work. Look at body language. If somebody feels that they are demotivated, how do you bring them out? How do you bring them up? Respond to others' feelings. You may have annoyed them by the statement you made when you are correcting, but then later on, you must also respond to their feelings. You can ask them, let's have a cup of tea. Let me give you a new direction on how you can move forward. That cup of tea can correct the feeling, the external feeling. That means you are looking at others. So you are emotionally intelligent. Then social skills. Good communication. One of the things that a leader must know how to do is how to communicate properly. If it is in written form, it must be well articulated for the receiver to interpret, decode, and give a feedback. If it is verbal, then it must have relevant grammatical coupled with diction, that people can understand what you're saying. That you don't leave them confused and say, what did the CEO say? What does the head of department say? I didn't hear. You must communicate very well. You must also know how to solve conflicts. When people under your leadership are not going on well, you can offer the entire team a cup of tea. And let their leader go and have that tea, take care of that tea. And they can discuss, or you can tell them, tomorrow we have a training and all of us are part of it. And give one of them a paper and a pen and tell them, today you are the one training us. You will have sorted out simple conflicts. People have different conflicts in society. Just mere jealousy. One person has been promoted, another one is not promoted. It's a jealousy. How do you bring people together to work? Another one got chance to travel abroad, the rest not. So they build negative attitude towards them. It is your responsibility also to solve that conflict by giving others alternatives. But it's also good to give praises to staff when they do well and the people you lead. You've done very well. You're a footballer, a football coach. Somebody was given a penalty and they didn't score and they are a star. So they feel bad. You encourage them. You did well. You did well. You scored yesterday. And that was the strength. So you cannot say, you messed us up. You made us not to win gold. You have to keep on praising. Then give praise only when someone deserves. You don't praise people who have done nothing. Maybe because they are part of your golf club members. Sometimes you say, these are people that are my buddies, they're in my kitchen cabinet. Give them due when they deserve. If they didn't work or do well, you tell them you didn't do well. And you must also learn how to handle bad news. In places where we work, you can't miss bad news. When you're given a responsibility to do, bad news comes from the people you serve, the clients. It comes also from the staff. It comes also from your own social homes. How do you handle bad news? Will make you become a successful influencer leader. And that would mean that your emotional intelligence is high. You've been told you've just lost your father today. And you are a CEO. Do you close your laptop and go home because you have lost the father? Now, if you tell people that, yes, I've lost my father, let's go on working, we thank God for everything, and you continue working, then you know how to handle bad news. Your staff has indicated, I was coming, you just got involved in an accident, so I cannot arrive in good time. Oh, so you got involved in an accident. How you remain calm and say everything is okay, you can find where to rest and then come and work. You are emotionally intelligent. Key elements of emotional intelligence. We look at emotional intelligence from all these frameworks. Now, if you have good social skills, then you influence. If you are motivated, then you are resilient in nature as a character. If you have high level of self-awareness, then this is high level consciousness, and therefore you have good intuition. You can always get to know when problems are coming and how you can tackle them before. But when you empathize with others, then your interpersonal sensitivity is high. All these things put together makes you a better leader. And that means that you score high on emotional intelligence. Now let's look at some of the quotes on emotional intelligence. Now look at this. Anybody can become angry. That means annoyed. That is easy. But to be angry with the right person and to the right degree and to the right time and for the right purpose and in the right way, that is not within everybody's power and is not easy. That is by Aristotle, emotional intelligence quote. Another one by Daniel Goleman says, for leaders, the first task is management. The first task in management has nothing to do with leading others. Step one poses the challenge of knowing and managing oneself. So if you are appointed a leader today, the first thing is not others. The first thing is yourself. So begin to know yourself. Now I've been appointed as a CS or a county executive officer, CEC. Who am I? Who am I? So you begin to analyze yourself. You can take your time and get to reflection in a quiet place and begin to analyze the traits that they saw that made them give you that leadership. And then start writing them down. This is who I am. I am strong in the spirit. I'm strong in physical. I am sociable. I am intelligent. I have competencies. So those things that you put together in your basket will begin to make you know that you have strength to push forward before you jump to others, to start analyzing who they are. Now, there are some people, you appoint them today, the first thing they will do is to invite everybody under their leadership and tell them, you see now, I am the leader and you are the led. So you have to respond to what I say every single minute. And if I see you walking in the corridors anyhow, home is best for you. That is not a good trait. The other quote is how people treat you in their karma, how you react in yours. When people treat you in a workplace, how they treat you, how you react matters a lot. If they treat you badly, you react badly, then your emotional intelligence is low. Low rating. Emotional competence is the single most important personal quality that each of us must develop. So if you want to become a leader, you must start by developing your emotional intelligence capability. The first thing. Only through managing our emotions can we access our intellect and our technical competencies. There is no good, strong, competent personality that can be successful if they cannot manage their emotions. You can be a very good footballer, but if you are hot-tempered, somebody annoys you a little by sliding you down and you give them a jab on their face, you get a red card. Yet, you are a high-skilled scorer. You can be one of the best teachers. You go to class, they look at your shirt and they say, "You don't look like our teacher because we don't like that shirt." You jump on students, they chase you out of the classroom, you don't teach. So how we manage our emotion depends on the technical. We'll determine the technical competencies and intelligence we exhibit. This is Dave Lennick. But what are the benefits of emotional intelligence as a leader? When you are scoring high in emotional intelligence by the framework and elements, the pillars and the elements, you become a better leader. So good leaders are emotionally intelligent. So if you see somebody successful, then their intelligence is so high. I was telling somebody that, I'm going to teach emotional intelligence. But somebody was telling me that we don't think you have emotional intelligence because of 1, 2, 3 things that you don't do. And I laughed and I said, no, successful leaders are equally emotionally intelligent. So if you have seen me successful, score me high, not my relationship with you, because you are not among those that are led. So probably I'm not emotionally intelligent here, but when I go to lead, I become emotionally intelligent by results, not by efforts. So you also become higher. You build higher internal awareness. This one helps to make good decisions, understand how you influence others and decisions, what your weaknesses are, and what your strengths are. When you study or you build your emotional intelligence, you'll be building your understanding. Also, when you build your capacity, you become better self-regulated. You reduce or minimize impulses. Sometimes leaders work with a knee-jerk behavior. Something has happened, and within a short time, they have reacted to it, and they have made a serious mistake on that reaction. You have to take time and study what has happened, and then react appropriately. So when you react quickly, you become a knee-jerk person. At the same time, you work on impulses, and it can be very costly. Increasing empathy, which means understanding others' emotion very well. You annoy them, you bring them back. You annoy them without knowing, you become sensitive to recognize that you are annoyed, so you have to go and look for them. And finally, we have better collaboration. You can adapt to any style or any situation that arises. You can reduce tension in a workplace, and you can motivate your team. If your team sees you to be stable, even when things are bad, they become very comfortable and they are ready to continue working because they say our motivation is in our CEO or our manager or our supervisor, because this person is never moved by things. So we are stable. You don't have money to pay people. They see you as stable and you assure them that you'll still get your money tomorrow. They build confidence in you. You have motivated them. Then you become emotionally intelligent. Yet, right under the carpet, you know very well that things are not good, but you have responded. And then you can reduce stress for yourself and employees. If you're a leader, don't do things that will stress your employees. If they see you stressed, they will be equally stressed. How? Build your emotional intelligence capacity. We see things like better cooperation and engagement form, which means that you form the team and you become part of the team dynamics where everyone contributes if you are highly competent in the emotions. Better organizational culture due to trust. Your people will trust you more. Better relationship, open communication channels that nobody can differentiate between a CEO and a cleaner. Everybody can talk and approach the CEO, and they can both do things together without one feeling that, I'm down there. You walk with a cleaner, you story with a cleaner, you dance with a cleaner, and they all accept, and they are very comfortable with it. And then, of course, you can look at the key elements of transformational leadership by Lone and Lone 2018. You will see some kind of elements of emotional intelligence. And finally, better performance and results. So if you see people performing well, it's because they have high level of emotional, they have built capacity for emotional intelligence to perform. And so don't compete with them because you've seen their results. Check yourself and see whether you fit in that framework. In the business world, if you have high level of emotional intelligence and you have built that capacity, the things you see is better success. You can predict success, high productivity, and effectiveness. When you talk of effectiveness, you achieve your goals. Not only that, even efficiency, better utilization of resources, higher morale and enthusiasm, better organizational culture, can handle change. When change comes, you can handle it. Teamwork can take risk. High-level emotional leaders take great risks for their life and the risk for others. And then we have what we call transparency and flexibility and emotional responsibility. These are benefits in the business world. So we want to look at resonant leadership. Now, leaders who are in harmony with the people that they lead in terms of people's feelings and channel them to a positive direction, inspired by his own values, such a leader succeeds in getting people united in an organization by means of the emotions they feel, by cultivating optimism. This is Goldman 2018 saying they're called resonant leadership. People's feeling first. Positive direction, focus. Then they cultivate optimism. Such leaders will succeed by getting people along with them. Do you have the skills of a resonant leader with high emotional intelligence? If you are a leader in any position, you have to check yourself. So where you are, because we're not doing an exercise here, you can write down the attributes of such a leader that you have, which you can consider in that state of description. You can do that along as we go on. This is my leader, and this is a resonant leader by these qualities. And you can choose personalities. We have had quite a number of them in Kenya and elsewhere out of Kenya. What are the characteristics of such people that you will be looking for? Look at their vision, look at their integrity, look at their respect that they have earned among people. Look at their courage, their strategic thinking, prioritizing priorities, how they improve others, how they mobilize employees to achieve organizational and own goals, both task and people-oriented. Get one of such leaders in Kenya, in Africa, in the world. Maybe at the point of discussion, you can tell us who you found as one of such leaders in Kenya. Now, we want to look at emotional leadership, emotional intelligence and leadership in non-Western society. Now, much research to show the emotional intelligence is more important for leadership in Western society than technical skills and cognitive abilities. Many times, people think technical skills and intelligence in the brain is what makes things work. It can only account for 15% of success story in an organization. Attitude is everything, and that can be combined together with emotional intelligence as the core or the epicenter of attitude. You may have gone to school, scored very well. Your cognitive ability is very high, but your emotional intelligence is poor, your attitude is poor, you go nowhere. You may have good technical skills, and your hands-on motor ability is very high. Poor attitude, little intelligence, you go nowhere. What is important is the emotional aspect. Not much research in non-Western society, but emotional intelligence inherent part of transformative leadership. So in many non-Western societies, there's a large difference between male and female behavior. So when it comes to context of emotional intelligence, we need to look at the gender aspect or sex aspect to see who are better leaders when it comes to emotional intelligence. Is it the men? Is it the women? And you can get examples outside. Of course, let's see. Kenya. Most studies in Kenya, that is Africa, we have very little studies. Even in South Africa, where Professor came from, there are very little studies. But a study by Airo, 2014, on school principals in Kenya, the findings indicated that emotional intelligence and leadership theories developed and tested primarily in Western context also applies to non-Western settings. So Airo was trying to prove that. Airo is formerly supposed to be the VC, but now in Moi, but now VC, Vice Chancellor Desta. Now, managers who were rated more effective leaders by their subordinates possess more aspects of emotional intelligence. So you can ask your subordinates or your staff that you lead to rate you on intelligence so that you can know how best you have managed. And of course, this study showed that this all over the world, including Africa, in modern leadership, the soft skills are important. And therefore, high emotional intelligence is an essential soft skill for a leader. So it is not the technical, it is not the cognitive, but it is the soft skills that make successful leaders. Soft skills. You can say so and so is soft. Not soft that you can touch them and you feel that their body is soft, but soft in the fact that they understand the environment and themselves and can work within that environment. How to develop emotional intelligence now as a leader. You can develop it by constant practice. You must practice emotional intelligence. Perfection comes by practice. You are at a lower level, you can rate yourself, but then you can begin to build your emotional capacity as you continue to lead. You can also do reflection. You can sit and see, evaluate yourself on areas that you've gone so wrong in your leadership and correct them as you continue to build your soft skills. You can encourage others to give you feedback quite often. When you annoy somebody, you can ask them, am I still good for you in the context of work relationship? Have I annoyed you too much? If they say yes, you can ask them for forgiveness and then continue working with them and perfect that area. So look for feedback. Now, some people think that when you get feedback from staff, then you are weak. It is an area of strength, good strength, because you're building your soft skills. You're not weak. You're asking them, how did I perform? And how did I perform in managing you as a person? If they tell you, I don't like the way you have behaved in the past, and particularly this day, tell them, I'm sorry, I will correct that one. Next time, you change the focus. You build your capacity. So you must encourage peer feedback, even colleagues. Body language. You must know how to build body language. Body language can intimidate, but it can also make people have a feeling that you're a good person. The way you look at them, the way you walk with them, the way you receive them when they come to your office. Do you receive them like, what brings you in here now? Just by looking at them? Or do you say, oh, welcome. How can I help you? Sit down. The body language is important. But then, more important, think before you speak. Many people have destroyed self and others because of what they speak. I know sometimes what you speak may work, but in a work setting, with the lens of emotional intelligence, you think before you speak. Don't just speak anyhow. I was listening to the interview with particularly the media. They can annoy you. And with our president, with all due respect, and you could see that the media team were literally looking to annoy the president. Now, how you respond to that is very important. Because if you responded by emotion and you tell them, you are I'm your president, that is not response. They've annoyed you. So how do you tell them? Say, okay, I understand what you have said is wrong, and it's an area that I will correct. Lots and lots of practice. So you have to practice how to build your emotional intelligence. Now think about a situation that you recently experienced in your work setting as a leader at your level. And how did you use, or could you have used, better emotional intelligence to manage the situation? If you reacted to your boss, for example, because you're a leader at your level, or you reacted poorly to others, how would you manage the situation? You can think about it on your own. Self-reflect again with this framework that we have just talked about and see how you can improve on that area. We will pass that. Self-management. How do we do it? Know your own values and principles. Take responsibility. Do not blame others. That is when you are managing self well. Now, you see, in a work setting, people may have not done well. Please be accountable. I listened to my good friend, Professor. Let me use, with all due respect, as a reference. That is Professor Lowe, the current VC for Masai Mara, before Parliament. And the chair of Public Accounts Committee was asking, Madam Vice Chancellor, can we say that your people are letting you down? That was one of the questions that came. And she was very categorical. She said, Mr. Chairman, I'm in charge. So she did not say that, my finance officer did not have these documents to put together. She said, I'm fully in charge. That is why I'm telling you that I've presented this case before. But this thing happened before I came in. But I'm fully in charge. No blaming of others. Keep calm. Keep calm and stable. Be motivated, which can be intrinsic or extrinsic. Look at what motivates you most. Then get a coach. If you want to improve on self-management, get a coach. Relationship management. We have to build culture of listening to our people that we lead. Don't lead as a single person. You can never be successful. Listen to the people that you lead and direct them appropriately. Give full attention, no distraction, reflecting thoughtfully, and then giving a concrete feedback. So you have to recognize their emotion, the others. How can I help you? Did I help you? That's a question you can ask after. Did my efforts assist in any way? Set clear expectations and then ask questions. Develop shared values with the others. But then, of course, more important, use praise. This is a good tool. Praise the people you lead and give recognition where it deserves and award them to some extent. They will consider you a most positive lead. Even if others don't receive and others receive, they will still see you as very positive when it comes to relationship. Then manage your boundaries well. When you realize that things are not working and your boundary is being infringed into, or you are infringing into others' boundary, then retreat and set your own boundary. Schedule time to build relationship. A leader that cannot buy a coffee to the people they lead is not a leader. Hey, Professor, let's go for coffee today. I felt like I should buy you something. Cappuccino, which one do you want? You have to create time to build relationship. When you go there, they will not miss the sight or the imagination for coffee time. So you become their identified. Be positive and avoid gossiping. Avoid gossiping. Yeah. Social awareness, body language. You look at these people. On the left-hand side, the first person there and the second one. Very defensive in nature. The one that sits at the middle there is very arrogant. The way they sit tells you that they think everything belongs to them. The one on the right is annoyed. Such people cannot work. But at least the social awareness here is that they can begin to build on how they react at every situation with their body language. Down there, are you being defensive? I don't think so. Okay. Irritated, happy, confused, worried. You can give answers to the right-hand side. If you take a screenshot, you can go and sit down and give an answer to the body language communication you get from people. Look at number 6, for example. That is business style. So this person is sociable and can conduct serious business if they are leaders. Number 3 is appreciative. Always giving a feedback. What you did is thumbs up. I'm in a hurry. I don't have time for you. So you can look at them when you do a screenshot. Emotional intelligence is about the brain. The brain of a human being is very important. That's why some people say, is this president, is this member of parliament, is this MCA nuts? What is wrong with their brains? Because they have not used their brain well. And you can see distinct areas of the brain, which is anatomical aspects of it that are very crucial for emotional intelligence. And Professor Nguka, I know you know very well those parts. Should be telling us, should be removing them for us so that we see them outside in the anatomy. These are what Goldman says carries our emotional intelligent capacity. Look at the red, for example. Sensory cortex is about empathy and self-awareness. Look at all men are colorblind, but let me try. The purple. The purple anterior cingulate is for impulse control. And you can see that all about emotions is in our brain. And so as we build our brain, it is important to also look at how we can shape the brain and to know which parts are important. The limbic system, yes. So when we develop emotional intelligence, new neuron pathways develop. So as you build your capacity, you build other areas of neural systems. When bad habits are unlearned, they break the neural pathways. We look at hard work must be motivated. And there is past practice, step by step. So you will see that we have the ability to build our focus for the brain to do what we want in leadership by practicing emotional intelligence to become better leaders. Emotional intelligence leadership style, 6 main styles. Each style has different effect on emotions. Each style used in a specific situation and is best has strengths and weaknesses according to that situation. A leader should adapt the style used according to the situation they are in. And so we look at, in brief, emotional leadership styles. And we have the authoritative and visionary leader. This leader inspires. They are strong on empathy, works towards a common goal, but give room for followers to decide how to get there. If you want to become a visionary leader with authority, authority is not force. Authority is by giving others room to decide. So then you get more power. Used for a new vision, drastic change, less experienced teams. Now, develop by increasing confidence, experience, and empathy. Learn how to be enthusiastic and excited at a workplace. Learn how to be convincing and use good presentation skills. So you must build how to make presentations. You know, if you mess in presentations, people will know that you have missed the point. So you must have good presentation skills. Were you in a situation where you used this at any level, whether in primary school? You can think about it. Then we have the coaching leader. aligns people's own goals with that of the organization, focuses on development for future success, encouraging, motivating, and building trust. Normally has in-depth conversation, strategic conversation with staff or those people who are led. Used with promising employees. You can only do this with promising employees. People you see have potential. You can use it anywhere. So you must develop coaching skills. That means you must know your employees well. Those who don't know their employees cannot exercise this coaching ability. Were you in a situation like this in your leadership? We have affiliative leader who works hard to ensure harmony and peace in the team. The peacemakers. Concentrate on conflict resolutions and prevention. This is the Agwambo style. You know the Agwambo? The Baba style. Encouraging employees connects people with each other. Have high value on emotional needs and emotions. People cannot die when you are seeing. Say, no, we have to empathize with people. We have to control this situation. Used when there is attention and conflict. Stressful times when motivation is important. Okay? Develop conflict resolutions and emotional intelligence. Very important. Have you been in a situation like this when you have to solve conflicts between people? As I say it again, this is the Agwambo style, but you might find that a leader can have more than one of such traits. Democratic leader. Now, somebody will be asking me, you've called Baba style affiliative. What about democracy? Collaboration, very important. Input from team members and listens more, tells less. Sometimes he does not do that. He leaves people and make a decision so that he can solve the conflicts without democracy. So he cannot be 100%. That is my leader. That's why I'm saying that. For example, use in more experienced team to build consensus when one works with specific experts. When the team is capable and is motivated, they often work together as a team. Develop by making sure the team knows each other, including the team problem solving and decision making. Learn to listen and facilitate. Have you been in such a leadership? Then we have the pace setting leader. Performance and meeting targets and goals are important for this person. I want results. I don't want to hear anything. I want results. If you are, as long as you're working in this organization, our performance contracting assessment is coming in the next 2 months. I want to see results, whether you like it or not. Give me results based on your objectives. That's the kind of leader. Expect excellence and will do much. High standards does not approve of poor performance at all. This is highly tilted towards management, towards the manager. Can lead to burnout, whether you're working overnight or not. Exhaustion is not important for this person. What they want is high turnover. Have you brought results? Used when high quality is needed. For startups and when the team is motivated. It's also an important aspect of leadership. Developed by improving quality, use of management techniques such as Sigma and motivational skills. Have you been in such kind of a leadership quality style? And then we have commanding leader. Autocratic approach depends on orders, threats of punishment, and strict control. Do it or you leave. Can be misused and have negative effects. Used in crisis situations. When things are not very good, departments where staff have no motivation, problems, and employees, they're not working. They're not giving results. You can use that. Have you been in that situation? You know, you can use all these leadership styles where it is necessary to become a leader, but then with emotional intelligence at the peak of the plateau. So things that emotional intelligence people do, we remember that there are bad habits to unlearn. We can also concentrate to improve our emotional intelligence. An emotionally intelligent leader stands on other people's shoes. We are not going to look at COVID-19. That marks the end of the brief. I welcome you for our leadership training because we'll go deeper into all these during such trainings. If we want to remain perfect leaders or emotionally intelligent leaders, I can assure you within this 1 hour, we have gotten competencies that would help us build our confidence. I would want to invite, now that Prof is here, I want to invite him to handle teamwork because we're handling leadership together with him. And I'll be more boring if I don't know how to get along with others. So Professor, you can come and continue so that we can, so I think time is going. We're supposed to start the opening ceremony. So you can come in and handle the other aspect. I stop sharing this and have you on board. You can clap for me if anything worked well. Yeah. So we'll be handling, this one is a very short one and it's on teamwork. Prof will handle that for us.
Thank you very much, Dr. Keo, for having brought us through the concept of emotional intelligence, which actually you ended up locating it into the human brain. I always tell people that the human brain has a component which is not visual. It's not, even atomically, you will not be able to see it, but it is controlled at the midbrain, a place called the limbic system. That is the one that is in charge of emotions. And that is where you need to sharpen. And as you've realized, it depends on learning and unlearning, which you have gone through. For you to become emotionally intelligent, it is something you acquire and build on it with practice. You learn good habits and unlearn bad habits, which has been presented. So with that, can we again put our hands together for our CEO, Dr. Keo, for a good job well done. Now, the other component which goes hand in hand with emotional intelligence is teamwork. Usually, just like the body that achieve activities in a situation of tasks, you have a goal that is set, and that goal is not achieved by one person. It's achieved by different structures, and that need harmony in between. Teamwork, in terms of definition, has been defined by Scarnati as a cooperative process that allows ordinary people to achieve extraordinary results, which means there is the multiplicity of the work output if teamwork is embraced. Harris also explained that a team has a common goal and even a common purpose, where the team members can develop effective mutual relationship to achieve a team goal, playing individual roles and individual tasks that is given to them. I want to give an example with the human body. You have your hand, you have your eyes, you have your legs, and you have your nose and ears. Each of those body parts play critical role. but for the overall operation of the entire human body to a given direction. For example, when all of you made a decision that they were coming to Kenya Nutrition and Dietetics Institute, the brain must have thought, and the brain issued instruction to various parts of the limbs, the hand and the legs, to carry you to come and sit here. That is called a common goal. The goal was to reach Kenya Nutrition and Dietetics Institute. But the brain could not come because the brain needed the leg to carry it. The leg could not come alone because the leg needed the eye to indicate and show direction for the operation. Now, that is how teamwork plays. It is important that in a team, each one of us recognizes our strengths. Individuals basically have to work together in a corporate manner or in a cooperative environment to achieve the common goal through sharing knowledge and skills. And you must appreciate that these skills are specific and vary from individual to individual. Each of those individuals also have strengths. In an environment of teamwork, it is important to notice those strengths and capitalize on the strengths to be able to achieve the goal with less of complaints. Mute the so-called weaknesses and amplify the strengths. The literature consistently highlights that one of the essential elements in a team is focused towards a common goal and a clear purpose as defined by the Fisher and self-realized. And you remember self-realization is part of the emotional intelligence. They are able to identify areas of their strength and be able to push in that direction and are ready to even help others understand. Team members must be flexible enough to adapt to corporate working environment where goals are achieved through collaboration and social interdependence rather than individualized competitive goals, rather than competing. So in such an environment of teamwork, there is nothing like I have achieved. For example, in football, will you score if you don't have they're called the scorers, number 9 in front, isn't it? You need the back line to be able to stop. You need the goalkeeper to sit in the goal. And you need number 2 and number 11 to clear the wings. And they will deliver the ball. By the time the ball is scored, that scoring is not an effort of one individual. It is an effort of the goalkeeper. It is an effort of the backliner. It is an effort of the guy who clears the number 5 and number 3. Their work is to clear the ball and put them into the D for purposes of scoring. And that is how teams work. And you realize one key thing that happens in football, each one of those persons understands their skills and their positions to play. And they work in cooperation. Sometimes even being able to be space aware, be aware of your environment. The emotional intelligence comes in to be able to loop into the teamwork. Now, there are specific successful attributes that are needed for effective teamwork. And one of the key effective attributes are commitment to team success and shared goals, so that when there is a failure, it is not up to an individual. You don't blame one another. You should be committed to achieving a goal. And I love, by the way, that's how KNDI works. These young people whom I always find here in Kenya Nutrition and Dietetics Institute have always amazed me. Young people with a lot of energy, but each one of them have played their role independently to have the Kenya Nutritionist and Dietitian Institute to the level where it is. And this all boils down to the tone at the top. Successful teams usually will be motivated, engaged, and aim to achieve the highest level of output. There is a very serious characteristic of interdependence. You need one person to play his role. Each one of us must be able to play our role, and they create an environment where together they can contribute far more than as individuals, each one of them playing their role efficiently and effectively. Positive interdependent team play is important and will be able to give superior outputs. In fact, outputs beyond, what openly with the team members. You be honest, trustworthy, supportive, and show respect to commitment to the team and to the individuals within the team, fostering the caring work environment, and be able to have the ability to continuously motivate the members to achieve the common goal. There, as I've said, you in the interpersonal skill, you must have that ability to discuss, open communication and positive feedback, like just being able to congratulate members for the performance. And I've seen that happening here in KNDI a lot. Appropriate team composition, sometimes even forming certain committees to be able to do certain work. And commitment to the team process, leadership, and accountability. The team members need to be accountable for their contribution to the team objective and project. And they need to be aware that the team process, best practices, and the ideas are the ones that will contribute to the end goal. Effective leadership is essential for the team. So at any given point, when the team is formed, there must be somebody who is able to give direction or ideas, or somebody around whose coordination will be able to ensure that they're able to move to a single direction. And some of the skills that you'll come to develop teamwork include even tug of war, or in a situation where you have to solve a problem, we give you something to carry or some string to untie, but you untie it as a team. It gives you an idea that you can't be able to achieve if none or one of you is not achieving. If there is anybody within your team that is not achieving, then all of you are not achieving. That is the concept of team. We are because you are. The Ubuntu philosophy. I think all of you are aware of that. So in terms of team formation, there are various stages of team formation, or there is the forming of the team, And then we have storming, then norming, and then after which performance. I will be able to explain each one of those. In short form, in some of the known categories, when organizations begin or when teams are newly formed, usually there is an aspect of not being able to understand each other. You don't even understand the temperament of individuals who are within the team. So occasionally at the formation stage, it might look very easy when teams are being formed. But once the teams are formed and the actual work begins, and especially when you are starting, for example, a department, then each one of you now begins to be independent and you begin clashing on ideas. That is what is called storming period. So when that storming period comes, most organizations or most individuals will always lose hope and say, kwani ilikuwa ni kazi yangu? Kwani lazima nifanye? Kwani nisipofanya kwa... So you begin hearing such kind of sentiments. That is storming. Or somebody is saying, you don't have to be the one to tell us what to do. I know what to do. But of course, once you understand each other's ability and each other's skills, and even the temperament, and even the emotional intelligence, then you begin to norm. You begin to live with each other amicably. And understand that, you know, after all, we must actually deliver. Even if you don't love each other, there is a goal that you must achieve. You'll have individuals during storming period that are able to discuss and talk about each other. And some of you might have known, for example, even in the Kenya Nutrition and Dietetics Institute, and our friends from the society, and even our friends from the union. There are periods that there was a storming period, isn't it? Where each of those groups did not want to even listen to each other. But it reached a point when we realized, you know, we are working for a common goal called nutrition and dietetics. We only have to pull in single direction to ensure that we achieve the goal of ensuring that nutrition and dietetics achieve the maximum efficiency and effectiveness required in the country, and that was envisaged by Act number 18 of 2007. And now there is norming. Now with the norming, which has over a period of time, then performance comes in. Efficiency outputs are now visible. First, by seeing recognition by the various bodies, ensuring that now we are able to achieve our goals. Training is going on in a common curriculum. Our nutritionists are also being employed following an environment that is created. If that was not done, or if there was no collaboration between three major facets of nutrition and dietitians, the union, the so-called the society, and the regulator, we will not be able to pull this thing together. And that this common four areas, you will always experience them during leader or grouping or teamwork. So those I've already explained them. The storming period you can see is characterized by lows and highs. Forming period is very smooth because people have not understood each other and there is usually no war. But once it reaches the storming period, I can assure you there will be ups and downs, differences in opinion, philosophies, and directions. But once people understand each other, then there is the norming period where then there will be increased work outputs, and then the output performance will be seen when now the successes and success stories can be seen by the group in terms of its delivery. All these periods require specific leadership style. In the forming period, usually, as I said, during the group formation, there is very little in terms of conflict. But you will need the conflict resolution skills during the storming period. People come to participate by something called, let's see, they are not sure whether things will go on. There is wait and see game, expectations, sometimes legitimate or illegitimate expectations. The discussions are usually peripheral. After the group, wengine wanaenda kando kando, wanadiscuss, sasa yule alikuwa anatuambia nini? Is there anything that they can be able to tell us? There are attempts to identify tasks. Some people begin to display their characteristics and weigh parameters. They decide on information that is needed during the group formation. And they watch very closely how the team leader is behaving with them. In fact, some of them will say, we don't think you can lead us, so and so can be able to lead us in the process. That is during, they are trying to check how the process are going on. And during group formation, usually the accomplishments are very little. You will not be able to accomplish much. Now, then after group formation, conflict come in. Competition, disunity and tension among people, fluctuations in relationships, concerns over excessive work that is given. People begin, get polarized and work in groups. They begin discussing even the leader. The team leader still is being watched closely. And at this time, because of tension and those group differences, again, there'll be minimal output. As I said, this is the time when people are beginning to understand each other and knowing that even if you don't love each other, you can still perform and have work done. Those conflicts are coming, and you can see here where during the storming period, your emotional intelligence will come in here very, very strongly as a very useful tool to be able, and conflict resolution tactics. At the norming period, you have already now accepted each other with their weaknesses and their strengths, and agreed that you have a work to do. So here, you now begin establishing procedures to keep you going, and everybody now has a line. You know very well that so-and-so, when she's or he is hungry, then tempers can easily flare. So you know that that person must be given lunch early before tempers flare so that they can perform better. You now know that some of them are introverts, are not able to express themselves. So you tell them, so-and-so, you have talked so much. Can we now have also opinion of so-and-so? You have now understood them. You sense, you bring a sense of team cohesiveness and team spirit to come in. And in the process of understanding each other, there will be a component of trust that is also going to come in, so that, you know, so-and-so is able to deliver, but if he's not fed well, the guy will not deliver, he will disappear. So you know tea has to be given at 10 o'clock if so-and-so has to deliver. So as a manager now, you know, because you need this deliverer, by 10 o'clock tea is available for him, and the guy will deliver. You shall have also known that the other team member is highly skilled, maybe in writing. So him, you give different reports. At that point now, the leader knows who is to give what, and give them as per the tasks, the skills to be able to achieve those tasks. At that point now, members begin to respect each other. They know, kama ni kazi hiyo, pea so and so. Hata watakuambia, huyo ndiye anajua. Kama ni kazi ya clinical, basi pea my friend from KNH, I'm just, your name. Again, can you give Dr. Keo? He knows how to transnite. So in the process, you can see that the team is now beginning to understand the skills of each other and using that to be able to deliver to a common goal. Respect for each other now comes in, and the respect through the members' contributions to the team begins to play, accomplishes moderate work during that time. During that time, you begin to accomplish moderate work because there is some little bit of, we call it, they are not willing to shift. So people are still sticklers of their areas of specialties. They don't want to shift to help each other. Now, when it reaches the fourth stage, which is the best stage, where you have the performing teamwork, here is where people have reached a point of informality. Now they can discuss as colleagues and say, you know, if we don't deliver, it is all our responsibility. Members will be willing to help one another. Those who are not able to deliver will say, did you manage to do the work? Okay, you can bring it on. Can I do it as you continue doing the other one? And they come in very strongly to support each other. There will be close and supportive members of the team, and getting concerned of each other when they are not there to be able to deliver their goals. In fact, that is when they would say, you'd rather work. Even at that point, the team leader will have easy time because they will even cover each other. They come and do the work of the other and deliver the work without knowing, especially when they have issues. They build links and form individual teams for the benefit of delivery of the team goal. They will be flexible and open. At that time, you do not have to do what we call strategic monitoring, or the kind of leadership which they call authoritarian or authoritative leadership, whether you have to monitor or you have to work under supervision, because they will deliver even in your absence. The functions do not become redundant, and they will have those distinct roles, and those distinct roles can crisscross and contribute to the overall goals that are being developed within the institution. At that point, now the team accomplishes the maximum output. So based on that, there is what we refer to as the teamwork in leadership. And the specific characteristics have been provided there. Excitement, participation, and optimism becomes the order of the day. Anxiety, especially frowning at non-performance, they will always be looking for opportunity to be able to deliver, looking for direction, and they will always be able to act politely. There'll be a reduction of that violence that was coming up in the storming period. There will be cautious atmosphere, and individuals will be trying to find a place and establish themselves. The issues in the process, particularly in the forming period, will be people trying to find inclusion, trust, role definition, and goals. So in terms of leadership, that is when you are now supposed to be able to define goals during forming period. You actually establish policies and procedures to be able to give everyone direction. And what they call group rules or group norms, and clarify boundaries and build a relationship at that time. So during the forming period, you can be able to solve that forming period issues by just at that time providing direction in those areas that I've talked about. Define their tasks, clarify boundaries, and give them the roles through policies accordingly, or sometimes even by just word of counseling. For the leadership during the storming period, during the storming period, as I said, there is the discrepancies in thinking of every individual. And some people were coming into the group thinking that there are specific benefits. And when they reach there, the benefits are not there. So the things are not reconciling. Those are some of the challenges during the storming period. You said we were to get this. Why are we not getting it? There'll be lack of task progress because they are saying, I cannot be able to deliver if there is no, my part of the bargain is not taken care of. There is the feeling of incompetence and sometimes confusion, and others begin to compete for power and authority, or sometimes compete for attention, especially in government institutions. That is when now backbiting each other, they go to the clear leader. For example, the CEO here with his team, individuals will come and backbite each other. So-and-so is not working. I see him leaving early. Now that such kind of things, and then when the others learn, they say so-and-so is backbiting me. Then competition comes in. Then they form subgroups. Including even trying to, I can say to blackmail even the institutional leadership. So what are some of the leadership actions that you need to take when you are in this period? The key, especially for those who are feeling that they are incompetent, they are not able to deliver, you need to train them. That's when you now institute proper training for them to have the skills that make them feel insecure in terms of delivery. This is also the time when you need to clarify for them the work process, especially after you had developed the policies and procedures during the stage of formation. Now, this is the time now to help them clarify those procedures and processes. And as a leader, that is the time now to open dialogue. What do you want? What should I give you so that you can be able to deliver your work? Let them openly tell you, I'm lacking a desk, I'm lacking a pen. You would have not known as a leader. That is why I'm not able to deliver this work. I need a laptop of this magnitude. So that is when you open dialogue for them to be able to talk to you. That's not the time to close the dialogue. You learn to resolve conflict in the process. Some of them will tell you, you probably didn't know, but they have a problem in the house, including personal problems can bring conflict. If you don't know, you need to know that somebody's problem in the house, especially those who are married, there was war in the house. That war can easily come into the workspace or come into the team. During dialogue, you will be able to unearth that and be able to ensure that that is resolved. Even if you don't resolve it completely, but at least within the team, you shall have resolved. Of course, during the storming period, you will also realize different group formation. Now, again, the conflict resolution mechanism, using the previous conflict resolution mechanisms that were talked, can be used. You reinforce forming actions and you clarify the communications. Once that is through, then you move to the norming. And some of the key characteristics of the norming are the feeling of relief and confidence once they have been trained, sense of cohesion, developing harmony, trust, and support of respect, knowledge or acknowledging contributions that have been made by others, evidence of real progress now towards the goal, and being open and giving feedback without fear of contradiction, and using inclusive language, us, not I. That is the time when you now begin to say, we delivered. We have done this, not I have done this. So at this point, Now you begin to use the word we, us, and not I or my, for that matter. So the issues here that a leader needs to focus on are, at this point, once they have accepted, then the leader must now relinquish control and let control be done by the groups or the group members. Now, but you have to be careful, because once you relinquish, there is an aspect of group thinking. And group thinking can sometimes be very dangerous. How many of you witnessed the Gen Z's process? The only mistake they made was to talk about that they were leaderless. That is the only mistake they made. But I can assure you, those guys had reached a point, those young guys, because they were supporting each other, sponsoring each other. I remember the first one that they organized, the Gen Zs had doctors, they had lawyers, and all the lawyers were at the gate of the courtrooms at the police stations. All the doctors and ambulances were stood somewhere so that they knew when somebody was injured, they are able to take to the medication, and the same Gen Zs are the ones doing the treatment. The ones who were taken to the police stations, they all went there to the police station. The first one was very organized. You can see that level. The only mistake they did was to lose out on that component of the leadership. The group thinking can be very dangerous and can sometimes threaten the main goal. So even if you relinquish, at that point, you want to relinquish the control, but you must be in charge of the vision and the direction where you want to take. So you must continue to confront conflict that will arise out of underperformance or somebody's feeling dissatisfied that so-and-so did not deliver much but wants to claim, they claim some rights to also enjoy. So you will still continue managing that. So some of the actions that you have to bring in at leadership level is to share the leadership. Let them take charge of certain leadership areas, give and receive feedback accordingly, deepen the skills and understanding, seek input from outside the group, so that there is something called in leadership, you can easily, is incest of ideas. I don't know whether that's understood. Eh? When a group has formed so much, they tend to think in one direction. And therefore you will lose out, and even certain mistakes may bypass. So at that point as a leader now, you incorporate a new eye to come into the group to be able to continuously improve the group formation. Once the group have pollinated properly, then they will harmonize, and that harmony itself can also be a danger. And that can, in terms of leadership, you incorporate new people into that group to bring in new ideas. So you seek input from outside the group, share opinions and skills, and at the end of it all, you examine the group functioning. That is the evaluation at the end of it all. And lastly, in the performance, the characteristics of performance, sometimes some of them are very dangerous. There is the feeling of pride, increased output and quality, shared responsibility, collaboration with whole groups or subgroups, close connection within the entire group, adjusting roles based on the needs of the group, spontaneously emerging leadership. You will begin seeing some individuals showing some characteristic of leadership and then performing at very high levels. Now, some of the issues you need to be careful of there is maintaining that momentum, because some of them are likely to be complacent. You know, when you've done something repeatedly, you even tend to, it becomes part of you. And you may make mistakes, not because you didn't know, but because you have become complacent. And that is a danger. And that is what a leader now need to watch. What are some of the actions? At this point now, you need to promote sharing and collaboration between them and among the group members. Deal promptly with interpersonal or group issues. At that point, if you don't deal with it properly, it actually destabilizes the performing group. Continue to deepen effectiveness, and at that time is now when you make efficient use of time. So time become a self-control. You give targets, and those targets will be achieved accordingly so that there is increased liaison between each of the group members. And that is how the leaders will always be able to perform. I think there are suggested activities there on each of those stages, and which, Doc, I think I would leave it that it can be shared by members accordingly. So those suggested activities for each of those groups you can do, and incorporate them into yourselves. Thank you very much. Yeah, I think we have done well. We will share this so that you can try to do the activities and see whether it's possible to build your knowledge on teamwork. Very important. So Kutwa is going to help us on the issue of, on the matter of questions and answer. Again, as I said, we need to give leadership a real focus. We have a comprehensive 16-module leadership for capacity building on different areas, including the talents building and all that, including corporate governance, so that people can build their knowledge. We'll be offering that course, I think, sometimes towards the end of the year. So just keep on watching, and you can have a comprehensive activity base. It's both physical and virtual. Thank you very much, Kutwa. You can come. Yeah. You come here, I think. Yeah.
So, am I audible? Okay. Thank you so much, Dr. Okeo and Professor Nguka, for taking us through the third workshop on nutrition leadership in practice, that is emotional intelligence and teamwork. And from what I'm checking through the chat box, there are no major questions, but basically what participants are commending on the importance of emotional intelligence and teamwork within the leadership framework of nutrition. But then there are three key areas which I would want to raise from members in the chat box, which you can help address. So the first one is from Lina Brock. She says, emotional intelligence is what most leaders lack. They are having a new saying, you can never outshine the leader. Yet clearly, you can see how their poor leadership skills are hurting the nutritionist under them. So I don't know if you can address that.
Allow me to bring in the African Nutritional Leadership Program. When we were in South Africa, sometimes in 2015, we realized that you lead from where you are. Each one of us is a leader in their perspective. And the role of leadership is at all levels. There is an aspect of leadership and management. Now, my comment is, even from yourself, the way you see that poor leadership, it is also your role to make sure that that leadership that has said that you can never be better than your leader, you make them, or you take leadership in ensuring that they embrace the good leadership through dialogue. And we have provided a lot of skills here, just by ensuring that they open up to be able to accept the concept of teamwork in that provision. So I would recommend that you take yourself, who has seen that gap, because we said in leadership, usually it is teamwork. And that teamwork takes cognizance of everyone's responsibility in a team. Now that you have recognized that the leader in the nutrition is not able to lead effectively and efficiently, you can pick a role using the skills that we provided here to be able to bring them over, which sometimes people say is not easy, but I've seen over a period of time, because even the position that where those individuals are, they are not there permanently. There are times that will come, and at any given point, the institution will still need to move on. There is nobody who is permanent in the position. So take up that responsibility and bring the leader on board and communicate effectively and efficiently, which was one of the skills, and give direction on how you want that leader to lead you. I hope we are getting each other. Yeah. There's a quote from there. Oh, yes. Can we run for Cesare? Run for Cesare.
There are actually two. There was this one first. Yes, there was this one. There was this first one. This one. Okay. And another one that was just.
Can we read it from my eyes? Okay, very bad.
Okay, thank you, Prof, for handling that. Then there was another concern from Dr. Cheserek. I think I'll take two of the same. She's asking, receiving feedback is great. The main challenge is how to handle and respond negative review of feedback, which requires practice. Then the second concern on that from her is that a team player versus being taken advantage of at work. Please comment on this.
How did you know that you're being taken advantage of? Team player or being taken advantage of? You know, once you become a team player, the feeling of being taken advantage of may not even be there, because it is for the overall development of team members. And we've talked about motivating team members. You can bring them on board. You don't do the task simply because you want to shine. You are doing the work because you want the group to perform. So in such a case, you actually bring everybody on board to have your skill. Because one of the key things that we realize make people not to perform is the feeling of incompetence. So give them that skill which you have so that they can do that work together with you, and even when you are not there. Yeah. Sometimes you can be, yeah. Sometimes you may be taken advantage of. You may be a team player, and you have a feeling of being taken advantage of. The moment it occurs in your mind that your people are taking advantage, or the leader is taking advantage of you or other team members, then you cease to become a team player. Correct. And also, when you are doing, when you are a team member, you must be diligent, which means that you must be part of the team with a goal on focus. And so it must be delightsome participation. Correct. In such a case, it overrides the feeling that you're taken advantage of. So you become a member of the team because you are happy with the achievements. You might have done more than the rest, but you're still a team member, because in theory,
in a society where we have 100% people or 100 individual, equivalent to 100%, for example, only 5% make things move. But you need team members to be part of the process. So some have to do more work. But if you have that feeling, then cease not to be a team member, you can take the back seat.
Yeah. Yeah. I think you said it, and I will not even add more. Basically, that feeling in itself is an indication that you're now no longer going to become a team member. You are displaying the characteristics of individualism rather than team. The second question was? Just on the...
The second question was more like a comment, which I think you can shed more light. She's saying, receiving feedback is great. The main challenge is how to handle and respond negative review or feedback.
Yes. Though, feedback is feedback, negative or positive. And in fact, they say for very emotionally intelligent leaders, the negative feedback is actually one of the best which you use to actually give direction. You remember, even in group formation, we said it reaches a point when there can be complacence, when they reach a point when they have harmonized so much that they even become a threat to the output. At that point, you will need to introduce a new opinion to pollinate or bring in new ideas. So negative feedback are not fairly bad. And using the emotional intelligence skills, don't treat them as enemies in leadership. Sometimes I know during leadership, where individuals who are in position of leadership, when they see contradiction or when they fear or they feel that an individual has taken a contrary opinion, then sometimes it is picked as a dissenting voice, and therefore they work mechanism to strip them apart or induce punishment to such individuals. In reality, those are the guys who are actually making you. Those are the guys who continuously put you on toes as a leader to be able to provide, rational leadership or think differently, are the guys who are actually making you grow. And those negative feedback should be received with happiness, and even calling them now to say, can we now give us the best way to go through it? Let them take up the responsibility. At that point, if it was somebody who was just talking, they will run away. But if it was somebody who was ready to pick up responsibility, that is the time they will now prove to you that they can be able to deliver. And then it becomes a team success. So learn to accept the negative feedback. Do not be carried away by positive feedback. Sometimes positive feedback can carry you away. So always be balanced and get emotional intelligence to guide you in the process of receiving both positive and negative feedback. Okay.
Well, okay. We can handle that.
Yes, thank you, Professor Nguka, for addressing that. Then there's just one question on emotional intelligence framework asked by Harriet Mwendwa. She says that question on who am I has disturbed and stressed up seriously. Please help me with resources to answer it.
I will do so after this. Just take the email and then we'll forward. Okay. So that she can get the resources. Now, there is one thing about handling negative feedback, and I think handling negative feedback is a pointer to success. If you don't know how to handle negative feedback, then you cannot be a successful leader. For example, if your intention is to do well, and somebody all of a sudden comes from nowhere and say what you're intending to do is not good, then you must accept that that is a positive. You turn it from negative to positive feedback. So negative feedback should be turned to positive feedback for you to be a successful leader. Let me give an example. Right now in Kenya, we know that there has been the problem of the debate surrounding genetically modified food, and I think Prof is here for the same. And in our conference, we have also a team that would want to discuss that from the scientific perspective. Now, one of our friends and partners in the whole exercise wrote to us before when it was circulated and said, you know, you must be aware, CEO, that there was a court ruling that is from our friends Kunad, I think Mumina is here, and that was Secretary General. There's a court ruling that barred people from implementing GMO or even discussing the matter. This would be contempt of court. And if you continue, we are going to stop it. And when I received it, I was very happy that at least it has excited someone to talk about it. So he said, okay, I think what my friend wants is a reply. So one of my staff who brought it, I said, don't worry. She was already shaking. He said, don't worry. This is a very good indication of success. So let me reply the letter. And we said, we are aware of the court case. You have educated us enough also on this. And we know that what we are intending is purely for scientific discussion. So if we discuss and find out the position, the real position of GMO, then you will be educating 1,000 of Kenyans. The intention is not to accept GMO in the country, but to discuss GMO as an area of science, because we all go to school and we study science. So when we send it back, you wrote back, this is the kind of feedback I was looking for. This is, I'm now okay. So then after that is success. So when somebody gives you a negative feedback, don't take offense, because behind the negative feedback, there is success. You cannot reach the honey if you don't struggle with the bees. Thank you. I think we end there. There's no question? Comment. Okay. So thank you very much for staying on for the workshops. They were very interesting, the 3 categories. We now want to move to the next stage, which will start in a short while. Meanwhile, we want to break up. We are going to start the official opening of the conference. And we will allow some of us to also change. You know how you start matters. If you start lazily, then your processes will be lazy. But if you start strong, then you can kickstart with strength. And so we can have a break. The program is made in such a way that we will have our tea immediately after you have we have had a short time break, maybe about 15 minutes. We can come back and we have our cocktail tea there, mocktail there. It's not alcoholic, it's non-alcoholic, and with some bites. And after that, we'll settle down and we will have the opening session where we will take you through the program for the entire period from tomorrow. And then after that, we will cut our GND cake and then we disperse. So we can break a bit. 15 minutes is enough. We change. You can make some calls. Then we can come and sit this at the end, because the other end is where we will be taking our tea. So we can always come and sit this end. We'll arrange it, but then we'll take our tea from the other side. We want you to give us a feedback on the setting, if you are okay with it also during the process, during the tea time. And then those online, please wait for the bigger moment, because what we are going to tell you starting from tomorrow, it will be very interesting to be part of this conference. Today was free. Tomorrow, the first part of the day, the morning session, including keynote, will also be free. Then after that, we will now lock it for those who paid to participate in the conference. So thank you very much. I can see Professor Mwoma, karibu sana. I know you have arrived, and Professor Konyole. These are great scientists in many areas. We expect to learn a lot from them. And Professor Nguka, thank you very much for the hard work. I know the last part I left for you. I always know that you are strong. Where I leave it for you, you'll pick it from there. And that was very great. So thank you very much, Kutwa and the other team members, Laura, and those who have been participating in the process, even those at the background. We wish you well within this short time. And when you come back elegant. Thank you. Yeah.
Mtakatifu na umungu alivua, kakubali kufunua kile kitabu, akatafuta aliyepotea, huyo ni kusuluhisha. Akatafuta aliyepotea, huyo ni niliyemsuluhisha. Nyaraka za mashitaka zilikuwa nyingi, Babiloni yote ikajua jina langu, ila baada ya kifo chake damu yake Yesu shinda hukumu. Ila baada ya kifo chake, damu yake Yesu ilishinda hukumu. Mtakatifu na umungu alikuwa, kakubali kufunua kile kitabu. Bwana wewe umeniita, nimekubali nitumike nyumbani mwako, nimekubali nimetoka kwa ajili yako, nimekubali nifanyike baraka kwa watu wako, nimekubali kwa kijiti cha moto uliniita, nikakubali ukasema nivue viatu vyangu na nikakubali, ukasema niongoze taifa lako, nikakubali niwatoe Misri kwa Farao, nikakubali mbele yako Yesu, umebeba nguvu yangu. That's why you are looking up Alisa, you ready? Niona kwangu wewe, unaleta kwangu ameniona, 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 kufunga kwangu ameniona, Kujibundi ila neema yako yanitosha. Nina cha kujisikia ila neema yako yanitosha. Sina cha kujigamba, ila neema yako yanitosha. Sina cha kuwaonesha, ila neema yako yanitosha. Sina sina cha kujisifia, yanitosha. Sina cha kujigamba, Nijalie unyenyekevu. Jalie unyenyekevu, Bwana. Niondolee kiburi.
Because of the online people, can we have occupy the seats this side? Kindly, let's occupy the seats so that we can pray and start. And we may need to have we may need to have some of our guests, the keynote speakers, and of course guests from outside. We can sit this other side, even as we occupy this end. Professor Konyole, where is Professor Mwoma? Professor Mwoma? Please, let's sit here so that when we are set, we can set up. After this, we can still, the cake, those who are, this cake seems to be facing a wrong direction. It should be square. Yeah, good. Like that. Like that. You can have the ribbon down. Well, for the time being, then we can, immediately we finish, we can have it there. You can direct people to go the other side. Ladies and gentlemen, can we come closest so that, Martin, can you organize with the staff, they come, and also any other expert down there. The staff who are expertise, they should come, even those who are presenting their papers. We can pray. We'll signal you for the online. Are we online still? Okay. Hello, we are waiting, Pinya. This side is not occupied. Some of us can come this side. Kevin, tell them to come this side. Then some can also remain so that we balance. I was just trying to occupy the space so that we can balance this. Some people can be here, Kenya, this side, and tell your staff also. They can come this side. Everybody is getting involved, including those who are down there. This is just a small ceremony, so can we do that? Anthony, is there anybody down there? Pew. He's telling them. Okay. We want to pray. So let's pray first. After prayer, we will do the national anthem, isn't it? You are set. And the East African. And then after that, we can start. I've offered to pray. We don't pray with the caps. Okay, we don't pray with the caps. Good afternoon and good evening. You know, we have a strong touch with the Nigerians, so you don't need to worry because of our collaboration. So when you see the Oga test, some of them are gifts. So you don't leave your gifts in the kitchen, in the house. You carry them. So shall we bow our heads and pray? Let's pray. Those online also, you can join us. Almighty and everlasting Father, the greater I am, the greater terrible God, we thank you this evening and tonight. We thank you because you are a great God. We bless your holy name because you are a God of standards and a God of all impossibilities. We know that you are in charge of this country, the good country, Kenya. We pray for our president, His Excellency, Dr. William Samoei Ruto, that you give him guidance for good leadership. We pray for our leader of opposition, Right Honorable Raila, and all the leaders around them. We pray for all the executives, the cabinet secretaries, and we pray also for the principal secretaries that are working with them, especially our own in the Ministry of Health. We pray for the members of parliament and those representing us in one way or another. We pray for all the CEOs and all the workers and the workforce in the health sector. Now we are here again. Our conference is yet to begin now. We know that it is you who purposed that at this particular point in time, we shall be gathered again all through from today to Thursday to discuss matters of One Health agenda with a nutrition lens. Now we are praying that you give us the spirit of divine guidance, the spirit of excellence, the spirit of deep insight. And also we are asking that you put the spirit of utterance and for our speakers and also journey mercies for those who are on the way. Now for our professionals, we always pray that you take good care of them. And we are praying that one of these days, this profession shall be a flag on top of the mountain. We are also praying for our partners who have been together with us in this, our various regulatory authority CEOs who have also expressed their interest to be part of this process. And we are praying for our fraternity of nutrition, now our council, the secretariat here at KNDI, Artery Board of Directors and Management, and also we are praying for our professionals who are already presenting the conference. Now, for those who have come from outside the country, we bless their country. We pray all this, Father. We know that we are trusting in the name of God, the Father, God the Son, and God the Holy Spirit. Amen. Hallelujah. That is what pastors do. The other side of me is pastor. So I've exercised that duty appropriately. May I take this opportunity to ask Professor Nguka, with all due respect, to come and lead us for the both anthems, the national anthem and the East African anthem.
Thank you very much, Dr. K, for that very wonderful prayer. We have a direct connection with the heavens now. So we want to start this process with the national anthem, then the East African anthem. Let's start. May we please stand? East Africa. Thank you very much. With that, let's resume our seats. So we are going to start the next step, where we are going to go through a summary of what we will have in the next 3 days. And that process will be started by none other than the CEO. So come and, well, Dr. K, get your part.
Can you extend your hand to your neighbor as a sign of respect and love? Hallelujah. We in this country was founded on love. That is love for God. If you look at our national anthem and you review it critically with a tooth comb, you'll notice that the blessings of the Lord was covering this country, Kenya. And of course, that is not far from the East African anthem. If at all we were to obey God according to the instructions that came by national anthem, we'd be having the most excellent country. And you know very well, this is what we are all fighting for. The element of patriotism, very important in all aspects, including education sector, health sector, social services. And we know that this is not only there, even when it comes to governance, we have to be candid with the matters of accountability. And in 2007, the parliament then gave the nutritionists and dietitians an act which is one of its kind. We do not have that kind of such an act anywhere in the world. And this act was meant to self-regulate the profession of nutrition and dietetics. So if you read through the functions of the act, which is found under section 6, it talks about 11 functions. And from function number 1 up to number 4, they are purely regulatory functions. Then we have from number 5 onwards, that is E onwards, there are service-oriented functions. Now, there is no way you can do both regulation and service, because then it leads to conflict of interest. So sometimes back in the past council, we thought wise to interpret the act and give it 2 arms where we could get a managing partner, which we now call the ATRI programs. It started in Busia, in Agenga. We closed it there. and we brought it to KNDI. This wing is dealing purely with service-oriented areas. And that is where we are talking about research and innovation as one of the pillars. And that pillar was started by the GND, Journal of Nutrition and Dietetics, as a startup. Now, this GND came in 2018 by proxy, and now it has gone 4 years. And this is the host of conferences and research platforms where we share or disseminate our data as professionals, and we also welcome other professionals that with similar interest. So today we are on the 4th international conference, and we want to start it in a style. I always tell people when I am preaching in churches that don't ever try to look that you are poor. Somebody once asked me, do we have monkeys in Africa? And are human beings monkeys? That thing is real. It's a real question that comes. Some people think that Africans are monkeys. And we have great scientists, great educators, great president, great Gen Zs. We have everything great, even great pastors, like some of us. And we want to demonstrate to Africa that KNDI is one of its kind. We are working beyond Kenyan boundary. That's why our vision, if you look at it, it says we are a regulatory authority on matters of nutrition and dietetics recognized internationally. And we have our Rwandan delegate from the Rwandan Nutrition Society. We have hosted Rwanda twice. The chair of Allied Health Science Council, I think, and also now the president of Rwanda Nutrition Society. And now we have a delegate that they have sent. We also have been visited by Uganda Dietetics Association. And of course, Tanzania was expressing interest. We have registered 2 from Uganda, I think, and some from Kenya, from Tanzania are looking for our registration as professionals. So we are beyond Kenyan boundary. Now we want to encourage activities of nutrition, not only in practice, but also in research and innovation. When I was in Maseno University, I think in 2014, I was the youngest senator. Then one of the things that I embraced most was writing in research and publications. And at some point, I remember when I went to look for senior lecturer, I was told that, where do you want to go? You're still young, and what is your problem? I said, I have published, and some of you seated there in Senate have not published. Yet they are senior lecturers. But then when I left, I said, I cannot stop research. So the first thing was to introduce the GND. And the second thing now is to make it an implementable framework. So we have ATRI, which is going to do community outreach. You saw us with Machakos County some 3 months ago. It was marvelous. We had to attend to 1,500 members of public for medical services. And it was very successful. We are now starting business incubation by onboarding with the professionals. We have research. And now research here is the Journal of Nutrition and Dietetics. We're in the 4th series, indexed and cross-referenced. Now we have conference series. And these conferences are not predator conferences. They are serious peer-reviewed paperwork. We have about 15 reviewers, and we have editorial board for the journal. And that journal is what has brought us here today. And we said, we want to celebrate the opening with in a style. And that style is cutting a cake. Now, you don't cut cake anyhow. Cake you cut, and you don't take a prototype of wine anyhow. You take it by a toast. So at the end of this, we'll be cutting our cake to jumpstart the science. We have started with a workshop today, and you can see it was successful and perfect with good knowledge and good participation. So I want us to go through what is there for us. And before I forget, I want to say that on Thursday of this week, when we are closing, our meeting shall be closed by our PS for State Department for Public Health. That is Madam Mary Mudhoni. She has already confirmed just a few minutes ago. She is very much pleased with KNDI. Now, in KNDI, we work inside the government from outside. I know you may not know what that means, that we do not get money from government, but we use the little money we get to do government activities, including policy. That has come out very well in the Kenya at 60 booklet I shared with Professor Nguka, which is hosted by none other than His Excellency the President. And we know how to interpret our law. So you are strong. Now that strength must be displayed in science. So today our science is bringing us to the 4th International Conference in Nutrition and Dietetics, held at KNDI Headquarters, Mlolongo, which means we are the only national government function that is outside Nairobi. And that is also called innovation, because you cannot be all in the city center. So we have this conference is focusing on One Health, and we are giving it a nutrition lens. Every other professional body can have their own approaches in One Health. So I'll take us through the background, and then I will invite Professor Nguka to give us what is there for us from tomorrow going onwards. Let's see. Now, in this conference of One Health, the theme is One Health, food, animals, plants, and humans. The conference is running between 12th to 16th. We want to believe 16th we will have a field visit for some of the farms accompanying Bear, who wanted us to be part of their trip. So as many of you as would want to join, there's free transport, I want to believe so. And Kenya, you can consult with Kenya. The sub-themes, we have microbiota and early stage malnutrition in the context of One Health. We have climatic change and food systems value chain. We have multi-sectoral and multidisciplinary collaborations. We have zoonotic diseases, food and humans. We have food processing and commercialization and health. And then we have One Health, food systems and anthropology. The specific focus is on culture and religious doctrines. Then we have general health interventions. Now, the good thing with us is we are talking about science. We are not only on practice, but we talk about science from research, and we are translating it into practice. Now, when we talk about science, we must demonstrate original research from the fields where we study. And we don't want to believe that we are not studying. We are studying. We are scientists. And that emphasis is very, very important, because nutrition came from a background where majority thought it was cooking. Nutrition is science. It's science from field to fork, and also science within the hospital settings. So One Health covers the entire spectrum of disease control. And here we are talking about prevention, detection, readiness, response, and management. It connects humans, animals, and environment to global health security. The globe faces an unprecedented challenge in the decades ahead of 2050. As many of you as will reach 2050, you carry your hands, producing 60% more food than is currently produced to feed estimated 9 billion people. One Health initiative is essential in addressing the challenge of producing more food because it recognizes the interdependence between human health, animal health, and environment. You cannot talk about human health if you don't recognize animal health. One Health can help identify and implement sustainable agriculture practices, reduce the negative impacts of climate change on food production, and promote food safety and security for a growing population. It also aims to optimize and sustain a balance that is health, people, animal, and ecosystem through integrated and unifying approach. One Health is not understood and One Health is not implemented in the Ministry of Health. That is our voice. We are saying that there's no way One Health is implemented in the under the Ministry of Agriculture, and we are just quiet in the Ministry of Health. Healthcare systems around the world are burdened by zoonotic diseases, particularly in developing countries, and many studies say out of 1,400 infectious diseases that affect people, 60% have zoonotic origins, meaning they can be transmitted between animals and humans. You cannot forget the COVID case. One Health, again, acknowledge the interdependence between human health, domestic and wild animals, plants, and the larger environment, including ecosystem. And so collaboration across sectors and discipline is essential to protect health and address health challenges like infectious diseases, antimicrobial resistance, food safety, and promote health and integrity of ecosystem. And we are saying additionally, child malnutrition is a pressing global health issue that affects millions of children worldwide. It can lead to stunted growth, cognitive impairment, and increased infectious susceptibility. So infections come in malnutrition. Recent studies we know that focus on health have shown issues of gut microbiota plays a crucial role in nutrient absorption, immune functions, overall health. Now, disruptions in the gut microbiota due to factors like infections, diet, genetic variables. Not only that, even antibiotics is of concern for malnutrition. Understanding the complex interaction between the host and the gut microbiota can provide valuable insight for developing therapeutic approaches and intervention. Recently, you saw we were endorsing Brookside products, particularly the probiotics. We did so just to ensure that we take back important bacteria when they have been removed by antibiotics. And that is an area that we as the nutritionists can battle with. As the medical doctors provide antibiotics, we balance that by providing microbiota or probiotics or even prebiotics. So what are we saying in this conference today? Implementing One Health approach faces challenges like institutional barriers, limiting funding. We know that One Health is spearheaded by Ministry of Agriculture and research associates of Ministry of Agriculture like Hillary, but we do not have it in the Ministry of Health. The focus for the Ministry of Health is curative and primary healthcare, but they do forget about the component of zoonotic diseases as well as things to do with climatic change. So this should be a bigger brother that must be tackled, with a pillar being the Ministry of Health, because it is health. And so we want to bring it back through our first discussion, and we shall escalate it to our partners in other medical field. So KNDI is in the front line towards ensuring this is met. This conference will provide such a platform as a start. In light of this, the Kenya Nutritionists and Dietitians Institute, in collaboration with partners across Africa, and of course our professional, will discuss One Health, food, animal, plants, and human. What I may say, we may not be straight to the point because of the nature of researches we do, but as many as would fall under health, we accepted them. This is where to be corrected. This is where to be told your research is bogus, do a better research. This is where you will grow up as a scientist. So the objective, the purpose is to bring together the community of practitioners in nutrition and dietetics for knowledge sharing and discussions as part of scaling up nutrition agenda. When you look at the scaling up nutrition agenda in the country, it is running, but it is dormant. Why? We do not see the impact, and those who are in it are only looking for funding and pocketing. Funding and pocketing. We do not see impact of scaling up nutrition. That is a fact. And you'll see people are going for grabs, but we don't see sense. So with this, we have 6 objectives, and we also have 3 outputs. So by the end of this conference, we want to see a collection of scientific research shared from different sub-themes, and we'll pick those that are relevant for further research and policy. We also want to have manuscripts in our Journal of Nutrition and Dietetics, and all these papers, the good ones that have been reviewed, will appear as reviewed in the peer-reviewed journal, the Journal of Nutrition and Dietetics. Now, we have also to come up with evidence-based policy briefs from these research findings and a common voice to Madam PS so that he can understand the concept. The problem we have in country is that sometimes when we have leadership, they come in when they are not knowledgeable in the subject area. They depend on us. Some of us mislead them by telling them that health is only for a doctor, a nurse, and a clinical officer. We have many other cadres that can lead health towards the good side. So I would want to officially welcome Professor Nguka to tell us what we have to discuss throughout. And then after that, we can get to the ceremony of cutting the cake. And we welcome you very much to KNDI. In KNDI, we love science and we love people also. So when you come here, prayer is our strength. So when you find that we are praying every lunchtime, you can join us even tomorrow. We shall be praying down there at the boardroom, and you can join. That is our strength. That is the strength of our nation. And just remember, this government was founded on God. And we are not lying. So if that's the case, our own president prays, isn't it? So you and I must also pray. Thank you very much, Professor Nguka. You can take us through what we have. And if you... Now I would want to declare this as a conference director. By the way, Prof called me the CEO, but I'm the conference director as a scientist now, not as a CEO. But now, as in my capacity as a CEO of KNDI, I declare it officially open.
Thank you very much. So after that conference brief, the purpose and objective of the conference, I would like to take you through a summary of what we will have from tomorrow all the way to Thursday. As was already alluded to, this conference will have keynote speakers, and the keynote speakers have been placed in thematic areas, which I will take you through quickly. So our first keynote speaker tomorrow will be Dr. David Okeo, who will take us through food choice dilemma, a review of animal food sources, risk, plant-based diet, and policy solutions. So tomorrow, I hope that has been displayed. Can we display? Okay. Okay, so then after which we'll have the second keynote speaker. And the second keynote speaker will be Professor George Grant. Can we get Professor George Grant up? Professor George Grant will take us through a topic called preventing and possibly reversing dementia and Alzheimer's using thermotherapy and vibroacoustic therapy in 12 subjects over 3 months. Then after that, we will move to the next keynote speaker, Dr. Beatrice Kiage. She will be able to give us a keynote on agroecology role in mitigating climate impact on food, nutrition, and health. Okay. From there, we'll have the next keynote speaker. That is Professor George Ooko Abong, who will take us through food safety and nutrition nexus, impact in human health. Professor Abong is from the University of Nairobi. Then the next, and this will be on 15th, will be yours truly, Professor Nguka, who will take you through tracing the missing link in the implementation of One Health approach in Kenya. The big question is, has Kenya implemented the concept of One Health approach within its healthcare systems? Dr. K was trying to preempt it, but he has kept it. We will answer that question on the 15th. And then our last but not least keynote presenter is Professor Silvanus Ochieng Konyole. Those of you who do not know the Ochieng is there. He will give us a presentation on micronutrient studies, dynamics in sub-Saharan Africa, research gaps, challenges, and implication for policy and programs. And after that, we will move to the papers. Each of those have been strategically arranged, and the conference will run, as we said, from tomorrow, with papers in between all the way to the 15th. And the first group will have the conference panel discussion with a topic on geopolitics and food systems. And that will be spearheaded by the host, Dr. David O'Kay, who is the chief editor of Journal of Nutrition and Dietetics based in Nairobi. And the panelists that we are going to have will be Dr. Paul Eme, based in New Zealand, Dr. Elizabeth Kimani, and consultant Ridi Bushani from Congo. Then our next topic of the panelist will be on indigenous knowledge, food systems. This again will be hosted by Dr. David O'Kay, the chief editor of JND. And the panelists will be as follows: Professor Mary Abokusa of JKUAT, Dr. Anne Aswani, Asinde Muliro University of Science and Technology, Dr. Mary Oyunga, Kalaro, or former Kalaro, Dr. Beatrice Ekesa, and Dr. Constance Uwor Gewa. So those will be the panelists. Oh, Dr. Ekesa is from Bioversity, Kenya, but Bioversity, Uganda. Thank you very much. Then we will go to the next theme, which is basically function of foods for health and well-being. Again, the host, as usual, will be the chief editor, Dr. David Okeo. Now, here at Function of Foods, the panelist will be Professor Nguka Gordon, Professor Anel Grese from South Africa, from University of Nelson Mandela, Dr. Beatrice Kiage from JKUAT, and then Professor Asenat Sigot from Masinde Muliro University. These are some of our mothers of nutrition, for those who don't know her. And after which, we will move to the pre-conference workshop. Which will be covered as follows. Again, the process will be spearheaded by Dr. David Okeo. Yeah. Or it will be hosted by? Okay. Yeah. Then it is not rhyming with this. Yes. That is on nutritional pharma navigating. What I have here is not running. Okay. Okay. So we'll have a panel discussion, Navigating Sustainable Food System, by Bayer Pharmaceuticals, who will join us here. And it will be Bayer. And the chief host will be Kelly Briston. I think she's from Bayer. And will be, yes, will be joining us on that. Then the next. So on the panelists there, we have Dr. Kansas Kanangire. Then we have Lena Tripat and Professor John Mwoma. Professor John Mwoma is here from Masinde Muliro University of Science and Technology. So he will be spearheading that panel discussion. Okay. After which, sorry, let me just move to the next. Sorry, I'm relying on that because I can't be able to see that here. We'll move to day 2. Can we display that? Day 2. It is 14th. Tomorrow will be 13th. So on 14th, on the morning session, we will have Dr. Agatha chairing that session, Dr. Agatha Christian. The rapporteur will be Kiome, and the chief host will be Dr. David Okeo. There will be panel discussion on the function of foods for health and well-being. The panelists I think we had already talked about, and the keynote address for that day will be Dr. Beatrice Kiage, as had already been put. This will fall under the sub-theme of climatic change, food systems, value chain. We'll have at 1 o'clock to 1:15, we'll have KNSA. KNSA is the Kenya Nutrition and Dietetics Students Association national chapter. That's various chapters. They will do that presentation. In the afternoon session, the chairperson is going to be Dr. Maureen Cheserek from Egerton University. The rapporteur will be Laura Cheng and Dr. Terry Mugambi. Terry Mugambi, you must be a doctor now. The keynote address will be by George Grant, as had already been presented, and the title had already talked about. This will be under the sub-theme of micronutrients, food processing, commercialization, and health. The chief host will be Dr. David Omondi Okeyo for the panel discussion. And as we said, it will be focusing on geopolitical wars and sustaining food systems. That will be at about 5:15 to 6. On day three, which is on the 15th, and that is Thursday, will be our last day. The chairperson for that day will be Professor Silvanus Konyole, Professor of Food Science and Nutrition, Masinde Muliro University of Science and Technology. The rapporteur will be Martin Kiome and Elizabeth Mboya. The chief host will be Dr. David Okeyo. Panel discussion 4 will come in under the title of Indigenous Knowledge of Food Systems. And the keynote address here will be Professor Nguka under the title that I'd already talked about. And the sub-theme will be General Health Intervention in One Health. The afternoon session will be chaired by Professor George Abong Ooko. The rapporteur will be Terry Mugambi and Laura Acheng. The keynote address for this day will be Professor Silvanus Konyole under the title that I'd already talked about. And in the sub-theme will be the multi-sectoral, multidisciplinary collaboration. And that will mark the end of our presentations for the conference. And mine is to wish you very fruitful deliberations. Enjoy this mouth-watering 3-day interactions with science and science proper. So mnajua venye science inafanyika hapa KNDI. Very serious. Thank you very much and may God bless you.
Thank you very much, Prof. And thank you everyone for attending and for appearing. For the opening ceremony, we did not have a band. We intended to have a band to sing for us. But unfortunately, Anthony did not bring a band. You know, jubilation and joy must be accompanied by timbrel and harps and dance. Of course, we have our voices, so we have no problem. I would want to invite our IT, Gordon, first, to launch the app for the conference. We will not give you booklets, but we will have an app where you can access all the materials, including the abstract. So Gordon, you can come and show us how to access that. And after that, we get to the last part, which is cake. And this cake will be spearheaded by this team that is around here and those who have invited. So they should get prepared. If they don't know how to lead the process of cake cutting, they can ask in secret from those who have done it, from the congregation.
Okay, thank you, Mr. Chair. Okay, I want to launch the app for 5th International Conference. The app is not live yet, so the link for app will be shared through WhatsApp. Madam Kenya will do that. I will share with her the link, the Google Drive link. You will download the app, then install it from there. If you face any difficulty, you can screenshot the challenges you face when installing the app, then we will help you further. The app for 3rd conference is live. You can also install that from Google Play Store. You can just search JND Conference 3rd series, then you will get the app from the Google Play Store. I think that's all.
That's interesting. You know, one of the skills that Those who did science of physics, mathematics, IT, botany, is the science of soft skills, how to make people laugh, because they just come and say what they want. It doesn't matter which grammar. Then they sit down. That is what we have seen. That is when we had one of the VC, the vice chancellor, as a physicist, he kept on saying physics is everything, and he never listened to anybody. So his emotional intelligence was very low. It was very zero. They would say priority is physics, and not just physics, but solar physics, nothing else. So those things of CG, English, grammar, IT, nutrition, they don't matter. Soft skill, we will be training them on soft skill, how to make people happy. Now it's cake cutting. Let's say cake cutting. Cake cutting. You don't want to say cake cutting. You don't eat this cake if you did not say cake cutting, because this is a hall beautified. So it is not mortuary. So you must say cake cutting. And I want Kenya to come in and tell us what to do next. And then after that, we can have those, the ribbon group. You can tell us what to do.
Okay, thank you, everybody. For those who are here, you'll get to enjoy a very rich fruit cake. For those who are online, pole pole tu pia mkiwa online mnameza mate kidogo kidogo. So I want the scientific team, and we are very well represented by Professor Moma, we have Professor Konyole, we have Professor Nguka, and also have Dr. Okeo here, who I also believe is a professor. Actually, he's a professor because the amount of work he has published and the work he has done, I think is big. I hope I will not get into trouble with the VCs in this country of Kenya. So the first thing we want to do is to cut the ribbon. So we will request the team led by our conference director to please walk to where the ribbon is so that we can then cut the ribbon. I think after maybe just a little bit before we tie the ribbon, we can have the scientific team go to the other side. Then they cut the ribbon as they enter. So just open the ribbon a little bit. Our scientific team heads over to the other side. And I'm really excited this time around. We have county representative. We have 2 county nutritionists who have come for this conference. So that's a big, big deal. So is there anybody who comes from that side of the country where you do because if there is anybody, I want people to go when we cut that ribbon. Oh yes, when we cut that ribbon, I want to hear the and the way the men do it, you can also do it. So I think in 1. So when it is cut, I want to hear so 1, 2. Okay. The ladies, are you ready? Are you ready, ladies? Are you very, very late? Oh, yes. So 1, 2, 3.
Okay, you can continue.
So we can now proceed to the cake. We can now proceed to the cake. We can now proceed to the cake, and I'll just give our conference director an opportunity maybe to just say something as he officially opens.
Praise the Lord. Praise the Lord again. You know, if you don't praise God, what gets into the stomach is problematic. Are we together? When they were just about to eat, they were told there's death in the pot. So don't try it. We are not going to have death in the pot. What we have is a healthy, one health, food, plant, animal cake. Are we together? And it is orange in color with green. We just missed the Journal of Nutrition, but when the PS comes, we will have another sharing with the PS, but that will be purely the Journal of Nutrition and Dietetics. Everybody has a portion here. Say amen. And as you eat it, let it enter your stomach. It shall not turn to acid. It shall not ferment. It shall be for good health. We pray over it. And before we cut it, we celebrate artery team who have managed to bring us the cake. And we also celebrate the KNDI staff. We have very interesting staff in organization of events. We don't need to hire. If you want them, we can donate. And even the environment, you can see, we have not hired. It is typically here every day. We are not hiring. And that is for you, and you are all welcome at KNDI. So we will be cutting this cake, and I want to take it back. You give us direction, and then we share the cake, and then we have a closing prayer. Our county nutrition representative. The cake looks like you. So
The first county nutrition is to register and push a team.
She's the one she's cutting. Yeah, but you can put for her. Yes.
Good evening. We are going to cut the cake and celebrate this event today. Thank you.
So let's take the name. So you okay. So we have the privilege and can commentate. You know, one of the things I do also is master of ceremonies. I've appointed myself. Now, you know, county is a government. And then we have the 48th. It is very, very much a privilege to have a county represented. And she's going to represent all the counties. And the good news is that she's a nutritionist. And she has come in the company of a nurse. We are talking about integrated approach in healthcare. And we are happy to have her to be the one cutting the cake. The cake knife has a ribbon tied to it, which is yellow. She's also putting on yellow. And all the things, the shamdo is yellow and gold. So everything is yellow. And Professor Moma is just beside as a bouncer with yellow. And so let us cut the cake, and we are going to sing it because cake is not just cut anyhow. Cake sio ugali. Isn't it? It's not ugali. Are we together? So we can sing for you kata, kata. Isn't it? Who is going to sing that? Kenya?
Aya. Psych. So, kata keki tukule sasa. Keki tukule sasa. Kata keki. Kata keki. Kata keki tukule sasa. Hiyo ni keki sio ugali. Hiyo ni keki sio ugali. Hiyo ni keki. Keki hiyo ni keki. Kata hiyo ni keki sio ugali. Naye daktari anameza mate. Naye daktari anameza mate.
CEO what?
So I think we are just going to cut the cake. Then we'll have our conference director have a piece, our conference chairperson, then our professors, and we're going to share the cake to everybody. Every single person will get a good, healthy slice of the One Health cake as we open this beautiful conference. Mr. Martin Kiome, we are asking you to assist us in popping the champagne.
Tumechafua meza na Martin ni wa kuchafua meza. Okay. You know, entry point, when you are celebrating, everything must be rattled. And noise is a factor. Yeah. In fact, any unorganized sound is defined as noise. And so Martin is ready to make for us noise with the things that matter in God's kingdom. This is not wine. Here we don't drink. Martin came from drinking. Now he's the best person. He's the best person to show us how this thing is opened and to pop it up. Anthony, you look like you are part of the process. Pick another one. We are popping and let Martin follow Martin's leg. Martin, Anthony, you pick one. Okay. You know, if you ever did anything in nutrition and home science or hotel management, you did this. You tested wine as part of testing. So, yeah. Move here. Anthony, quickly. We have Anthony is coming. Make sure you shake it properly. I don't know what shaking is in Kiswahili, but yeah, kutingiza. Martin, tingiza properly. And, you know, be careful, Mugenya, because Martin is sometimes unreasonable. We thank God for everything. And you can celebrate, you can have your cake. So it's time for me to pick the cake. And of course, our mommy here, you can give our professors here. We want to celebrate them. You know, as we are in the practice, they are in the science. So they can take and we can toast and then we can eat, isn't it? And we thank you very much for appearing for the opening ceremony. We love you as KNDI. This is your place. For the professional, this is your building. And we are yet to build more and more. Thank you very much. Oh, this will be. Where is some doors? Please, it starts at 7:30 and the first keynote at 11. Don't miss, the first keynote is free for everybody, including those online, and the first session. Then after that, we lock it for those who paid to be part of the process. Tell your friends to join tomorrow. Ours is impact, so we want to see how many people we can reach with the knowledge of science. Then after that, other things. Thank you very much. Those online, please, just make sure that you pray and unameza the way you were told. This cake is very nice, and we love you. Next time you pass through KNDI, ask me for the cake, and I'll give it to you. Thank you.